fourth session. May I request Dr. Karunesh Ranjan for moderate the session, please.
Good morning to everyone. Welcome everyone to Chanakya Hotel for the Aarcon 2024. Firstly, I would like to invite on the stage the respected chairpersons, J. Chaudhary sir to come on the stage, Khurshid Alam sir to come on the stage, Dr. Mithilesh sir to come on the stage, and Sudhir sir to come on the stage. Now, I would like to invite our first speaker to deliver the speech, Dr. Raj Kiran Dudam.
Shall I go ahead or?
Welcome to Dr. Raj Kiran Dudam. His topic is approach of clinician to a patient of suspected RA.
Thank you very much, sir. Once again, I thank Dr. Amulya and Dr. Manish and entire Aarcon team for inviting me here to speak on this topic, clinician approach to a patient with suspected RA. So I'll begin with cases. So we have a 35-year-old female who came to our OPD with inflammatory polyarthritis involving hands, elbows and knees for a period of 6 months. So this is what we see. What else a rheumatologist sees beyond this? So that I will enlighten. So along with joints, as a rheumatologist, we see what else the patient is having. This patient is having alopecia, skin rash, skin pigmentation, her fingers are swollen, she is having Raynaud's, and she gives a history of shortness of breath for almost like maybe 15 to 20 days. That's what had brought that to the hospital. So this patient has puffy fingers, you can notice. So this is not just arthritis, this is arthritis plus symptoms, which is Dr. Bhojani was telling yesterday. So in this particular cases, apart from our routine tests, which I have discussed yesterday, we also try to do these investigations. So remember, if the patient is having arthritis plus symptoms, along with rheumatoid factor and anti-CCP, also get this ANA profile, CPK and HRCT based upon their clinical symptoms. This particular patient has a speckled positive ANA, her ANA profile is showing UNRNP and CPK is high, and which confirms a diagnosis of mixed connective tissue disease. So to summarize this patient, along with arthritis, she is having puffy fingers, Raynaud's, anemia, liver enzymes are elevated, CPK is high, and along with rheumatoid factor, because we have done ANA and other things, so we are able to conclude that it is mixed connective tissue disease. So whenever a clinician approaches or thinks of rheumatoid arthritis, think beyond joints. So what else is there in this particular patient? It's only the joint symptoms, or beyond the joints anything else is there? So now case 2, where the patient is having polyarthritis involving typical rheumatoid distribution. What is a rheumatologist seeing here beyond joints? Again, this patient has alopecia, skin rashes, distribution, fever, fatigue. Apart from this, this patient is also having mouth ulcers and she is unable to eat and she is having feet edema. So you can see the classical malarash of the patient and the palatal ulcer, which is very characteristic of SLE. So again, we did some special investigations. Here the pattern of ANA is different. We have homogeneous pattern, we have double stranded DNA positive, confirming it a diagnosis of SLE. So in when you are dealing with the connective tissue diseases, so think like whether this particular patient is having any major organ involvement or not, because beyond musculoskeletal and skin manifestation, does this patient is having any like renal involvement, hematological involvement or hepatic involvement or CNS involvement? This particular understanding of the patient is very, very important before initiating the treatment. So now coming to approach to arthritis. So first remember, all rheumatoid factor positives is not rheumatoid arthritis. How to diagnose rheumatoid arthritis? What are the criteria of rheumatoid arthritis? Already Dr. Bhojani has discussed yesterday. So first see whether this particular patient is having joint problem or not, whether it is arthritis or arthralgias. What is the pattern of arthritis, whether it is acute or chronic. Patient coming with 2 days of joint pain, rheumatoid factor positive, could not be rheumatoid arthritis. It could be a simple viral arthritis. So before making a diagnosis of rheumatoid arthritis in a patient suffering with inflammatory arthritis, look at the following patterns of arthritis, what that particular patient is going on, whether it is a symmetrical, bilateral, like inflammatory arthritis involving small and large joints, or whether it is an asymmetrical arthritis, like what we see in psoriatic arthritis, or whether it is an axial arthritis, like what Dr. Kavita has discussed yesterday, the pattern of arthritis in SPA, axial, peripheral, etc. Or whether it is a benign arthritis, not not much of inflammation, it's more of a degeneration, wear and tear, and joint pains. So as I said, look beyond joints, look for all these things. Sometimes you open up the box and see beyond joints, you might find a lot of new things there, and the diagnosis might eventually change. Once the diagnosis change, the entire natural course of the disease changes, the treatment patterns changes, the choice of drugs which we use change. So, like, look at the constitutional symptoms: skin and hair, mucous membranes, eyes, nail, hematological manifestations, cardiorespiratory, nervous system, and GI tract symptoms. And with this will bring you to another, this might take you to another diagnosis beyond rheumatoid arthritis. So whenever you look at the hands, you look at the pattern of arthritis, like typical swan neck deformities are seen in rheumatoid arthritis, dactylitis and DIP arthritis can be seen in psoriatic as well as osteoarthritis, and rheumatoid nodules and gout you already know. And don't miss the skin. Whenever any patient comes to you with joint pains, look beyond joints. As I said, carefully observe the skin. The pattern of rash, whether it is a malar rash or butterfly rash, typically seen in lupus or pepper salt pigmentation like what you have in scleroderma. Observe palatal ulcers, skin tightening in scleroderma, very bad alopecia in lupus, and facial puffiness can be a manifestation of nephritis in patients with lupus. And look for hidden areas of psoriasis in the scalp and feet and behind the ears. And so a patient coming with arthritis is also having a scleritis and having some chest symptoms. It may not be simple rheumatoid arthritis, could be vasculitis. The choice of our drug might change here. And especially somebody coming with a very deformed hands and no joint pain at all, but a lot of ulcers in the fingers. Think of Hansen's. So now, after excluding all these things, we have made a diagnosis of rheumatoid arthritis. So there are lots and lots of like drugs which are available to treat now for rheumatoid arthritis. There is evolution of therapies happening over a couple of decades. So the most important treatment paradigm in rheumatoid arthritis is symptom relief. Patient, when they comes to us, that they just want a symptom relief. So we need to aim at relieving the symptoms of this patient, and at the same time it's our responsibility not just to relieve the symptoms, also to prevent the joint damage, and also to see that this particular person doesn't develop any major organ manifestation subsequently. And whatever drugs we use, finally we have to achieve the clinical remission in this particular patient, and if we are unable to achieve remission, at least think of achieving low disease activity. So there are various guidelines to guide us how to pick up the drugs in this particular patient. We look at ACR, EULAR, APLAR, and our IRA guidelines. But again, these guidelines to some extent tell us what to be done. But we have a complex dynamics in our country, like where the economics of the patients, you want to choose biologic, you can't choose biologics because patient cannot afford. And this is one problem. The other major problem is patient has an affordability. But the issue is he doesn't want to pay money because they have joint pains, but I don't want to pay this much money for this particular problem. And most of the time, the suffering is from the women's side, the men has to pay. So, and this lots of complex issues which as a consultant we need to deal with. And the practice settings change, rural, urban keeps on changing. So the drugs which we choose might differ. And sometimes patients have reimbursements and institutional supplies. This also. So as a clinician, when we prescribe, we keep all these things in our mind. So as a rheumatologist, what are we doing? So what is a contemporary practice in treating rheumatoid arthritis? So as we discussed yesterday, we have an elaborative discussion. We have this list of drugs to treat rheumatoid arthritis patient. So how to start treatment once we make a diagnosis of RA? Just calculate the disease. So we have various like measuring scales to calculate the disease, but simply when you observe the patient, just look at how many joints are tender, how many joints are swollen, so and what is the extent of inflammatory markers which are raised like ESR, CRP, and you will get an idea whether this is a low disease activity or a moderate disease activity. In low disease activity, you can choose drugs like hydroxychloroquine and sulfasalazine, and the disease is moderate to high, think of methotrexate monotherapy and a course of short course steroids or biologics if you are unable to give steroids. So as I said yesterday, methotrexate is the preferred choice of drugs. So gradually you escalate and titrate according to the efficacy of methotrexate. And if methotrexate is not working, you think of another drug. Or if methotrexate is contraindicated, think of giving leflunomide or sulfasalazine. And steroids we use as a bridging therapy. Better if you use steroids as low as possible and as shorter duration as possible to reduce the side effects. So we start this therapy with methotrexate or bridging therapy of steroids and observe after 3 months, and if you are unable to get into the remission or if you are unable to achieve the remission, just try to escalate or add on the therapy, whether your combination of synthetic DMRs or you add biologics and targeted synthetic DMRs. Observe this patient, and every 3 months our goal is to bring down the disease activity and try to get the patient into remission. And similarly, if one biologic fails, we use another biologic. If targeted synthetic drug like tofacitinib fails, we think of adding a biologic. So we keep changing. It's more or less like an hypertension management or a diabetes management. The main goal is to bring down the disease burden. So once we have achieved, once our patient is doing well and we have treated them, so keep the patient in remission. Don't be hurry in reducing the drugs or de-escalating the therapy very, very quickly. If last visit a couple of months before patient is having a lot of problem and now they have come with a reasonable remission with inflammatory markers down and no active arthritis, don't immediately reduce the therapy. So maintain the patient in remission for a considerable amount of time. Most of the studies they show if the remission maintenance is longer, once you taper the therapy, the chances of relapses will be very, very less. So the minimum thing which needs to be done is to maintain the remission at least for a period of 6 months. Then you try to gradually reduce the dose. So there is a way to reduce the dose. If the patient is on methotrexate, sulfasalazine, hydroxychloroquine, try to take off sulfasalazine and maintain on methotrexate, hydroxychloroquine. If the patient is on methotrexate, not responded, you added tofacitinib or a biologic. The guidelines say to stop methotrexate because it has not worked eventually, and if you remove the biologics or JAK inhibitors, the patient disease might come back again. So there are a lot of combinations which we look into whenever we are tapering the drugs. So there are special situations like patient might be having a lung problem. If the patient is having ILD but very bad arthritis, still you can give methotrexate. If the arthritis is not very severe, you can choose an alternative therapy. Especially if the patient is having heart failure, avoid anti-TNF drugs. NASH, look at the liver. If there is no fibrosis or LFTs are normal, you can still give methotrexate. But if the liver is getting compromised, we need to choose another drugs. Subcutaneous nodules, methotrexate and tofacitinib are preferred drugs. And if the patient is having a very, very bad infection and got admitted in hospital in previous 1 year, better to avoid these high-end drugs like JAK inhibitors or biologics. Try to manage as much as possible with methotrexate alone. If the disease doesn't get controlled, you can take a risk, but try to avoid these drugs. Hepatitis B, always check these things before giving methotrexate or before going for biologics, and co-manage with hepatologist. And when there is a background lymphoma, if the choice of biologic preferable would be rituximab, and hypogamma is one thing which can happen on patients with rituximab. If there is no concomitant infections in the previous year, you can still go and give rituximabs. So apart from treating these patients with medicines, the most important thing is diet. So every patient comes and asks us at the end of our prescription, Doctor Sahab, kya khana hai? So this is also very, very important. The dynamics of diet we need to understand. We need to know what are all exactly the anti-inflammatory diet, and we need to put more emphasis on reducing the weight because the obesity has a very bad prognosis in rheumatoid arthritis. Simple things like regular exercises, keep the joints active, and reduce that diet, and basic exercises like yoga, tai chi, all these things will help. And apart from this, always counsel the family members also. Like these patients are not normal. Women might find difficult when she gets up in the morning to cook or make breakfast for the children. Support to the women from the husband and other family members is very, very important. These are very, very key aspects and very sensitive aspects which we, in our busy clinics, we don't discuss with the patients, and we need to tell them to give a sensitive touch to our treatment. So the take-home message is, once like a clinician approaches to the treatment of RA, before approaching, just question yourself, am I dealing only with RA or something else is there? Because like we need to see the patient as a whole. It's not just joints and bones and skin. We have to see that the patient do not develop any major organ complications in the future. So, like choice of JAK inhibitors or biologics should be thought of only when methotrexate is not working. So, as I said yesterday, methotrexate is the first drug of choice, and if methotrexate is not working, then only think of adding these drugs, especially in the present Indian context. Whenever you combine medications, you focus on efficacy, but at the same time also look at the toxicity and the side effects of those medicines whenever you are combining them. And low disease activity at least should be aimed if you are unable to achieve the remission. And most importantly, improve the adherence and compliance of the patient. Treatment medicines are available, but the most important aspect in treating a patient suffering with rheumatoid arthritis is talking to them. So this is what like which can surpass the every medical therapy. You just talk to them, make them understand that this is a chronic disease. You might have to live with it for a very, very long time. So we will give you the medication, but again, you have to fight it through. Family support is very, very essential. The other aspects of medical prescription are also very, very important, especially when we are dealing with this kind of diseases. So this is our hospital where we are completely dedicated to treat patients end-to-end for rheumatology problems. And with this, ladies and gentlemen, I thank you very much for your patient listening.
Thank you, Dr. Rajkiran. Our next speaker is Dr. Rajiv Ranjan.
Questions later?
Welcome, Rajiv.
A very good morning to all of you. So my topic for discussion today is that when to refer a patient of spondyloarthritis and rheumatoid arthritis to a rheumatologist. So I have gone through many articles and many such guidelines. Is there any such guidelines? So you will find that there is very little guideline that when to refer a patient, but gone through some paper and I am putting some important things in front of you. Those who are not rheumatologists, those who have not very advanced knowledge of how to deal the complicated cases. So the most important thing is the delay in referral. This is the important thing, delay in referral and delay in diagnosis. This is the two things that lead to the multiple complications, deformities and damage to any patient suffering from joint disease. So there are three important delays. One is patient delay. The patient is having early morning stiffness, some sign of inflammation, night pain, but he is not going to a doctor, trying some desi preparation, trying some painkillers, over-the-counter preparation and getting some relief. So this is the very important delay. This is variable from patient to patient and also from the location. In rural area, in urban area, the delay is variable. Many times nowadays, even the joint pain which is not related to inflammation in metro cities, patient is Googling and coming to rheumatologist directly without any arthritis or inflammatory disease. So this is variable from place to place. The second is delay from physician or the practicing doctor. If the patient is having some issue, there is delay in some starting DMARDs. If you are delaying the DMARDs treatment, there will be poor prognosis in the future. Because most of the studies in rheumatoid arthritis have shown if there is delay of 1 to 2 years, almost 40 to 50% of erosion starts within first 2 years. So delay in treatment, delay in starting DMARD is very important prognostic factor in the future. And obviously the third delay is hospital delay. The patient has referred, but there is delay in getting appointment and other things. So if you see the EULAR guideline 2022 update, so they have clearly written that all the patient of RA should be referred to a rheumatologist. But they have also mentioned that many countries in the world where the rheumatologists are not available at all. And even in the remote areas, the rheumatologists are still not available. So, or even the trained rheumatologists are not there. So what you have to do? So when to refer a patient of rheumatoid arthritis? So very important, when you get a rheumatoid arthritis patient, clinically, if the patient is having classical inflammatory sign, early morning stiffness of more than half an hour, and you are getting the inflammation in the joint, bilateral, symmetrical, additive inflammatory polyarthritis, start DMARD as early as possible. So first thing, if you are giving DMARD, methotrexate is obviously the first line of therapy for rheumatoid arthritis patients, unless contraindicated. So if you have given methotrexate and also added some drug, and the patient is not getting any relief by 3 months, So there must be some other reason why the patient is not getting any relief. Either the diagnosis is wrong, or the diagnosis is different, or is there any neuropsychiatric component into it, or something else. You have to reevaluate, and if you are not able to find out the exact reason, you should take an opinion from an expert. The second important thing, the target. In rheumatoid arthritis, we have 6-month target. When you are starting DMARDs or the therapy, the target is either low disease activity or remission by 6 months. So if you are not achieving this target, you have to take an opinion from an expert. The third important thing, aggressive or atypical presentation. Yesterday, Kaushik sir has told many important rheumatoid arthritis mimics, and many times I also remember one patient having 60-year-old coming with severe multiple joint arthritis. But one thing is, this was asymmetrical, predominantly involving the wrist joint, elbow, and the knee on the right side only, and left side few small joints of the legs are affected. So asymmetrical presentation, aggressive presentation, it's very important. When I evaluated, all the parameters are fine except RF is slightly positive. Inflammatory markers were very high, so there is no doubt about the inflammation. The joints were swollen, tender, and everything was there. But the asymmetrical onset elderly patient, I thought something else. When I do the screen, one important thing that we usually miss is the screening. Screening by doing hepatitis B, C, HIV, screening by just doing one X-ray. Chest X-ray, when I got it, I found a patch in the lung. And when it was evaluated, it was found to be lung cancer. So very important, when the aggressive presentation of rheumatoid arthritis is there, or atypical presentation that is not matching with the classical RA, think or screen the patient. In fact, the screening should be done in all the patient, the viral markers or chest X-ray. So not responding to your conventional synthetic DMARD, you have added combination of methotrexate, leflunomide, sulfasalazine, and even the patient is not responding in the 3 months at all and not achieving the remission by 6 months. So something else is there, or we need to upgrade the treatment. Because if you see the data that even combination of therapy of conventional synthetic DMARDs, almost 40% of patients do not respond at all. So you will get response in the 60% or up to 65%, but 30 to 40% of patients, they do not respond with the only synthetic DMARD, or they not achieve the target. Another important thing is complications of rheumatoid arthritis. So when there is a complication like the scleritis, if someone is getting scleritis, recurrent scleritis, these patients need a special attention. These patients need aggressive treatment. One patient came to me with recurrent scleritis, and he was not being treated aggressively, and he landed into the scleromyalgia, perforance, and blindness. So important thing is that you have to be very cautious which patient to be treated aggressively. Second is severe ILD. If the patient is having progression of ILD and you are giving treatment and not responding, the ILD component is not responding, obviously take an expert of a pulmonologist and also take opinion from a rheumatologist. Deformities on treatment. You are giving the treatment and the patient is developing deformities, multiple joint erosions. So obviously either you have to treat aggressively or you have to find is there any something else. Patient with having multiple comorbidities, having kidney problem, obesity, having some fatty liver disease, some cardiac issue, because these patients need proper monitoring, proper drug interaction, and you have to modify the therapy. So these patients land into multiple complications if they are not taken care. Patients with chronic infections, hepatitis B is active, patient is taking anti-tubercular drug, patient is having some HIV in hepatitis C, because drug interaction monitoring and modifying the therapy is very, very important. So these patients need an expert opinion and the care of expert. Patient with having a malignancy or a chemotherapy. So what happens, even the chemotherapy activates the immune system and can lead to arthritis flare-up. So this type of patients require proper monitoring and care by expert. So patients having you are giving the treatment but not responding, not receiving the remission by 6 months, and persistently high ESR and CRP, and those patients who need biological therapy, I think an opinion from your expert colleague is required. So now coming to the second topic, when to refer a patient of spondyloarthritis to a rheumatologist. So again, the problem with delay in diagnosis and delay in treatment in ankylosing spondylitis is very vast. You can see many studies showing that almost 6 to 10 years there is a diagnosis delay, and even a proper treatment is not given to the patient for 6 to 10 years. Many times the patient disease is progressing, deformities are coming, severe hip arthritis is occurring, there is damage in the spine, syndesmophyte formation is there, and still we keep the patient on NSAID, which is not going to modify the treatment or modify the progression of the disease. So those kind of patients need a special attention. So already I have talked that treatment, early treatment is very important. If you can treat the patient early, you can stop the inflammation and you can prevent the deformities and damage. Because if the deformities and damage develop, these are irreversible deformities. So as per guideline, so ideally all the patient of SPA should be referred to a rheumatologist, but many patients who can't reach a rheumatologist, or many part of the countries where the rheumatologists are not there or trained rheumatologists are not there, so you should have some important guidelines for when to refer. So these are the important features where you have to think for early diagnosis. So patients coming with inflammatory back pain, the one important thing that most of us miss is inflammatory back pain nature. If you remember this one thing, what is inflammatory back pain, you can diagnose the ankylosing spondylitis or SPA very early. The only important features, two important features that you have to remember is, first, early morning stiffness. If the back pain is associated with morning stiffness which is lasting for more than 30 minutes, then you have to always think for some inflammatory nature of pain. If patient is having night pain, he is lying down and after 1 to 2 hours of rest, the patient is having pain which is not going by movement by 20 to 30 minutes. So though these two important character can diagnose a ankylosing spondylitis patient very early. Obviously the HLA-B27 has been become very vastly used in the practice, and many of the patients even having non-specific back pain are advised to HLA. So this has also led to some positivity and also some negativity. What positivity? We are able to diagnose patients very early, but yes, you know that HLA-B27 positive can be seen in the normal individual. Approximately if you see if 1,000 patients are having HLA-B27 positivity, only 70 to 80 patients only develop ankylosing spondylitis. So it means that many patients are having only HLA-B27 positivity without any arthritis or SPA. So what happens? So HLA-B27 positive can be also present in normal individuals. So remember this. Sacroiliitis, because of rapid and early use of MRI, we are able to find out the sacroiliitis and early diagnosis. If someone is having peripheral arthritis, like the ankle arthritis, persistent knee arthritis, hip arthritis, always think of a spondyloarthritis group of illness. Extra-articular manifestation, someone is having psoriasis, someone is having recurrent uveitis, if having features of inflammatory bowel disease, dactylitis, these are the things that you have to look for a spondyloarthritis. If there is a history, family history of a spondyloarthritis, then always think the patient or the family members may have some feature if they are developing some arthritis or extra-articular features. A very important point is good response to the NSAID. You are giving painkillers, a patient responded very well. So obviously these patients can be fall into the group of spondyloarthritis. Having persistent acute inflammatory markers like high ESR and high CRP with some back pain or arthritis, peripheral arthritis, think about spondyloarthritis and early diagnosis. So again, for the ankylosing spondylitis patient, if the patient is not achieving remission or low disease activity, by 6 months you are giving the treatment, you are following all the guidelines and patient is not responding, then always you can take an opinion from an expert. Extra-articular manifestation, if the patient is having recurrent uveitis, recurrent inflammation in the bowel leading to bleeding from gut, weight loss, fever, so these kind of patients need a special attention and aggressive treatment. If the patient is having extensive psoriasis, so obviously you have to take an opinion from expert because this patient require higher therapies or aggressive therapy. Recurrent dactylitis, because many of times dactylitis do not respond with the DMARDs, so you need a special attention. You are giving the treatment and patient is developing a stoop posture and a patient is having deformities, so always take an opinion and treat those patients very rapidly so that the patient can be maintained remission. If the patient is having persistent high inflammation even after your treatment, or patient need biological therapy, they should be referred to a rheumatologist for screening and proper evaluation and to rule out the mimics of this ankylosing spondylitis. Steroid therapy, if the patient is a steroid dependent, obviously in ankylosing spondylitis, steroid is not a treatment, and it is given only for short period and also for peripheral arthritis. They don't have any role in the axial symptoms, and if the patient is always taking a steroid, you need to think about referring this kind of patient to an expert. Aggressive or atypical presentation, if the patient coming with some other issues like having persistent ankle arthritis, knee arthritis. I got a patient, a young patient having severe knee arthritis, given and said no response at all, given even intra-articular steroid. After 2 months he relapsed. Again the patient was put on tofacitinib, and that patient came into emergency with shortness of breath, and after evaluation found miliary tuberculosis. So those patients who are not getting response or getting partial response, think about something. And that patient was also HLA-B27 positive, but no axial symptom at all, no sacroiliitis. So HLA-B27 can misguide you and can blind you, and you can't think beyond that. So always think, if someone is having atypical presentation, not responding to the treatment, think about some other, especially the TB in our country. If the patient is having some associated chronic infection like hepatitis B, C and HIV, if the patient is taking anti-tubercular drug or having history of malignancy, then this kind of patient need a special care and a special monitoring of the drug therapy. So thank you so much. Now I'm hoping to get more referrals.
Now I call upon Dr. Kavita Krishna. He is talking on very important topic which is very useful for us. All orthopedic surgeon can see the rheumatoid patient. Madam.
Thank you, sir. A very good morning to all of you. So we shall be discussing an interface between orthopedic surgeons, rheumatologists and also physicians. Let's see, 62-year-old female, rheumatoid arthritis for 20 years, planned for bilateral TKR, hypertension, diabetic. So this is a very common case scenario for all of you. ECG showed mild ST depression. There was some dry cough, exertional dyspnea, patient on methotrexate and tofacitinib, and also slow dose of prednisolone. Moderate ESR, anemia, creatinine borderline, and also neck pain and a little UTI. Now look at this X-ray. So issues to be addressed are, we have to evaluate for the cardiovascular risk, pulmonary function, the anesthetist perspective, because if you see this X-ray, there's a lot of cervical spondylosis, loss of cervical lordosis, and also probably a cricoid artery cartilage problem also here. And intubation is going to be difficult. We need to optimize the DMARDs, the steroids, blood pressure, blood sugar, multiple problems here, and infection control also. So surgery in rheumatoid arthritis, when we evaluate, we have to see what type of surgery is it. Is it elective? Is it emergency? Surgeries which may be done as arthroplasty, which is most common, arthrodesis, synovectomy, arthroscopy, carpal tunnel release, or tendon transfer. Surgeries for atlantoaxial instability, which is often in with coordination with spine surgeon or neurosurgeon, or a completely unrelated to rheumatoid arthritis, patient has trauma, some degenerative spine disease. So timing of surgery is very important. When medical therapy fails, which is becoming less and less now, pain, deformity, restrictive mobility. So early surgeries are less now. Usually these patients present later. And you have to consider the fact that these patients are younger than other patients for arthroplasty. So you have to also time it right so the arthrodesis or the arthroplasty lasts as much time, so patient may need a revised surgery. So indications, as you all know, is predominantly osteoarthritis, and rheumatoid arthritis or inflammatory arthritis contribute to a very small percentage of arthroplasties. So what is the planning? There's a lot of planning should be done ideally. Prior strengthening in terms of physiotherapy, like the patient needs to walk on crutches post-operatively. You have to strengthen the arm muscles. It should be done pre-operatively, not post-operative. Lungs, spirometry, the patient should stop smoking. If the dental infections, urinary tract infections, which are very common, should be optimized. Nourishment should be good. Hemoglobin should be at least above 9 or 10. WBC count should be correct. Bone health should be evaluated. Otherwise, if it's an osteoporotic bone, the joint implant won't hold well. Many of them, besides DMARDs, are also on steroids, antiplatelets, so these need to be modified. And we need to assess the bone health. The DEXA scan should be done in most of these patients. So besides history and examination, we need to evaluate all these factors and find out whether the patient is fit for surgery or no. Atlantoaxial subluxation is important from the anesthetist perspective because they need to manage the airway. Many a times we do under spinal, but they may need intubation or sedation, etc. And pre-op lateral cervical radiographs can be considered in most of the patients. The case that I showed you, cricoarytenoid joint disease, can be a challenging factor. And whenever the bone density is not good, one should wait a little before offering them a spine surgery. So there's a close communication for the anesthetist, which is important. We have to time the surgery well, as I said. You have to stabilize the upper limbs. Some of them have neutropenia because of drugs or maybe Felty syndrome. You should build up the WBC count before that. The risk of prosthetic joint infection is always there, so that should be minimized. At least the risk factors should be minimized because there is a risk of infection as well as dislocation. Positioning of the surgery can also be challenging, like the patients who have shoulder pain. They cannot lie down in lateral decipitous position when they are undergoing a hip surgery. So all these factors need to be considered in a rheumatoid arthritis patient who is undergoing hip surgery. You have to assess the disease activity. If the rheumatoid arthritis is very active, there is no point operating. You have to wait for the disease to become at least minimally active, only then operate these patients, well controlled and optimized on the medication regimen. So when we do manage these patients, we have to balance the risk of infection versus flare of the inflammatory disease. So rheumatologists should be involved before planning the surgery regarding medications, disease severity assessment, regarding glucocorticoids, what are the risk of having surgical site infections. Also, there's a chance of hemodynamic instability. You should not suddenly stop the steroids because there can be hypotension, etc. And the patient should be lowest preoperative doses of steroid to minimize all these risks. So yesterday there's been a lot of discussion. So conventional DMARDs, by and large, most of them can be continued unless you feel post-operative there's an infection. So you can delay restarting these drugs. And if the patient are on a lot of NSAIDs, there is a risk of GI bleed, anemia, acute kidney injury. Many a times the creatinine is done just on the day of surgery. You should evaluate the creatinine level before so that the patient doesn't go into post-operative acute kidney injury. Regarding antiplatelets, low dose aspirin, many surgeons nowadays don't mind operating. But with clopidogrel, many of the patients are dual antiplatelets by default nowadays. So you must omit clopidogrel at least. Aspirin you can decide, and if you really feel the patient has a post angioplasty status, you can put them on heparin low molecular weight. Okay, so it should be a team decision. Regarding methotrexate, is by and large clear that you should not stop it. So there have been studies which showed that methotrexate, the anchor drug in rheumatoid arthritis, there was an RCT where group A continued methotrexate, group B withheld, and group C was never on this drug. So when they saw the complications, they found that group A, in which methotrexate was given and continued, had the minimal risk of infection. So this is proven beyond doubt. There is no need to stop methotrexate. Even the flares were minimal. Like what happens is after surgery, some of them just go on a flare. So the ones who are on a methotrexate do not get a flare of the disease, which can be quite troublesome. Leflunomide, there's not much safety data, but by and large, you can continue at least sulfasalazine, hydroxychloroquine, but you can continue these drugs, and there is no need to stop it. There's no risk of surgical site infection. So overall, the guidelines say you can continue conventional DMARDs. Now the question is of biologic DMARDs. There was a question yesterday, how much before, how much after. So there are strict guidelines. You skip the next dose and so that you miss one dose in between. So infliximab, it depends what dosage you're giving, what patient is on monthly or every 8 weekly, etc. Adalimumab is the commonest that we use nowadays, so it's every 2 weeks. So you miss one dose, after that you operate and then start after another 2 weeks, provided there is no surgical site infection. For each biologic, there is a guideline, so follow that For rituximab, it is the longest. So for 6 months, you cannot operate the patient ideally. And this is all for elective surgery. Emergency surgery, there is no rule. If you have to operate, you have to operate. JAK inhibitors nowadays, they say you can, like tofacitinib is the commonest JAK inhibitor used nowadays. So you can stop just 3 days, but I prefer to stop it about a week before. And most of them, they are NBM or something or the other. So we restart usually by and large after 2 weeks, JAK inhibitors or any other DMARDs that are there. So as I said, it's usually around wound healing is around 2 weeks. So after 2 weeks, you can start. And this is just repeating whatever I said. Aspirin also we have discussed. Antihypertensives, yeah. So telmisartan is the most commonly used antihypertensive. ACE inhibitors like ramipril, etc. very few people use nowadays. What you have to remember, till the day of surgery, till the day before of surgery, you can continue whatever is going on. On the morning of surgery, telmisartan, ACE inhibitors should be stopped because they have an increased tendency of post-operative hypotension, especially with spinal anesthesia. And post-operative, post-spinal, the BP remains a little low. So you should be in close contact with the physician to restart slowly. And regarding now steroids. So ideal patients are those who are less than 5 milligram of prednisolone. No steroid is of course the best, but many of them are, despite whatever we discuss in different conferences, most of the patients do get steroids from time to time because the disease is active, patients don't get relief, some of them are self-medicating. So the risk is minimal if the steroids are less than 5 milligram per day, and it is less if it's less than 15 milligrams per day. More than 15 milligrams per day, definitely the risk of infection is higher. So delay the elective surgery if the steroid dose is higher. And regarding the peri-operative stress dose glucocorticoids, so if the patient is not on steroid, no need to give. If they are on steroid, we have the conversion factor for hydrocortisone, etc. For each, like some are on methylprednisolone, some are on deflazacort, some are on the prednisolone. So you give the conversion perioperative stress dose and consultant with the physician, preferably the rheumatologist. So there is no increased risk of infection, but patient doesn't go into post-operative adrenal crisis. So this just summarizes an algorithm which summarizes whatever I said. Continue the conventional DMARDs throughout the perioperative period. Hold one dosing interval with other biologics. Usually restart after 2 weeks. That is the time when the infection risk is less and the wound healing is well by then. And the JAK inhibitors also, though they say 3 days in the latest guidelines, better to stop 1 week before and restart 14 days after. Another common clinical situation is supposing a patient has had history of septic arthritis and now you want to do surgery, what is the risk of getting prosthetic joint infection? So often the surgeons are wondering whether should we operate now or should we operate way late. So there are many studies which have been conducted. So what is found is the risk of prosthetic joint infection after an episode of native joint infection prior to that is averages 5.9 months. So preferably do not operate within 3 months unless really required. Ideal time is around 6 months. Delaying more than 6 months, say you operate after 12 months or 1 year, doesn't really reduce anything. So optimum time is around 6 months. So these studies show you that here if you see at 12 months the risk wasn't really less, at 6 months is just right. To sum up, pre-op preparation requires physiotherapy, thorough pre-op evaluation, cardiovascular risk. Look at other comorbidities. Blood sugar should be controlled. Look at the HbA1c couple of months before, not just on the day before of surgery. Evaluate bone health. Correct the osteoporosis so the implant will hold better. Cervical spine should be evaluated because the anesthetist should be taken into confidence. Difficult intubation assessment is important. Assess the disease activity. There is no point operating in an active rheumatoid arthritis. DMARD, steroid management is not difficult, guidelines are there, but discuss with the rheumatologist whenever you plan the surgery. So the key to a successful elective surgery in rheumatoid arthritis is just adequate preparation on all fronts so that the patient is happy, the orthopedic surgeon is happy, and the rheumatologist is also satisfied. Yeah, that's my department. Thank you so much.
Thank you, madam, for nice presentation. And now, next and last speaker of this session is our guru, Professor S.S. Jha. His topic will be time to employ serial killers to terminate premature wound, question mark.
Thank you, Chairman. My presentation. When went off. So friends, there are innovations in all the fields. Well, war is going on between so many countries, and the world was taken by surprise that there were simultaneous serial killing through pagers and even walkie-talkie. So, innovations in serial killing also has taken place. Friends, we want to terminate, but terminate what? Our patients? No and never. Definitely the target is the disease concerned in rheumatology. So it has already been talked about previous evening also, this morning also, that the ideal treatment target is remission, which should be sustained, either drug-free or persistent, or achieve a low disease activity. Let me define what we mean by remission. Paradigm shift from controlling symptoms to controlling the disease process with abrogation of inflammation. So, remission is finally defined as complete absence of clinical sign and symptoms of synovitis, so there is no swelling. Elimination of silent synovial inflammation, normalization of markers of systemic inflammation such as ESR and CRP, and there should preferably be little or no radiographic progression as well. Low disease activity is an acceptable alternative when remission is not possible, especially in established long-standing disease, because comorbidities or other patients' factors limit DMARD options. So what is the future? Let us talk about the disease terminating. So understanding of the pathways behind initiation of rheumatic diseases, perturbation, which is disturbance or disruption of immune regulation understanding. So new targeted intervention at individual patient level will influence mechanism driving occurrence of sustained drug-free remission and maybe offer a cure. When the patients are coming to our clinic, they are having a hopeless face. Oh, my disease cannot get cured, it can only remain controlled. But yes, there is another innovation with its limitations which can offer a cure. So now let us talk about the two immune systems working in rheumatology or for any attack on the body. So the innate immune system is activated through all these cells, monocyte, macrophages, neutrophil, dendritic cell, and so on. So they are the first line of defense, and they necessarily get activate and instruct the second one, the adaptive immune system, and they comprise of lymphocytes. Mind you, these T cells and B cells are going to be the focus of my talk this morning. Well, this is a B cell which are autoreactive, and they contribute in rheumatoid arthritis or other rheumatic disease to inflammation and tissue damage. So my serial shooters are going to shoot these autoreactive B cells, and not in one go. They will continue to remain live in the body for very, very long time, so the serial killing goes on and the disease gets cured. Well, I have already said they are serial killers, and what we employ to kill those B cells are T cell therapy. So these T cells are known as serial killers also, and this stems from ability to selectively destroy these autoreactive B cells that express the target antigen. So this is the T cell. It has a therapeutic potential, so ability to precisely eliminate or terminate the pathogenic autoreactive B cells. They offer more targeted approach compared to traditional therapies. Well, in rheumatology, have there been potential applications? Yes. Rheumatoid arthritis, CD19, CD20 and CD22, they deplete autoreactive B cells. Lupus nephritis, again CD19-20. Sjogren's syndrome, again CD19-20. Psoriatic arthritis, again CD19-20. And again in ankylosing spondylitis also, CD19 and CD20 reduces the autoreactive B cells and so terminate the disease. Well, coming to, so what is CAR T cell therapy? It uses genetically modified T cells to recognize and attack these cells producing the disease. So CAR means chimeric antigen receptor T therapy. This is a form of immunotherapy that has been explored in the treatment of various rheumatological conditions, including rheumatoid arthritis, lupus, and multiple sclerosis. Friends, methotrexate is one drug which also has been used in tumors or malignancies. We have taken that as the seat anchor drug. Here, this T cell or this immunotherapy also is used for terminating various cancers. So we have adopted the same into rheumatic field. So this is the diagram of T cell therapy. These T cells are taken from the human body of the patient and they are in the lab genetically engineered as chimeric antigen receptor. So what are the steps? You have extracted a patient's T cell from his or her circulation. You have genetically modified them to express a chimeric antigen receptor known as CAR, and then again you reintroduce the same into the patient's body by reinfusing them to target specific cells or proteins involved in the disease process. So here you can see it has been taken out from the patient's blood. The T cell has been isolated, activated, and there is genetic modification. So, and after this genetic modification, they are converted into CAR T cells. Here they multiply and they are injected back into the patient. And then this chain of events do take place. So, the principle of CAR cell therapy is that this is a living drug. Living drug means these T lymphocytes which have been genetically engineered are living products. And the another advantage that they can access all sites of the human body. They recognize the antigen expressing cells and kill them. So recognition and effector function together, and activation and proliferation at site of antigen exposure takes place. Why do we see it call it a live medicine? Because it involves a dynamic living component as part of therapeutic process. Modifies patient's own T cells, a type of WBC which plays a crucial role in the immune system. Well, there are challenges. What it can do, it can overreact. So we have to look into that the genetic engineering has a control that it does not overreact and does not damage healthy cells. Well, we have to keep the potential side effects into control, and we definitely have to understand the long-term implications. Friend, you can see that within this blood vessel, the CAR T cells have, after they have been infused, it converts into CAR T, that CAR T cell now is coming out from the blood vessel towards the area where it has to attack. So CAR T cells after infusion into the bloodstream undergo extensive proliferation inside blood vessel and leave the circulation to reach their target cells. Now at the site of action, how it works. So this can trigger extensive proliferation of CAR T cells and release of tumor antigens which activates immune system to recruit non-CAR T cells, thus eliciting further anti-tumor response in a process which also goes by the name of cross-priming. Mode of action, well, they target CD19, which is a protein expressed on B cells, or CD4 is a protein expressed on T cells. They activate, so upon binding with the CAR activates the T cell, leading to its proliferation, cytokine production of IL-2, 6, TNF-alpha, and cytotoxic activity, and elimination. The activated T cells eliminate the target cells, so reduces the inflammation and modulating the immune response. Well, friends, there are complications with even routine drugs, and here too the complications could be mild with fever and fatigue, and it could be serious and life-threatening because this cytokine release syndrome. This could be life-threatening because of excess release in bloodstream of IL-2, 6, and TNF-alpha. Here also, for treatment of this cytokine release syndrome, tocilizumab is the drug of choice. First generation, second generation, third generation, and even fourth generation are now available. Well, based on cell source, they are designed as autologous CAR T cells, where the patient, now see, we are talking of the patient, so derived from the patient's own T cell, but it can also be allogenic, derived from a healthy donor T cells, and T cells may also be generated from human embryonic stem cells and induce pluripotent cells. Well, based on additional feature, they are classified into armored CAR T cells, switchable CAR T cell, and universal CAR T cells. Well, some ongoing clinical trials in rheumatoid arthritis, lupus nephritis, and RA are there. The benefits are that this is a targeted therapy, and long-term response is to be there, and there is a potential for achieving remission. Well, cost, yes. The cheapest CAR cell therapy, all of us will be happy to know, is available in India. IIT Bombay has genetically engineered and is available, and the cost will be around 20 lakhs. Other countries, it is almost a crore and maybe above. China also produces them. Well, off-the-shelf universal CAR T cells is also possible, use of a variety of gene editing techniques, but apart from rheumatology, these can also tackle autoimmunity, infection, inflammation, degeneration, wound healing, and fibrosis. So, is the time mature enough, or it is a premature move? Well, early results are really encouraging and promising, but is still experimental in rheumatology, and more research is needed to ensure safety and efficacy and for establishing its role in routine clinical practice. Friends, I would like to conclude that this is highly personalized. T cells are collected from patients. They enable to recognize and attack the targeted autoreactive B cells, grown and expanded in lab, reintroduced into the patient, and these CAR T cells continue to live within the patient, function within the body, seeking out the target cell, actively work to maintain therapeutic effect unlike traditional medication, persist in body for extended periods, living cells are constantly combating. Friends, I would like to end with this favorite painting of Achilles' mother is plunging her son by the heel in the river Styx to make him invulnerable, but unfortunately it was the heel area which could not be dipped, and that was vulnerable. I keep this painting only to remind you, look and talk to the patient and see that if there was any pre-Achilles swelling or pain. Thank you very much.
Thank you.
Thank you, sir.
Thank you, sir, for nice presentation. Now the time for discussion. We invite questions from the audience. And three speakers are Dr. Raj, Dr. Madam Krishna, and Dr. Rajiv Ranjan from. Any question? Yes. Dr. Bharat.
Till the time, any questions? Yes, please, go ahead.
I have seen since yesterday, whenever you talk about corticosteroid, usually you prefer prednisolone, while I think most of the orthopedicians also use deflazacort. So what is your take on that, ma'am? Which one to prefer?
Yeah, so most of the studies which, when you talk about literature, talk about prednisolone equivalent is there. So they say deflazacort and methylprednisolone is causes less osteoporosis, etc. But I don't think there's much difference. So it's your choice. Deflazacort probably causes less fluid retention and little less osteoporosis, they say so. But 4 of methylprednisolone, 5 of prednisolone, and 6 of deflazacort is the same. So when you're going for a lower dose steroid, it doesn't matter what you use. But you take the cost into perspective. Like we have a lot of patients of lupus, where we need to give 60 milligrams, 40 milligrams of prednisolone. So there it's always prednisolone. But in, I think, rheumatoid arthritis, we're using doses of, we are using doses much lower. So it doesn't matter. Probably prednisolone, say, what personal experiences, they get a little facial puffiness, fluid is more than the other medications. That's it.
Ma'am, we are more concerned about avian because we are seeing.
I don't
which
know
one
if there are
is
any
best?
studies to say that deflazacort causes less avian. I don't think so. They are all the same, yeah. In fact, the cost difference is a lot. A 5 milligram prednisolone costs much lesser than 4 milligram of methylprednisolone or 6 milligrams of deflazacort. So risk of avian is the same with all.
Well, I would like to add regarding avian production. This is a definite possibility, but not with the lower dose. It is only the higher dose, more than 7.5 milligram or maybe 15 milligram for more than 6 months, then we have it. Well, our COVID experience have definitely made us aware that a higher dose loading in COVID patients, we had many patients of avascular necrosis.
My question is from all of you. Is there any standard protocol, fixed standard protocol, followed by all, by EULAR, to treat early, late rheumatoid arthritis like ATT? Is there any standard protocols?
What about ATT?
Like ATT, there is the ATT, there is the standard protocols.
Ah.
2 month this drugs, 4 month this drug.
Yeah,
Is there any standard protocol
Yes,
for
yes.
rheumatoid?
The entire guidelines are standard only. The guidelines which are there, EULAR, ACR guidelines, they are all standard protocols. Yes, to begin with, it's all methotrexate, and if methotrexate is not suitable, you choose another drug, and every 3 months you assess. Because ATT, there you are closing the treatment. Here you are not closing the box. You need to continue. And this is more dynamic treatment than ATT. Like because the treatment keeps on changing as the patient's response is. So you can't compare the tuberculosis treatment with rheumatoid treatment. Vis-a-vis you can compare with an hypertensive treatment or a diabetes treatment. No? So this therapy here, the protocol is set there. Like every 3 months you assess the patient till you achieve the remission. Because you give some time for the medicines also to act and show some response. Don't change immediately. Start the therapy and observe, and after 3 months you assess, and if the disease doesn't improve, you escalate. And in between, if the patient develops any side effects, you stop or change the therapy.
Thank you.
Excuse me, sir. If I am giving biological from this side, sir, and the chairperson, sir, if I am giving the biologics and I am having the remission, when should I stop the biologic and when to start with?
So once you start the biologic, when to stop it? This is your question. So the first thing is to achieve remission, then to maintain the remission. See, the better is, the longer the remission period, the better is once you de-escalate the therapy. So if you have at least a minimum of 6 months of remission period, then you try to de-escalate the therapy. Suppose if you are choosing a biologic like adalimumab, which you are giving once in 15 days, so there is a way to taper it. Either you can reduce the dose from 40 milligrams to 20 milligrams and keep the interval same, or either you can increase the interval and see. Like 40 milligrams, from 2 weeks to make it for 3 weeks or 4 weeks, like that, not beyond 4 weeks, where it's not pharmacologically suitable. So this is how we de-escalate the therapy. But more often the recent guidelines of ACR EULAR, what they are trying to emphasize is, because the patient has failed methotrexate, you have added biologic, now the patient had responded. Okay. So if you remove the biologic, and again you are keeping the patient back on methotrexate, there are chances that you might be going back to the same position. So here the methotrexate alone is not working, you have added TNF, it is working. So you can think of removing methotrexate and maintain the TNF. So this is what the discussion is on. But again, India is a very different country, the costs come into the picture. The patients are worried because they don't want the costliest drug to be taken for a longer time, because more costly, if they feel more powerful, more side effects they will get. So we need to discuss, we have these challenges, and finally the treatment recipe will be between the patient and physician dialogue and whatever you decide commonly.
As you said, sir, biologics should be tapered with the sort of the improvement in the patient. And again, after 1 year, he come or she come with the gradual swelling. So for the coast region, initially for 3 months we give at the 15 days adalimumab, and after 3 months we usually give practically with at sort of 1 month or 2 months interval, because I hope it is there is remission. But if there is recurrence, what should be the dose of that adalimumab? It should be whether from the initial level or
actually, honestly, 3 months is a very, very short period. Short period, because this 3 months concept, actually we initially started with this 3 months concept. So in 2010-11, when we have started using Emerald, so in Hyderabad, myself and Aarcon Rao sir and Malaviya sir, most of them. So because we can't use the initial biologic, the company, the Pfizer, which they have come, they have not said to give for 3 months or 6 months. There, you start therapy, you continue therapy. There was no concept of this 3 months, 6 months therapy. So because we can't give therapy with these guidelines, most of them, to understand the patient after giving 3 months. So we have did a small study there, giving this Emerald for 3 months and observe. And after 3 months, most of the patients were off steroids, off NSAIDs, they were doing well. So we thought of slowly de-escalating the therapy. But since a decade of our experience, it has been observed that those patients who are having a late disease, early disease is different, it behaves differently, and a late established rheumatoid arthritis behaves differently. If you have an early disease is disease duration of less than 2 years, they respond very well. If you give an early biologic, 3 months, 4 months, they might go into good remission. But the late diseases are the one, they are very resistant, because the immunobiology is completely different. What's happening in the tissue is different in early disease and in the late disease. They are the very difficult ones. There the 3 months, 6 months might not work. This is an important clue. If the patient is suffering with rheumatoids for 5 years, 10 years, and they come to you, you give a biologic, you just take it as a granted, your 3 months therapy will not work. Definitely after 3 months, patient is going to relapse. For this patient, tell them at least for 1 year or 2 years, longer time. So minimum 2 years it has to be given. Early disease, yes, you can put your money there. Early disease, within 2 years, you can presume that you can take off this patient of biologic.
Sir, my question is from Professor S.S. Jha. When we talk about the biologics and your latest CAR-T treatment, which is costing 20 lakhs, you see, I want from your end, the comparative cost therapy.
Well, I have put a word, is it premature? And I said, work has started. In the world, the first patient of lupus has been cured, and she has almost continued asymptomatic for 1,000 days. So, if a patient is able to spend And as I said, that it is available in India for that price, and if somebody can afford, it definitely would be a choice maybe in coming years when you can have control over the disease. And as I have said, that they do not overreact and you do not have the side effects as well, which could be life-threatening. In continuation of what was asked from the chair, I would like to say one thing. I always keep on telling that you first go to school and then you go to college for your graduation. So complete your schooling with conventional synthetic DMARDs and then graduate to biologics. Or if you feel you cannot manage beyond conventional synthetic, refer to one of the rheumatologists who will take appropriate action. Everybody is always eager that there will be a mathematical type of recommendation. No, each patient is variable. You have to look into the various factors connected. Has the patient other comorbidities? Has the patient already developed deformities? So, please, but do not stop at the level of conventional. There was a time when leflunomide was used, and on the box it was written is to be recommended only by rheumatologist. I think urologist also they used to write. And there were so many court cases faced by our orthopedic colleagues because they had prescribed this drug. Unfortunately, the initial recommended dose used to be 100 milligram for 3 days, loading dose, and then go for 20 milligram. Now it has been realized that even 10 milligram or 20 milligram daily, and maybe after some time even on alternate days, are better drugs to be used. Well, I have a point to ponder upon. Last evening I also talked about sulfasalazine and its role not only in rheumatoid, but we orthopedic surgeons keep on seeing more cases of spondyloarthropathy, and if I can say so, we are not recognizing spondyloarthropathy because the patient keeps on telling, they are informed person, Doctor Sahab, मेरा तो rheumatoid factor negative है. Now this one thing, if the patient has not told you, you tell him that this is a rheumatoid factor negative disease. Number two, on the very first visit, you must tell them that the treatment has to be continued longer and that the treatment will not cure you, but definitely we will control it. So regarding sulfasalazine in spondyloarthropathy, I wanted to say that sulfasalazine is not one drug. It is combination of two things. And this sulfasalazine usage was started, interest was taken up after in an anti-leprosy, dapsone, we found that there is anti-inflammatory property. So it has one component which is antibiotic and another component which is anti-inflammatory, that is 5-acetyl salicylic acid. Now when we ingest, only 15% is absorbed from the small intestine. The rest goes to the large intestine, and there in the colon, they are divided into two parts. 90% of the anti-inflammatory remains in the gut, works on the immune system available in the gut and thereby modifies. The other anti-inflammatory part works, and that is, since it is anti-inflammatory, I say, we are even otherwise saying that use 2 NSAIDs. So maybe why it works, this is just a hypothesis, that because there is anti-inflammatory property in sulfasalazine. Your comments.
Agree, sir. Agree. This could be one reason. It might someone might feel like that this drug will work in axial SpA2. As sir said, like one thing is its anti-inflammatory property. Other thing is the antibiotic property. There is also one hypothesis that it might alter the gut microbiome, so which might play a very important role in the diseases of spondyloarthritis, where we have the lots of issues with gut microbiome, which can be contributing to the disease. So these are various hypotheses, its anti-inflammatory activity and its effect on gut microbiome might help in controlling the disease even in axial SpA. But however, these are lots of hypotheses, but unfortunately they could not be converted into the real world scenarios where which we find the responses. That is the reason most of the guidelines do not include sulfasalazine in treatment of axial SpA. But however, lots of experiences, like Ja sir has like more than 50 years of experience in treating this kind of patients. Even most of our senior physicians, when I was doing my rheumatology training in almost 18-20 years before. So for axial SpA, this was the only drug. We have grown up treating our patients with these drugs, NSAIDs and sulfasalazine. Now I think the newer generation is learning a different thing, but definitely I think there might be the role. And just a couple of minutes, I would say I think one of the best lecture I heard on CAR T-cell is from Dr. Ja. So I would like to give, because he had made this a very, very complex topic so simple, and I think he had just opened up and made people understand. And the second thing is this therapy is for more complex autoimmune diseases like lupus and scleroderma. So recently we did one CAR T-cell therapy in Hyderabad. So the patient was following up with me for scleroderma, that the patient is scleroderma. So in our hospital we could not do it, and we worked with Dr. Sarachitramouli in KIMS, so which is a bigger hospital. So we had, I think last month we had the patient of scleroderma who had received CAR T-cell therapy, and the costs are not 20 lakhs. Actually, we sent it to Malaysia where we have got it for the 2 antibodies. It's more than 50 lakhs. It's almost entire therapy. So once it crosses almost 50 to 70 lakhs, the cheaper ones which they are making in Tata in Mumbai, it's coming for 20-25 lakhs, I think. But the therapy is much, much higher, and it doesn't end there, because later on patient has to go through a series of side effects and lot of problems. It might add and add. Every admission might give more and more complications, and the cost might increase further.
Thank you,
Dr.
sir.
Raj. Now,
Sir,
concluding this session, due to short of
proceed
time,
with the next session.
we can discuss in the lunch time or tea time.
One comment again regarding sulfasalazine. There are opportunistic infection with use of these drugs. Sulfasalazine 1, which in fact restricts tuberculosis not to develop.
I would like to invite on the stage Dr. Shamshul Hoda sir.
Thank you very much. Samshul, before you start, there is a lucky draw from Dr. S.S. Jha. Can you pick up one? Sir? These are the people. Registration number, ma'am. Yeah, now.
So the lucky winner is Dr. Ravi Ramraj Singh, 172.
Ravi Ranjan Singh.
Ranjan Singh, sorry.
Dr. Ravi, please come over, and the next session will start. Yeah.
In the meantime, with this suitcase on in madam's hand, I am reminded, I went once to Ram Vilas Paswan, he was a minister. We had concluded a Bihar orthopedic conference, and we wanted to give a suitcase to him. He said, no, I cannot accept it. First open it and show that it is empty. And this morning, we are going to have from Ram Vilas Paswan's party, our youngest lady MP.
Thank you, sir. Dr. Samshul, please.
Thanks, Emilio, sir. Thanks a lot. I thanks everybody for coming here for this wonderful academic arena, and we have been learning a lot from everybody. Thanks to our faculty, thanks to Amolya sir, and especially the delegates. So now for the next session, I'd like to invite our chairpersons, Dr. Praveen Kumar, Dr. Kanhaiya sir, Dr. Vinod Kumar Thakur, Dr. Gaurishanga Jha. I request all the chairperson to come. Dr. Praveen Kumar from Darbhanga sir, Dr. Kanhaiya sir, Dr. Vinod Kumar Thakur, and Dr. Gaurishanga Jha sir. So I request everybody to make it very academic and interactive. Thank you. Over to you, sir.
So good morning to all. Without delaying time, I invite Dr. Kavita Krishna, arthritis of ankle and foot. His talk is, please come.
So I'm back again. It's another important topic which is like, I think, important for all, for the patients, for the orthopedic surgeon, and also for the physicians. So ankle and foot pain is often a dilemma when it doesn't get better. So it's a weight-bearing joint, a very important joint. So when we deal with ankle pain and joint, Dr. Kaushik said yesterday, clinical examination is most important. So what needs to be emphasized here, which I think orthopedic surgeons are better at examining joints than rheumatologists, the details, especially the articular versus periarticular. So we'll just revise. Articular talks about synovium, cartilage, bone, menisci, and capsule. And if the pain is around the joint or away from the joint, it involves ligaments, tendons, bursae, muscle, fascia, nerves, skin, subcutaneous, etc. The point here is that all of them can cause pain around the ankle or the foot, but articular pain is diffuse, deep. There may be swelling, crepitus, instability, locking, or deformity. Periarticular is often localized. Findings are sometimes remote to the joint, and there's usually no crepitus there. In articular, there's pain on active and passive movement both, whereas peri or extra-articular, it is pain on active movement. So when a physician or a rheumatologist talks about ankle or foot pain, we are talking about medical non-traumatic causes, because traumatic causes, you all are the experts. So we talk about gout, spondyloarthropathy, rheumatoid arthritis when it affects the foot. Osteoarthritis is a wear and tear, which you all are well familiar with, and certain rare and interesting conditions. So again, I'll keep it case-based. A 45-year-old female came with fever and rash, pain and swelling of ankles, of joints since 1 week. A very common scenarios in the last 2 months. Acute inflammatory arthritis, I don't know how it is in Bihar, but in Pune, Maharashtra, very rampant viral chikungunya arthritis, raised ESR, raised CRP. Within first 2 weeks, but you should do chikungunya PCR, do not do IgM. After 10 days or 2 weeks, you can do the IgM testing. So many a times IgM is advised in the first few days, which will come negative, so there is no need to do that early. If at all you wanted to do PCR, which is an expensive test. But this particular patient, after 2 months, rash had gone, fever had gone, but joint pain persisted. And she also developed persistent swelling of the hand joints. So here she was rheumatoid factor anti-CCP positive, and we started treatment as rheumatoid arthritis. The point here I'm going to make here is, it can present acutely, that could have been a trigger, but she has got rheumatoid arthritis. Another patient, 30-year-old male, which you commonly may encounter, 4 years recurrent pain and swelling of left great toe, classical chronic monoarthritis, podagra of the first MTP joint, a chronic tophaceous gout. So the 6-step approach to arthritis in every patient is, since when? Is it acute or chronic? How many joints? Is it single, 2 to 4, or more than 4 joints, mono, oligo, or polyarthritis? Is it articular, periarticular, that we already discussed? Is there a back pain or no? That we discussed yesterday, so it may go on into a spondyloarthritis. Is it inflammatory, non-inflammatory? We discussed inflammatory has morning stiffness, persistent pain in the morning, that it gets better with exercise, inflammatory markers, associated fever, etc. Is it arthritis? Or this got some other which could suggest a connective tissue disorder, like rashes, fever, ulcers, etc. And is the skin, eyes, bowel, or genitourinary involvement there? This is a very important question you have to ask every patient. They may forget to tell, and we may forget to ask, but this changes the diagnosis considerably. And the most important remains history and clinical examination, and 10 to 30% could be laboratory imaging, and then you arrive at a diagnosis. This patient was a 56-year-old female, obese, sorry, this is a male, obese, alcoholic, ankle and foot swelling, chalky white discharge, high blood sugar, high HbA1c and high creatinine. You can see the chalky white discharge, uric acid was high, chronic tophaceous gout with high degree of inflammation. This is interesting, 22-year-old male, pain and swelling of joint of toes, ankle, young patient, but tophi since 5 years, chronic tophaceous gout, no doubt about it. So family history also was there. So when you have such patients, young patients presenting with chronic tophaceous gout, it's very challenging to treat because the tophi just go on increasing. We do not have pegloticase in India. They need lifelong treatment, and the tophi, you can see the right fourth toe, there's already exuding chalky material that this persists. It can quite deforming and troublesome. So here, if affording, if you have a tertiary care center, you can do enzyme testing, genetic testing to arrive at a diagnosis of the cause, do genetic counseling for these patients. Dr. Amulya asked me yesterday about enthesitis. So this is a 25-year-old female, pain, swelling and tenderness over the posterior heel. You can see on the heel part since 4 months. So this is enthesitis. It could be peripheral spondyloarthropathy. As for other symptoms, watch the patient. Here, as Dr. Jha said, sulfasalazine often works well. Sulfasalazine works within 4 to 5 weeks, not for 2 to 3 months. You don't have to wait, so you can see the response. But this another patient who came in the same month, 50-year-old female, ankle pain. She also had a chronic swelling over the heel, as you can see in the lateral picture. So we thought, okay, this looks like enthesitis or this is spondyloarthropathy again, but she wasn't responding to standard NSAIDs or sulfasalazine. So here we went in with the ultrasound, and this ultrasound here showed tophi around the Achilles tendon, which is not a common site. The gout in females presents a little differently. Most of the patients of gout are males. So when you have females with hyperuricemia and gout, they can present differently, and it may not be the classical podagra of the great toe. So again, as I said, history, examination, and ultrasound or X-ray may be important. Talking about imaging, the classical rat bite appearance, calcified tophi are seen very late. We have to catch these patients early. Erosions, etc. happen in gout much later. So if you have an opportunity, do aspirate the fluid wherever possible, but you have to have a polarized microscope, which is not available everywhere. But if you're in a bigger center, do it, and you have to take the sample immediately for examination. But MSK ultrasound, wherever it is present, it is there in all the teaching institutions. It's a good teaching tool. It has a role. Like this lady is a 38-year-old female. She was referred to me by the cardiologist for a young dilated cardiomyopathy, heart failure. She was on a diuretic and anti-failure therapy. So when she came, she was referred as a query, spondyloarthropathy, ankle joint swelling, but she had a uric acid of 10.2, which is probably iatrogenic because of the diuretic. And the ankle joint swelling and pain was recent, in 2 weeks. So we omitted the diuretics and we preferred indapamide, which causes less high uric acid. And you can see the ultrasound helped us here with the double contour sign, which is seen in gout patients. It's quite classical. So you put clinical and ultrasound features together. So if you have a center, that's fine. Otherwise, it's worth getting some people trained in this. It's a very useful investigation where you're not sure in ankle and foot arthritis. In cities, you also have DCT now, which is another good investigation where you cannot aspirate the fluid. So this sign corroborates your diagnosis of a gouty arthritis, where you don't have fluid to tap, you're not sure on ultrasound. 50-year-old female with multiple joint pain and swelling, 4 years. She came only with foot. She did not show me her hands. And we thought, okay, polyarticular gout, postmenopausal female. But when we did her X-rays, a lot of erosion, a lot of damage, in the X-rays. And then, like, I was just seeing the investigations further, and I said, "Haath dikhao." And then it was just, there was no doubt about it. She had extensive rheumatoid of the hands also. There were a lot of nodules. So severe erosive arthritis, a lot of talk about RA, when to stop biologics, how long to give. So in experience, what we find, 30% of the patients do well. They go into remission very early. They have palindromic rheumatism. 30% of the patients need that intensive 2 DMARDs, conventional plus biologics, and there are 20 to 30 who don't respond no matter what you do. They just go on progressing, So these are the patients where we struggle. They often are defaulters. They go to Ayurveda. They come back to allopathy. But so this is a one which is now chronic nodular RA also. With a lot of these are difficult to treat no matter what you do. And you can see the ultrasound also showed a high right hand tenosynovitis, a lot of uptake here. So RA in Indians is not often valgus, it is hallux varus, because most of our Indian females, males, they walk in the fields bare feet. So both are equally important. This is another important, interesting case. 50-year-old male, swelling of the left foot and ulcer over the hind foot, but no pain. So whenever you have swelling and something going wrong with the joint, but no pain, it should ring a bell. So this patient had a calcaneal fracture with the posterior and superior displacement. You can see it's a very interesting X-ray here. So this is a Charcot's arthropathy, which is still around, Charcot's arthropathy in diabetics, though we don't have much of tabes dorsalis or syphilis anymore. Another lady, this was referred to me, 71-year-old female diabetic, fever, hypoglycemia and dizziness, high creatinine, then they thought it is cellulitis, treated with IV antibiotics, but the swelling was persistent. So there was no pain. In spite of all this, she said, nahi, dukta nahi hai, chakkar aaya, to main gir gayi thi. And then we looked carefully at the x-rays, which were just kept aside for a day or two in the ICU because they were focusing on the cellulitis. So you all are the experts here. You can see shaft of the proximal phalanx of the great toe was fractured, and also there was a minor hairline, sort of thin fracture of the tibio-talar joint. So these two were missed for the first 1 or 2 days because the focus was on controlling her AKI, her sugar, infection, etc. And she had no pain because this was also a heavy diabetic with neuropathy and Charcot's joint. So whenever there is no pain, it should ring a bell. Is it a diabetic neuropathy because of which she has or he has no pain? These are some other classical x-rays, swelling of the third or the fourth digit, classical dactylitis. So you should ask for fever, loose motions, UTI. There could be peripheral spondyloarthropathy. Other causes of dactylitis means swelling of the entire digit. It could be the hands, it could be the toes, fingers or the toes. So reactive arthritis, sarcoid and psoriatic arthritis. So look for hidden sites of psoriatic lesions. As I said yesterday, lower hairline, in the gluteal cleft, in the umbilical region, behind the ears. So the diagnosis and the treatment also depends on that. If you see a patient like this, so you should, yesterday I think we discussed balanoposithitis with spondyloarthropathy, etc. So when you have keratoderma blenorigica, it could be again a variant of SPA. Again, you can see that swelling of the fourth toe. This patient again came just with swelling and rash, etc., but had extensive psoriasis. So again, ankle, when they just show the ankle and the foot, you have to see the other parts of the body because there could be lesions elsewhere. This is interesting, 10-year-old female, pain in the right foot. But you know, can anybody see this? There's a AVN, avascular necrosis of the navicular bone. So this is sometimes missed. So it could be AVN, can be because of steroids, can also be because of lupus, sickle cell disease. So when you get avascular necrosis of a particular bone, think of doing a sickle cell testing, look out for vasculitis. Steroids may or may not be given to these patients. So AVN or osteonecrosis is an important part in the foot also. You have a second bone, a first bone disease, you have metatarsal head. So sometimes they have, ladies are wearing high heel shoes, you know, with really high heels. So they can get this head of the metatarsal AVNs. So all this history is important. All that is swollen in the foot is not an inflammatory arthritis. It could be anything. And this patient is, I think, my last case here. So 15-year history of ankle, foot swelling, recurrent knee pain, 33-year-old male. He was labeled as CRMO, chronic recurrent multifocal osteomyelitis, referred by my colleague. He's a foot surgeon in Pune, an excellent ankle and foot surgeon. So he said it looks like just CRMO, but you see he's just getting it. So I said, fine. So there was pus here, so they aspirated. You can see the surgery was done. The fluid was looking like that, so it was thought it is septic arthritis. But why would he get septic arthritis? He was not on steroids. He was not on any immunosuppression also. So they did a tissue biopsy, and I told him, you please send for tuberculosis. So fluid AFB was seen, there was caseous necrosis, the histopathology also confirmed. So if you have one diagnosis, the old teaching which our professors also taught, fit everything into ek diagnosis mein tum sab karo, but it is not that way. Many things go parallel. Patients don't walk out of textbooks, you know. So you have to think of many times 2 or 3 things. So this patient had to go to Germany actually. So he came back, I'm not able to go because of this. So he took antituberculous drugs and we gave him for a long time, and now he's doing very well. Another 28-year-old male referred to me by my orthopedic friend, and pain and swelling of feet and ankle. he kept getting these funny lesions on his feet, you know, it was oozing like serum. He did a biopsy which showed livedoid vasculopathy. This can again be very challenging to treat. So treatment of livedoid vasculopathy is a lot of trial and error sort of a thing. But finally, he luckily responded to rivaroxaban and nifedipine combination. And when you see something like this, gangrene, lot of rash, the lacing, interlacing, don't wait for anything. Just refer to a physician or a rheumatologist, because these are vasculitis patients. They are not simple arthritis patients, because they get complicated, they get diffuse alveolar hemorrhage, they go into acute kidney injury. To sum up, whenever you get ankle or foot pain, arthritis, duration, acute, chronic, those are the causes of acute chronic arthritis, inflammatory, non-inflammatory, with or without backache. Is it periarticular or is it the joint? Is there a connective tissue disease or no? Is it unilateral, bilateral? Then again the cause. Bilateral is often rheumatoid, remember that, or a spondyloarthropathy. Where is it involved? Which part of the foot? Is it the MTP? Is it the toes? Is it the ankle? Is it the forefoot? And as I said again, skin, eyes, genitourinary and bowel symptoms. And always rule out osteomyelitis, which is infection usually, Charcot's arthropathy, and avascular necrosis, the rare causes. And if there is a gangrene, don't wait, just refer, because vasculitis can be life-threatening. Thank you so much.
Thank you, Dr. Kavita. The next speaker is Dr. Ishan Misra, extra-articular manifestation of rheumatoid arthritis.
Good morning to all of you. So rheumatoid arthritis is not just a joint disease. In 30 to 40% of the patients of rheumatoid arthritis, at some point of time they will develop extra-articular manifestations. The significance of extra-articular manifestations is that these are the predictors of premature mortality. They indicate active and severe disease. They indicate the need of aggressive management, and there should be a focus on prevention of organ damage. You can see here the survival rates of patients with patients of RA with extra-articular manifestations is low compared to the patients of RA without extra-articular manifestations and with the general population. A lot of extra-articular manifestations of rheumatoid has been described according to the organ system. We'll discuss some major ones. Very important, coming to the cardiovascular disease, there is studies after studies, there is a significant evidence that there is a greater risk of cardiovascular disease, heart failures and stroke event in RA patient. CVD is the leading cause of death in RA patients. Patients of RA have 48% increased risk of cardiovascular incidents compared to general population. And these increased risk is not fully explained by the traditional risk factors. Rheumatoid arthritis itself is an independent risk factor for cardiovascular disease. Why is it so? It has been prophesized that it is due to the residual inflammation in rheumatoid arthritis, which leads to endothelial dysfunction and hence more cardiovascular diseases. Sorry. Also, other cardiac manifestations like pericarditis and myocarditis are seen, which are rare. Heart failure, very important, is twice as common in RA patients compared to non-RA patients. It is more heart failure is attributed to, again, the residual inflammation in RA. Increased inflammatory markers is associated with 8% more risk of heart failure. Also, it is attributed to chronic use of anti-rheumatic drugs, mainly glucocorticoids. If used more than for 6 months and more than of 7.5 mg prednisolone, it will increase the risk of heart failure in RA. A lot of pulmonary diseases have been described in RA, but the most important and the most common ones are interstitial lung disease. RA, rheumatoid arthritis associated interstitial lung disease, the risk factors are older age, male population, smoker, patients with active synovitis and high seropositivity. High titers of rheumatoid factor more than 90 indicates higher risk for ILD, and also high titer of anti-CCP. Clinical features, mostly there will be older age group, and usually ILD will develop after 5 years of the rheumatoid arthritis diagnosis, but rarely this can be the first symptom as well. The symptoms are dyspnea on exertion and non-productive cough. Signs, there will be basilar crepes, presence of pulmonary hypertension, and rarely clubbing can be seen. The most important type of interstitial lung disease in RA is UIP pattern of ILD, and characterized by honeycombing on the HRCT with fibrosis and septal thickening and tracheal bronchiectasis. Coming to the membrane involvement, it is quite common, but most of the time it is subclinical. The symptomatic membrane involvement is seen in only less than 10% patients of rheumatoid arthritis. Rheumatoid nodule is the most common cutaneous manifestation. As discussed, occurs on the extensor surfaces, can occur in lungs and other internal organs, seen in smoker seropositive disease. It is an individual predictor of increased risk of CVD and all-cause mortality. Rheumatoid vasculitis, just discussed previously, very rare, seen in less than 1% of the cases, occurs in long-standing burnt-out diseases, most commonly involving the skin, but can involve other organs as well. In severe disease, the medium vessel vasculitis-like presentation identical to polyarthritis nodosa is seen. As previously discussed, the cutaneous vasculitis like nail fold lesions, non-healing ulcers, and gangrene should be urgently referred to to the rheumatologist. Also, rheumatoid vasculitis can present with neurologic symptoms like mononeuritis multiplex, a new onset of foot drop, a distal symmetric sensory sensitive motor and neuropathy, some ocular manifestations which we will discuss now. Rheumatoid arthritis can involve almost all layers of the eyes. Most common is in conjunctiva, keratoconjunctivitis, sicca, or the dry eye, episcleritis, scleritis, and keratitis as well. As dry eyes are seen in around 40% patients of RA, may be associated with SSA antibodies. The symptoms are, apart from dryness, foreign body sensation or gritty or sandy feeling in the eye, burning and photophobia. Diagnosis can be done by Schirmer's test and slit lamp examination by the ophthalmologist. Episcleritis, usually mild, abrupt onset of inflammation in episcleral layers, associated with redness and irritation and watering. Usually vision is preserved. Most patients have a mild disease and self-limiting. It can be classified as simple or nodular. Scleritis, whenever present, it is more severe. Constant boring pain which is worse at night around eyes, radiates to face and periorbital region. Any ocular movement will worsen the pain. Urgent referral to a rheumatologist and ophthalmologist is required to preserve the vision and has a more ocular morbidity. Necrotizing scleritis is a dreaded ophthalmic complication, and advanced necrotizing disease can cause scleromalacia perforans, and which can cause perforation of the sclera. And with the advent of better drugs, these complications are becoming rare and rare. Corneal inflammation. It usually occurs in association with scleritis, but sometimes without it. Corneal melt is characterized by collagen breakdown, by significant swelling of the corneal matrix. And there are various stages and various types, but fortunately the incidence is very less due to newer agents, especially anti-TNFs. Kidney disease, direct effects of RA are very rare, mainly focal glomerulonephritis and the effects of rheumatoid vasculitis. But one observational study has shown that serially, if you see over the years, the rheumatoid patients will have decreased GFR as compared to non-RA patients. And it is also attributed to long-standing inflammatory process, sometimes secondary amyloidosis, and due to chronic overuse of drugs like NSAIDs and cyclosporin. Very often hematologic abnormalities are seen. The most common is anemia of chronic disease, which is normocytic, normochromic, and usually resolves with the disease activity. And some drug-mediated anemias by methotrexate and leflunomide. Neutropenia is mostly drug-related, but if it persists, it can indicate myelodysplastic disorders. High WBC usually corresponds to high disease activity, but more than 15,000 is uncommon, can be reactionary due to glucocorticoid use. High eosinophil, again, corresponds with disease activity and some organ involvement. Thrombocytosis is same, and thrombocytopenia is very rare and mostly due to drug-related causes. Felty syndrome, very important extra-articular symptoms, now seen very rarely, is a triad of rheumatoid arthritis, neutropenia, and splenomegaly. It occurs in long-standing and seropositive deforming RA. Patients of Felty syndromes are more prone to bacterial infections because of neutropenia, and they are higher risk of malignancies in Felty syndrome. If you follow up the patients of RA, you will see there is more risk of hematological malignancies. These are attributed to chronic immune dysregulation or chronic immune activation, twofold higher risk, and some theoretical association with certain drugs. There was this study which showed that compared to the low disease activity in RA, there is 7 times more risk of lymphoma development in the medium disease activity, and 70 times more risk of lymphoma development in the high disease activity. So muscle weakness, also very common in RA patients, attributed to directly due to synovial inflammation, and which leads to diminished joint movement and muscle atrophy. Also can be drug-induced myopathies, like use of glucocorticoids, rarely with statins and hydroxychloroquine. With this, I will end my talk. The conclusion is we need to recognize extra-articular manifestations will be present in 30 to 40% of the cases. They will indicate higher mortality and morbidity in RA patients. They should be actively sought out, and the disease should be maintained aggressively. Most often of the times, these patients are poorly controlled RA patients. You will have to understand that these patients have more cardiovascular risk. They are more likely to die earlier in coming 10 years. So management aims at control of disease activity and should be actively managed, as it may be associated with high morbidity and mortality in RA. Thank you.
Thank you. Dr. Syamasis Bandopadhyay, Spondyloarthropathy Management.
Our next speaker is Dr. Smriti Ramatage. Kindly come to the dais.
So good morning to all. I would be talking about fibromyalgia today. Yesterday only doctor had asked regarding one patient who comes with pain but you find nothing, no synovitis, nothing. So fibromyalgia are these patients whom we miss out and sometimes label as psychosomatic and just try to get rid of them. So fibromyalgia is a chronic condition which is characterized by widespread muscle pain, fatigue and tender points. Up to 8% of the population is affected, and most of the population affected is women and diagnosed between the ages of 35 to 45. The various risk factors: genetics, traumas, physical trauma, emotional trauma, infections, these are the theories. Hormonal changes, especially menopause, autoimmune diseases. It's a common association with autoimmune diseases like rheumatoid, Sjogren's and lupus, and stress, which is a very important precipitating factor. So now fibromyalgia rather than might go into the neurologist domain in few years because it is strongly linked to the brain. Brain connectivity and neurological disorders are, research suggests that it is linked with altered brain connectivity and neurotransmitter imbalances. Then there is a central sensitization in fibromyalgia, and study confirmed that the brain amplifies the pain signal. There is an amplification of the normal pain signal by the brain, and that is causing fibromyalgia. what you can perceive as normal, the fibromyalgia patient perceives at a bit higher level. So the perception of the pain is higher in these patients. And then there is this gut-brain axis in fibromyalgia, where the theory is that there is an alteration in gut microbiome which contribute to the symptoms. So altered brain connectivity, central sensitization and amplification of the pain signals, and the gut-brain axis, reduced beneficial bacteria of the gut, gut symbiosis, and impaired gut barrier. Neuroinflammation, then neurotransmitter imbalances, increased glutamate, reduced serotonin, altered dopamine, and raised substance P, and hormonal imbalances. Now these are the patients who come to the OPD with widespread pain. The patient is complaining of only pain, and you feel how severe is the pain. But when we examine, there is nothing. There is no synovitis, there are no inflamed joints, but the patient is complaining of pain. And if you touch anywhere, the patient has pain. Now these are multiple tender points which are spread all over the body. Now if you ask this patient, they complain of severe fatigue. And on asking, they say there are sleep disturbance. Like a normal women coming to my chamber and saying कि यहाँ दर्द हो रहा, वहाँ दर्द हो रहा, वहाँ दर्द हो रहा है. And when you ask them, are you sleeping well at night? The usual answer will be no. For how long? For a few years now. I'm not sleeping well in the night. Now what is the indicator that you are not sleeping well in the night? So you ask the patient, are you getting up fresh in the morning? So when you are getting up fresh in the morning, it means that the quality and the quantity of sleep is good. But when the patient says that, no, I'm not getting up fresh in the morning, it says that there are sleep disturbances. Now this is the first thing which might help you in clinching the diagnosis of fibromyalgia. Second question should be, are you stressed out? So stress is one of the, and the patient, usually a woman will say yes. And now this should not be labeled as psychosomatic. When she's saying that she feels stressed out, we need to validate it and we need to give it importance. And the third thing is excessive fatigue. So these patients feel tired all the time. So waking up is a task, doing any household work is a task, doing anything is a task. It's like just you are, pulling through every day. It's an effort. So they have a lot of sleep disturbances, cognitive issues like difficulty in concentrating, memory issues, mood changes, anxiety, depression, and mood swings. And a lot of these patients have linked to obsessive compulsive disorder, especially they have a finicky for cleanliness. A lot of women, when we ask them, they have like this, the perfectionist tendencies and a finicky thing for cleanliness. And they have a lot of 70% around have associated headaches and migraines and irritable bowel syndrome. So they are regularly visiting either a neurologist or a gastroenterologist or a rheumatologist or an orthopedic surgeon. So these are these patients can go anywhere and usually are not diagnosed. So they can come with headaches, sleep disorders, dizziness, cognitive impairment, anxiety and depression, visual problems. Usually they have issues with the TM joint. So patient coming to you with TM joint pain or coming to a dentist with TM joint pain, which is not pathological, could be fibromyalgia. Fatigue, joint pains, chest pain, stomach, they can have varied disorders. So widespread pain, multiple tender points, fatigue, cognitive issues, sleep disturbances, mood changes, anxiety, depression, headaches, migraine, and irritable bowel. This is a wide spectrum. And usually the patient has been going from one doctor to other and they think कि आपको कुछ नहीं है, हमारे पास आपके लिए कुछ नहीं है, आप पूरी तरह से normal है, आपका सब report normal है, आप भी normal दिख रहे हो, you don't have anything. So the revised 2016 ACR criteria says that the widespread pain index. So initially we were looking for the tender point, now this is the widespread pain index. 1 point for each area affected in the last 2 weeks. A symptom severity score of 0 to 3, fatigue, waking unrefreshed, cognition, general somatic symptoms. 0 is no problem and 3 is a severe and continuous problem. So these are the tender points: back of the neck, front of the neck, upper back, lower back, shoulder, chest, hips, elbows and knees. So examine these tender points. Now if this patient has around 14 tender points, this is definitely fibromyalgia. So patient is not getting up fresh in the morning, there are sleep disturbances, patient has stress, patient has fatigue, and patient has multiple tender points, can clinch the diagnosis of fibromyalgia. But get a alkaline phosphatase because osteomalacia is one of the closest mimic. Get a CPK because this patient could be having myositis. And unless and until we do the CPK, we do not know that. Get a ESR and CRP because there could be some simmering rheumatological problem which we are not able to identify. Most of the patients with hypothyroidism have it as an association. So get a thyroid, vitamin D and B12. Vitamin D and B12, you all know that it comes in varied presentations. Deficiency of vitamin D and B12. Now, for managing these patients, the first thing is you need to know the patient. So I know you are all busy orthopedic surgeons and it's difficult to give time to something which is non-surgical. But just giving 5 minutes to the patient and talking to the patient, just asking whether she has lot of stress and whether she has a good sleep. These are two very, very important things. क्या आप सुबह फ्रेश उठते हैं, नींद अच्छी होती है क्या? And the second is थकान होती है क्या? Third is तनाव है क्या? These are the three things which are, simple to ask. But if you ask it, you can clinch the diagnosis of fibromyalgia, and I am very sure, like, if you are seeing 100 patients in a day, 20 of them, around 20 to 30% could be falling into this category. So exercise is one thing which helps the patient. Cognitive behavior therapy and reduction of stress. You can, if you are not able to counsel her, you can ask her to take the help of a counselor, and a sleep hygiene, avoiding caffeine at night. Antidepressants, SSRIs, duloxetine, milnacipran, which is again an antidepressant, have been recommended. Tricyclic antidepressant, amitriptyline, we can use in a lower dose because it changes the pattern of sleep. It increases the depth of sleep. As the depth of sleep increases, the patient wakes up fresh. So small dose 10 milligram or 5 milligram of amitriptyline can help this patient. Pregabalin and paracetamol. Alternative therapies are there. So physiotherapy, good quality of sleep, breaking up activities into chores. So these patients actually they see the whole thing in one go, like the whole day comes in front of them. So you have to counsel them, they take one thing at a time, take as much as you can. So slow down and take it easy. Do not expect too much from yourselves. CBT, complementary therapy and medications. These all are the pillars for treatment. So these are the emerging treatments for fibromyalgia. So this is our study where we studied the clinical features, sociocultural characteristics, sleep pattern and depression in fibromyalgia patients from India. And we had around 121 patients, and most of these patients they were married and they lived in nuclear families and were middle to upper class. Contrary to existing literature which says that higher prevalence of fibromyalgia has been observed in patients with high educational status, we had patients from middle class. And most of them had headaches, difficulty concentrating, fatigue. So these patients had, most of them had tender points, they had widespread body pain, fatigue, waking unrefreshed, arthralgias, difficulty in concentrating, feeling low energy during the day, 69%, irritability, feeling depressed, acid peptic symptoms and abdominal cramps. 100% of these patients had daytime sleepiness, so they took small naps in the day. Most of the patients had a habit of taking naps in the day. Daytime somnolence was in a lot of patients. Snoring was present. Most of the patients woke up at night and the sleep duration was reduced. Most of the patients had depression, which was associated. 50% had mild depression, 6.6% had severe depression, and 24% had moderate depression. So only of them 17.5% had no depression. So that says something about the patient who is coming to us with pain, but no evidence clinically of any rheumatoid or no synovitis. So we need to be alert about the possibility of fibromyalgia after ruling out that there is something sinister underlying, and help the patient If there is underlying depression, we can help the patient with an antidepressant. So just because you can't see my pain doesn't mean I have to validate its existence. So the patient tells you she has pain. Usually they are women, and women are usually ignored for pain, that this is something psychosomatic, which is a very broad label, which should not be done. And we need to listen to the patient, ask for stress, see for depression, ask about easy fatigability, ask for sleep problems. You look fine, that's how I look, but that's how the patient feels. So we need to assess that. And these are the famous people who are suffering from fibromyalgia and living with it. Thank you.
Dr. Syamasis Bandyopadhyay.
Thank you, chairpersons. Thank you, organizers and friends from Patna and all across India. Now, spondyloarthropathy, on which we are having a short discussion now, is a spectrum of conditions in one big umbrella. It encompasses undifferentiated SPAs, psoriatic arthritis, juvenile SPAs, the well-known ankylosing spondylitis, arthritis associated with inflammatory bowel disease, and the very well-known reactive arthritis or post-viral arthritis. So key features of spondyloarthritis, which you have already been told before, is that it's a conglomeration of disease. It's not rheumatoid, so people often call it, I have got rheumatoid arthritis. Enthesitis, dactylitis, and arthritis are the hallmark, in contradiction to synovitis, which is there in rheumatoid arthritis. And there is an association of a gene, HLA-B27. We use a lot of instruments to assess spondyloarthritis as such, and one of the well-known and well-documented instruments are BAS-DI, which looks into the disease activity, the BAS-FI, which looks into the functional status. Then there is DFI, or Douglas Functional Index, both for function, and BAS-MI, which is also for function. And there is MSAS, which is the structural damage that it causes to the spine and beyond. Now, we all are in our busy practice. We find it very difficult to do these sort of instruments. So I've just made little notes on these activity scores, like BAS-DI, which is a self-administered instrument. And the questions are very simple, which we always ask people, but in a structured way, which is fatigability, tiredness, spinal or hip pain, then pain, swelling of joints other than the spine, level of discomfort, and how long the morning stiffness lasts. The BAS-FI, the functional thing, includes a visual analog score, and then some questions which involve ability to bend, looking over your shoulder, standing unsupported, rising from a sitting position, exercising, performing daily activities of living, and climbing 12 to 14 steps. As you can see from the questions we ask in a structured manner, these are the questions we ask them always. ASAS, which is the assessment of angstpon, improvement of more than 20%, an absolute improvement of 10 units. It's a patient's global assessment by a VAS score, pain assessment again by a VAS, then functional by BAS-FI, inflammation and absence of deterioration of the potential remaining domains. Now, overall, in a broader spectrum, spondyloarthropathy can be differentiated into two large groups, which is axial and peripheral. Now, axial is with radiographic sacroiliitis. We can be without radiographic sacroiliitis or marrow edema in the MRI of the SI joint, and HLA positivity plus the clinical criteria. Peripheral, one has to have some degree of search for psoriasis or the skin lesions, especially in the elbows, the knees, the palm and the sole, back of the ear, navel. These are the hidden areas where the psoriatic rash could well be there, and patients are hiding it because nobody wants to show off a skin blemish or a skin lesion when they are out from their home. So one has to be a little intrusive here to find it. Then the history of inflammatory bowel disease, because a lot of our IBD patients get hidden on the umbrella of IBS or irritable bowel, so one has to have a pointing and a history and investigations if needed to prove or disprove inflammatory bowel disease. Then history of preceding infection, and without psoriasis or inflammatory bowel disease or any other preceding infection, you can have peripheral arthritis as well. The treatment options are obviously non-pharmacological, like physiotherapy, rehabilitation. These are important processes which we doctors often miss, but are important, and regardless of what therapy we give, an exercise regime of appropriate nature is very important for the patient, like participation in swimming, etc. Pharmacological treatments, as we all know, can be either systemic or local. It is important to keep in mind uses of local agents like local steroids in areas of concern, which gives immense benefit to the patient at a very short interval without much systemic intervention. NSAIDs remain still the first drug of choice for pain and stiffness. One has to have a continuous NSAID for some time. On-demand treatment is acceptable for a group of patients who are in active life. There is no particular NSAID of interest, because we have seen that head-to-head trials of a lot of NSAIDs have done, and so far they have not shown any major benefit or otherwise in these regards. But one has to understand and keep in mind the GI, the renal, and the cardiovascular side effects of NSAIDs for prescription in such a long duration. Glucocorticoids. For patients with isolated local inflammation of sacroiliac joints, one or two peripheral joints, or enthesis or enthesitis, local glucocorticoid injections can be used sparingly. One point of caution is the Achilles tendon, where repeated injection of glucocorticoid can be extremely disastrous, but local injections in areas of concern is of immense benefit, as we all know. The long-term use of systemic corticosteroids is relatively contraindicated because of the risk of vertebral osteoporosis, and also the cardiovascular, renal, and GI side effects. But you know that in some patients with anterior uveitis or inflammatory bowel disease, systemic steroids or topical steroids or both are indicated. Now, biologic agents and small molecules, the JAK inhibitors. Biologic agents are of TNF-alpha, interleukins, and JAKis. For patients whose symptoms are not controlled with NSAID therapy, or for whom NSAIDs are unacceptable for side effects, the use of biologics are strongly recommended currently as per every protocol we go through. TNF inhibitors, we have got infliximab, etanercept, adalimumab, golimumab, and cetuximab pegol, which are the 5 TNFs currently in use. IL-17 blockers like secukinumab and ixazomib, and IL-23 blockers like ustekinumab. They are licensed for use in specific categories like secukinumab in psoriasis and psoriatic arthritis, ustekinumab in inflammatory bowel disease and IBD-associated arthritis, and JAK inhibitors have come out in real term in our country at least because of the cost issues involved and availability of cheaper versions or Indian versions of JAK inhibitors. Now the algorithms, which are based on asacelular recommendations for management of axial spondyloarthropathy, is pretty cumbersome. So this slide is quite, packed, and I guess you will not be able to see much from this slide. So if you pick up the phase 1, which is the top part of the slide, then we have a clinical diagnosis of axial spondyloarthropathy. Then we give them NSAIDs and titrate up to maximum tolerated dose associated with physiotherapy exercises, educations, and stop smoking alcohol, because we know that overall smoking has a negative impact on the axial spondyloarthropathy management and treatment and disease progression. And if we have sufficient response in 2 to 4 weeks, then we continue. If we don't, then we go to the next phase. So we consider local infiltration of glucocorticoids and for peripheral variety and very early axial variety, sulfasalazine can be tried. In asacelular recommendations or in Western Europe, sulfasalazine is not there in many of their recommendations, but we have got studies from PGI-MER in arthritis, International Arthritis Journal about sulfasalazine being used in very early part of the spondyloarthropathy spectrum. And then if it doesn't work, then we give TNF-alpha, IL-17 or IL-23 and JAK-I, and the current practice is essentially with TNF and IL-17. JAK-I, as I said, is picking up because of its availability and price issue. Where there is history of recurrent uveitis or active IBD, TNF is preferred, followed by ustekinumab, the IL-23 blockers, and IBD one. One should remember that if there is IBD-associated arthritis, then secukinumab is not indicated at all. Obviously, if we get sustained remission, then we look forward to tapering of these biological DMARDs over time. Phase 3 will be re-evaluation of the diagnosis, presence of other comorbidities, and then every 3 to 4 months assessment of the score and continue the treatment. Asacelular recommendation of axial SPAs, rheumatological diagnosis of axial SPA with elevated ESR, CRP, and positive MRI of the sacroiliac joint, bilar marrow edema, or with or without radiological sacroiliitis, failure of standard treatment, then all patients should be offered one of the biologic treatments. Peripheral SPAs, it's slightly different from the treatment of axial SPAs. NSAIDs remain mostly, NSAIDs remain one of the drug of choice with mostly local glucocorticoids in the first line treatment of peripheral manifestations, especially in larger joints and enthesitis areas. Several biologics and targeted synthetics, as we have mentioned, has been proven to be effective in these peripheral versions of psoriatic arthritis as a prototype for peripheral SPAs. Usually standard CDMARD treatment with methotrexate, sulfasalazine, leflunomide over a period of 3 to 6 months. If they fail, then the recommendation is to go for a biological DMARD. Now, JAK-I has started as a new category as a primary agent with methotrexate in our country as the cost-effective modalities of treatment available to our patients. Treatment decisions about patients with predominant severe enthesitis and dactylitis has to be made on an individual basis, and there is a consensus that biologic agents TNF targets are probably the first line drug of choice in many of the guidelines. The algorithm of PSA in the same format of phase 1 and phase 2, which we have discussed before, so I don't need to bore you with that. And then the question is how to monitor these SPA patients. They include patient-reported outcomes, clinical findings, laboratory tests, and imaging, and the frequency of monitoring should be decided on the individual purpose. There are some tests that are recommended to be done before initiation of biologic and JAK-I. hepatitis B, C, HIV, TB gamma gold, and or Mantoux test. And if Mantoux test is more than 10 and TB gamma is positive, either or, then we call it a latent TB, and a prior anti-TB drug should be given before the start of biologic or JAK-I. This is very important to keep in mind. Some special areas of concern which might interest you is that if there is a prior history of TB, then possibly etanercept or golimumab are preferred than other TNFs like infliximab or adalimumab. Otherwise, ustekinumab, secukinumab, and ixazomib has a higher chance, or has got a lesser chance of reactivation of TB in these situations. In situations of IBD-associated spondyloarthropathy, secukinumab is not recommended because it can unmask the IBD. If there's uveitis, then etanercept has not shown to be effective. Pregnancy up to date, cetuximab pegol was the only preferred choice, but recently there are some data coming up with ADA as well, which can be used in pregnancy. In psoriatic arthritis, where the skin involvement is predominant, secukinumab often remains the preferred drug of choice. Thank you very much. Thank you, sir.
I request Dr. Kavita Krishna ma'am, Dr. Isan Mishra, Dr. Syamasis Bandyopadhyay, and Dr. Smriti Ramteke to please come on the dais for discussion.
Now I think so many questions will come from the audience. All the speakers are here. Please put their questions.
Yes, my question is from Kavita ma'am. Ma'am, you have shown few tests for post-chikungunya.
Yes.
So, because we are getting so many post-viral arthritis, ma'am, but we do not go for any test, because is this test will change the management and how to manage the, because it is prolonged period and we used to give NSAID usually.
Yeah, so acute stages, no need to do any tests. If you're suspecting the acute stages, fever with joint pains, so arthritis. So it could be dengue, it could be chikungunya. So you routinely do whatever fever workup you want. Question is the joint pain more prominent? Rashes are classically day 2, 3, the rashes may start coming. The ankle joint gets swollen out of proportion to other joints, and knee joint is more swollen than the hand joints. So about 30% of them respond by week 2. They get better, nothing much happens, and they go. 80% of them come back with more joint pain, more swelling. So what I usually do, NSAIDs initially, I do not prescribe anything beyond paracetamol or tramadol, because the LFTs are deranged, platelets are a little low. And when this thing settles, fever goes away, then I can try naproxen. That works better than your etoricoxib. And that's what I prefer. I know many people prefer aceclofenac or diclofenac. I usually give etoricoxib or naproxen. And for 10 to 15 days, many of them respond very well. If there is no fever, pain is just too much, then a small dose of steroid also can be added once the fever is totally gone and they are not responding. So for I think 4 to 6 weeks, we just try to juggle around with all this. They get better, it's fine. Otherwise, then we add hydroxychloroquine. In fact, we are collecting data on our patients there. And you can give hydroxychloroquine, that a lot of counseling is required. Ki aapka ESR, CRP abhi bhi zyada hai, so you need to take more. And we have to taper the NSAIDs slowly. Do not hesitate to give for longer, because they're in real pain. Ankle and knee joint is swollen, they can't walk, they're limping all the time. So you give steroids, little low dose tapering. Low dose, not high dose. Naproxen also taper it slowly. Don't be in a hurry to stop it. If the creatinine and all is fine. And hydroxychloroquine, if you're not sure, get a fundus baseline done and give it for 3 months. Don't be in a hurry to stop it. If after 2 months it is still in pain and hand joints are more involved, then it is worth, like my patient, do a rheumatoid factor anti-CCP, because chikungunya could just be the start. It is actually underlying rheumatoid arthritis, and they have family history. Family history is very important. Mother, sisters, aunts, they have a family history of rheumatoid arthritis. So chikungunya was just the trigger.
Thanks, ma'am. Thanks all the faculty for a wonderful teaching. I have a question from Dr. Smriti regarding fibromyalgia. It's a real diagnostic dilemma whether it is the case of fibromyalgia or else. So what are the, besides all the text, what are the key points in clinic for good diagnosis whether it's a case of fibromyalgia or else. What are the key points? What will be the basic treatment protocols in our clinic?
So when the patient is coming with lot of aches and pains, a young woman coming to your clinic with lot of aches and pains, and you ask the patient, she says this pain all over, and you feel that there is some inflammatory condition like rheumatoid. But when you examine the patient, you find nothing, except for wherever you are touching the patient, she has pain. The joints are all fine. So that is the first place where you should suspect it. Second, if the patient on examination she has tender points, and then you ask the history, she says, I don't sleep well, and for years together I have not been sleeping well. When I wake up, I am not fresh. That's the most important thing. How are you waking up? Are you feeling fresh when you wake up? No, I am not feeling fresh when I am waking up. That's the second thing. And third is there a lot of stress? Are you taking lot of? There might be no stress, but she is perceiving stress. So that is the important thing. The patient's husband might say there is no stress at all. You know, isko kya stress hai? But the patient is feeling lot of stress. Now that is one place where you should see that this patient probably needs help. She is not able to deal with whatever life has put on in front of her, or her day-to-day activities. And the fourth is lot of fatigue, thakan. That is a very important thing. Now all these four factors, if they are there, and then you see if the patient is vitamin D and B12 deficient. So if it is there added, please correct it. Check the ESR CRP. It is normal, you need not worry. And see for osteomalacia. See the alkaline phosphatase calcium. So if it is fine, now this patient is fibromyalgia. Check for the, just check out for the tender points. You can just check in the books how to check the tender points. See if the patient has multiple tender points and all these things are coming together, then this patient has fibromyalgia. Low dose amitriptyline, pregabalin, duloxetine, paracetamol for some time, like few months, around 2 to 3 months, and then you can taper it off, plus exercise, plus behavioral therapy. You can yourself counsel the patient about taking less stress, organizing her things into smaller versions, you know, rather than looking at it as a whole, a very big stressful thing, maybe breaking down things, and counseling regarding sleep, changing the sleep pattern. With the advent of mobile phones and all, till late people are on phones, and the sleep time is deprived. So it's both the quality as well as the quantity of sleep which is compromised. So you have to counsel the patient about that. And exercise plays a very important role.
Thank you. So the key points will be unspecified stress and fatigue. So is there any minimum criteria for the tender points? How many tender points we have to check?
14.
14. Thank you. Thanks a lot.
Excuse me, ma'am. My question from the Smriti, ma'am. Ma'am, many patients you said that there is the suffering from the irritable bowel syndrome in fibromyalgia.
Yeah.
So can you treat separately the irritable bowel syndrome, or itself it's going after treating the fibromyalgia?
No, these are
prebiotic, probiotic you can add?
Yeah, you can definitely add. You can use, you've seen that there are many upcoming studies about the role of probiotics in fibromyalgia because of the connection with the gut and the gut microbiome. So irritable bowel syndrome, migraine, tension headache, anxiety, depression, and TM joint pains. These are all associations with fibromyalgia. Fibromyalgia, and the patient can have irritable bowel syndrome. Most of the patients may have irritable bowel syndrome. It's again because it can be traced down to the stress.
Mostly female are suffering from the fibromyalgia.
Yeah.
Is there any hormonal connection, because there is in perimenopausal time, there is the increase in incidence in females. Or after childbirth, there is the certain spurge of the incidence of the fibromyalgia. There is the hormonal any connection?
There is a definite hormonal connection because perimenopause, menopause are the times when they get it. Secondly, childbirth, another thing which happens during childbirth is that after childbirth, the women doesn't get to sleep as well as she used to sleep previously. So there is always a compromised time for sleep after childbirth, after you have children. And then after few years, it is never restored back. That pattern remains, that is carried forward and not corrected. That is one of the contributory things. Yeah.
Ma'am, role of flupritine in fibromyalgia?
Sorry?
Flupritine, flupidol, flupritine.
Yeah, I use a lot of flupritine and it has excellent results.
How long we can use safely?
We can use for 3 to 6 months, not a problem.
Thank you.
So thank you all the speakers, thank you all the delegates for the nice involvement, nice presentation and nice discussion. Now we conclude this session. Over to the next session.
Thank you all for a wonderful session. Thanks all the chairperson for the same. So continuing the same discussions, now it's time for the wonderful interactive Aarcon ki Adalat. So I invite Amolya sir, SS Jha sir for the same. To Gas.
Now for time for Aarcon ki Adalat, I request Dr. SS Jha sir and Dr. Amolya sir. Sir, please call Dr. SS Jha sir. Chair.
यानी मुंबई से हैं और डॉक्टर राज किरण हमारे हैदराबाद से। सो रिस्पेक्टेड जस्टिस डॉक्टर एस एस झा सर, आप आज्ञा दे तो कार्यवाही शुरू की जाए। सर थैंक यू सर। और everybody knows this detail that RA affects 0.5 to 1% of the adult population. In India, prevalence rate is about 0.7%, 5%. Prevalence in women is 2 to 3 times greater than men. The first allegation जो आप पे आ जा रहा है sir, there are large number of patients but very few rheumatologists in India to manage the problem. And you people, only the rheumatologists feel that you can manage all the patients of India. About 1 crore population, can you manage?
माननीय महोदय, आरोप तो पूरा गलत ही है। तभी तो आपने हमको यहाँ बुलाया, आपको सिखाने के लिए कि आप आर्थराइटिस किस तरह से ट्रीट करें। और हम माने और हम आए और हम सिखा रहे हैं और सालों से सिखा रहे हैं। हमारा प्रॉब्लम ये है कि जब शिष्य बन के बैठे हो तो कुछ सीख तो लेके जाओ। हम तो सिखाने बैठे ही हैं, हम कभी नहीं कहते कि ये है। हमको हमारे गुरु ने सबसे पहली बार जब हमने ये वाक्य उनसे कहा था कि सर ऑर्थोपेडिक सर्जन एक सर्जन होता है। फार्मेकोलॉजी की टेक्स्ट बुक सेकेंड एमबीबीएस में पढ़ने के बाद कभी किताब खोलता नहीं है और उसके बाद ऑपरेट करने के अलावा और कुछ करता नहीं। तो आप कैसे उनको मैनेज कराओगे? तो सर ने मुझे कहा था, बेटा जितना सिखा सके सिखा दे, क्योंकि सारे पेशेंट जब तेरे पास आए ना तो तू तो वैसे ही मर जाएगा।
थैंक यू। पहले आरोप को आपने अपने तरफ से सिद्ध किया है कि ऑर्थोपेडिक सर्जन्स को आपसे सीखना है। और जो इस तरह के जो प्रॉब्लम्स आ रहे हैं, कल से हम लोग देख रहे हैं, जनरली दीज पेशेंट्स कम टू ऑर्थोपेडिक सर्जन्स ओनली। सेकेंड एलिगेशन जो हमारे तरफ से एक कोर्ट में हम आप पे लगाया जा रहा है वो है rheumatologists have less faith in credibility and talent of orthopedic surgeons. ये तो बात है सर, आप क्या इसमें सफाई देना चाहेंगे?
इसके जिम्मेदार तो खुद ऑर्थोपेडिशियंस हैं। सो ऑर्थोपेडिशियंस दे themselves और कॉज रीजन फॉर दिस। उनके ऊपर जो क्रेडिबिलिटी नहीं है। क्यों बोले तो बिकॉज वी सी लॉट्स ऑफ प्रिस्क्रिप्शंस वेयर ऑर्थोपेडिशियंस राइट प्रिस्क्राइब मेडिकेशंस वेरी रैंडमली। जैसे ऐसे ऐसे कॉम्बिनेशंस लिख के देते हैं, वो हम देखकर हम सोचते हैं तो ये तो बहुत ही टॉक्सिक प्रिस्क्रिप्शन है, ये तो इतना डेंजर प्रिस्क्रिप्शन दिखता कभी कभी। तो उसमें काफ़ी सारे जो रूमेटोलॉजी का ड्रग्स रहते हैं वो पूरे के पूरे रहते हैं उसमें। इफ़ यू सी कुछ पेशेंट आते हैं RF पॉजिटिव, उसको इधर दर्द रहता है, वो प्रिस्क्रिप्शन लेके आता है, उसमें मेथोट्रेक्सेट रहता है, लेफ्लोनामेड रहता है, यूग्रोटेमोड रहता है, टोफासिटिनिब रहता है, एसिक्लोफेनाक रहता है। और उसके बाद में कुछ वो प्रिस्क्रिप्शन लेके हमारा पास आता है तो फिर हमारा पास कुछ रहता ही नहीं दवाई देने के लिए। जब इन डिटेल अभी आ रहे हैं मेथोट्रेक्स, अरे डॉक्टर साहब ये तो मैं लिया, अभी मैं ऑलरेडी लिया ये दवाई, तो कुछ काम नहीं करा, अभी कुछ और दो। तो इसमें क्या होता है ना, मोस्ट ऑफ द ऑर्थोपेडिक प्रिस्क्रिप्शन समटाइम्स एज डॉक्टर कौशिक सेड कि एजुकेशन क्या होता है ना, बिकॉज ऑर्थोपेडिक सर्जन्स आर सर्जन क्या होता है ना, सर्जन अपना हुनर बढ़ाने के लिए देखता है, वो ही विल ट्राई टू मास्टर इन हिज सर्जरीज, क्योंकि उसी में ज़्यादा पैसा मिलता है। तो लिखने में तो कम ही लिखता है, तो फिर वो अपना स्किल बढ़ाने के लिए देखता है TKR THR। इसमें क्या होता है ना, ये एड ऑन है, दिस इज़ व्हाट मोस्ट ऑफ अस फील, ये एड ऑन है सर्जन के लिए। तो फिर दे फील लाइक इसको देखो, एक कहाँ सुन लिया तो मेथोट्रेक्सेट काम करेगा, कोई कंपनी वाला बोल दिया सर टोफासिटिन रिजल्ट बहुत अच्छा है सर, अभी आप एक ट्राई करके देखो। जैसे ये कोई साबुन है, शैम्पू है या परफ्यूम है, अभी ट्राई करके देखो, तो कंपनी वाला बोलता है कि सर ये जरा ट्राई करके देखो, तो देन ही विल ट्राई एंड सी, क्या किसके ऊपर, पेशेंट के ऊपर। एंड दैट काइंड ऑफ पेशेंट्स व्हेन दे बिकम सिक एंड कम टू अस, एंड हमको कैसे, आफ्टर ऑल वी आर ऑल्सो ह्यूमन्स, हम भी लाइक हमको ऐसा लगता है कि कोई पेशेंट का ऐसा हालत ख़राब हो गया, ऐसा कुछ ऐसा वो देख के ऐसा लगा, तो फिर वी ऑल फिट। मतलब जो ऑर्थोपेडिक्स है जो कैजुअली लिख देता है, चलो एक नहीं तो एक तो काम करेगा, कभी मेथोट्रेक्सेट काम नहीं करेगा तो टोफा काम करेगा, अगर रेसिक्लोफेनाक काम नहीं करेगा तो फिर समथिंग एल्स विल वर्क। सो ऐसा कॉम्बिनेशन देखते देखते सम ऑफ देम, आई डोंट से एवरीबडी बिकॉज देर आर वेरी गुड पीपल हियर, ऐसे अगर कोई ग्रुप में ऐसा कुछ प्रॉब्लम है तो इट इज़ नॉट लाइक दैट एंटायर ग्रुप खराब है। इसमें आई पर्सनली फील अगर कोई अपना लाइक अपना प्लांटेशन में कोई प्लांट खराब है तो फिर इट बिकम्स आवर रेस्पॉन्सिबिलिटी टू करेक्ट इट और रिमूव इट।
थैंक यू सर। आप अपने उत्तरों से हमारे जितने भी ऑर्थोपेडिक सर्जन्स हैं उनको आप उनका मनोबल तो गिराते जा रहे हैं, पर संसार में इस तरह के मरीज सड़कों पे घूम रहे हैं। और जो तीसरा आरोप पे आप पे आता है, you always blame us because this was managed by orthopedic surgeon. That's why I'm telling. After seeing these types of badly managed patient society, but I would say, but luckily Dr. Kaushik ने पहले इसका आंसर दे दिया. Now next, what is your plan? How will you train us further?
ये जो अदालत चल रही है, एक्चुअली इस हॉल में होने की बजाय टीवी पे होती तो ज़्यादा मज़ा आता, क्योंकि यहाँ पे जितने ऑर्थोपेडिक सर्जन बैठे हैं उनके इरादे कितने नेक है वो तो जाहिर है, तभी तो वो लोग आए हैं। गलत लोगों के सामने हमारा तर्क हो रहा है। फिर भी आप लोग सुन लीजिए, अगर जो आप ट्रेन होना चाहते हैं, और ये मैं आपको 3 उदाहरण दूंगा मेरी 20 साल की प्रैक्टिस में। मैं पिछले 12 साल से रूमेटोलॉजी स्टूडेंट्स को ट्रेन कर रहा हूँ। मैं महाराष्ट्र यूनिवर्सिटी ट्रेन्ड फेलोशिप टीचर हूँ। एंड मुझे ऑर्थोपेडिक सर्जन्स के कॉल आए कि मुझे रूमेटोलॉजी प्रैक्टिस करना है। मैंने कहा बेशक आइए, टीचिंग इज़ फॉर ऑल, विद्या सबके लिए। लेकिन उनकी कंडीशन ये थी कि हम हफ्ते में 2 बार 1-1 घंटे के लिए आएंगे। अब जिस शास्त्र को सीखने के लिए आपकी ऑर्थोपेडिक्स का मैं उदाहरण देता हूं कि आपने 10 साल पढ़ाई करी, उसके बाद आपने फेलोशिप करी, उसके बाद आप किसी गुरु के नीचे सीखे, उसके बाद जाके आप किसी हेड ऑफ डिपार्टमेंट की हेल्प लेके अपनी स्किल बढ़ाते रहे। लेकिन आपको रूमेटोलॉजी जो उससे भी वास्ट है उसको हफ्ते में 3 बार 1-1 घंटे आके सीखने के बाद आपको रूमेटोलॉजी प्रैक्टिस करना है। मैंने आपको कल एक उदाहरण दिया था कि वर्ल्ड के सबसे टॉप मोस्ट, और बाय द वे फॉर योर नॉलेज ही इज बिकमिंग द नेक्स्ट प्रेसिडेंट ऑफ द यूरोपियन लीग अगेंस्ट रूमेटिज्म। दिस जेंटलमैन इज एन ऑर्थोपेडिक सर्जन and he is given up orthopedics. He fell in love with rheumatology. You can look it up. aapko jo kal, I think was it Ishan showed one of the quotation, one of the papers, aur usme the very first author was his name, right? Ishan, you showed Xenophon's paper, right? This gentleman is an orthopedic surgeon. He has devoted his life to rheumatology. कितने आना चाहते हैं मैदान में? सबको मैं अकेले ट्रेन कर दूंगा, आ जाओ। हमारी एमडी के बाद हम 3 साल डीएम रूमेटोलॉजी के लिए करते हैं। क्यों? शौक है हमको, पागल हैं क्या? ऊपर से फेलोशिप जो 3 साल 2 साल नहीं कर सके उसके लिए 2 साल की फेलोशिप है, तब जाके आप रूमेटोलॉजी प्रैक्टिस होने के लायक होते हैं। यहाँ पे मेरे पास ऑर्थोपेडिक सर्जन कंडीशंस रखते हैं, हम हफ्ते में 3 बार आएंगे 1-1 घंटे के लिए। क्या सीख लोगे आप? So the challenge is not that we don't want to train. The challenge is you don't want to be trained. You want to do it at your conditions, which means you will operate, you will earn your money, you will do whatever, and conditionally you will keep a patient. Now I am going to tell you one very bad incident that happened many years ago. This is very rare, very uncommon, but this happened where an orthopedic surgeon was telling a friend of mine that तुम्हारे पास भेजेंगे, पेशेंट हमारे पास ही पहले आता है, तुम्हारे पास भेजेंगे तो तुम ठीक कर दोगे, तुम ठीक कर दोगे तो हम क्या ऑपरेट करेंगे? Can you beat this? Is that the attitude? That's not the attitude of you people sitting in the hall, which is why I said that this is very uncommon and very rare. लेकिन ये सेंटेंस मेरे खुद के करीबी दोस्त ने सुनाए है ऑर्थोपेडिक सर्जन से. ये एटीट्यूड तो नहीं है. आप और हम दोनों एक ही थाली में बैठे हैं, हम दोनों उसी टाइप के पेशेंट देख रहे हैं, हाथ मिला के काम करते हैं. थोड़ा हम हाथ बटाएं, थोड़ा आप बटाइए, तब जाके पूरी इंडिया के पेशेंट्स ठीक हो जाएंगे. क्यों नहीं होंगे?
डॉक्टर कौशिक, आपकी बातें आज के ज़माने के लिए तो बहुत अच्छी है, पर अगर देखा जाए तो जिस तरह से ऑर्थोपेडिक सर्जन इतना मेहनत करके आगे बढ़ना चाहता है, तब भी समाज में जिस तरह से ये पेशेंट्स हमें मिलते हैं, और वो जो पेशेंट्स हैं जब उनको देखा जाता है तो कहीं ना कहीं से लग जाता है कि कुशिनॉइड है. क्या कारण है कि आप लोग लो डोज में इतना ज्यादा स्टेरॉइड देना चाहते हैं फॉर लॉन्ग टाइम इन पेशेंट, विच लीड्स टू ऑस्टियोपोरोसिस एंड अदर कॉम्प्लिकेशंस? हाउ विल यू जस्टिफाई लो डोज स्टेरॉइड्स फॉर लॉन्ग टाइम?
सबसे पहली चीज, इफ इट इज लो डोज कॉर्टिकोस्टेरॉइड तो कुशिंगॉइड होगा ही नहीं. दैट्स अ प्रिंसिपल ऑफ मेडिसिन. आपकी बॉडी की रिक्वायरमेंट, आपके सबके बॉडी में, और ये आपको याद होगा एमबीबीएस डेज से, all of us have natural cortisol in our body, and that cortisol is equivalent to 7.5 milligrams of prednisolone per day. Anything lower than that is not going to give you Cushingoid. Our problem is ये जो हम यहाँ पे झुलझ रहे हैं ना, एक्चुअली आप दरवाजे के बाहर जरा झांक के देखिए, आपके सबसे बड़े दुश्मन कौन है? द क्वैक्स. पेशेंट आपको ये बताता है कि उसने कितनी आयुर्वेदिक खाई? पेशेंट आपको ये बताता है कि वो जेन्युइन आयुर्वेदिक थी कि नहीं? पेशेंट आपको ये बताता है कि होम्योपैथी प्लस आयुर्वेदिक प्लस पेन किलर प्लस आपकी दवाई चालू है? ये आप जानते नहीं, वो हम स्किन देख के पता लगा देते हैं. 7.5 मिलीग्राम प्रेडनिसोन तक आप नहीं होंगे, पहली चीज. दूसरी चीज, मैं हर पेशेंट को सिखाता हूं, हर ऑर्थोपेडिक सर्जन को सिखाता हूं, हिंदी में, मराठी में, गुजराती में, सब भाषा में सब पेशेंट को बोलता हूं कि स्टेरॉइड दोधारी तलवार है. मरते आदमी को जिंदा कर सकती है, नहीं तो उसको नोबेल प्राइज नहीं मिलता. लंगड़े घोड़े को रेस जिता सकती है वो, लेकिन अगर उसको योग्य बीमारी, योग्य समय और योग्य प्रमाण में दिया जाए तो वो अमृत है, नहीं तो विष. और ये मेरा सेंटेंस मेरा बनाया हुआ है, लेकिन प्रैक्टिकली हर रूमेटोलॉजिस्ट यही सेंटेंस अलग अलग शब्दों में यूज करता है. तो ये तो आपका आरोप पूरी तरह गलत है. ये हो ही नहीं सकता कि कोई रूमेटोलॉजिस्ट रूमेटॉइड आर्थराइटिस में 7.5 मिलीग्राम प्रेडनिसोन के ऊपर जाए. स्टीरॉयड का इस्तेमाल रूमेटॉइड आर्थराइटिस में एज ए ब्रिज थेरेपी किया जाता है. पेशेंट आपके पास व्हील चेयर में आता है, लंगड़ा के आता है, वॉकर पे आता है, औरत जात ज़्यादा होती है और औरत के ऊपर घर चलता है. एक औरत बीमार पड़े, पूरा घर बीमार. उसको खड़ा करना ये सबसे पहले आपका धर्म है, ना कि उसको लेक्चर दें रूमेटॉइड आर्थराइटिस क्या है, कितने टाइम दवाई लेंगे, वो सारा नेक्स्ट विजिट के लिए रखो. सबसे पहले उसका दर्द कम करो ताकि वो उठ के बच्चों का टिफिन बना सके. और उस टाइम पे अगर जो आपने थोड़ा सा डोज स्टीरॉयड पेन किलर के साथ दिया तो ये सिर्फ पुण्य का काम है. लेकिन उसके बाद आर्थराइटिस की मेडिसिन चालू करके स्टीरॉयड बंद करना, किस तरह से करना, कैसे धीरे धीरे शरीर में से निकाल देना, ये तो हम लोग मेडिसिन में सीखते ही हैं. इसलिए ये हमारे लिए रोज का काम है. लेकिन ये आरोप पूरी तरह गलत।
By your intellect answers, you are trying to de-justify all my allegations, sir. लेकिन हम सारे ऑर्थोपेडिक सर्जन्स को रिप्रेजेंट कर रहे हैं आपके सामने। आरोपों का जो ये दौर है ये खत्म नहीं होने वाला है। इतने सारे ग्राफ आप बना के दे देते हैं और ये सूक्ष्म दिमाग ऑर्थोपेडिक सर्जन्स का कहां कहां काम करे। एवरी ईयर यू पीपल कम आउट विद न्यू गाइडलाइंस फॉर डायग्नोसिस एंड मैनेजमेंट टू कंफ्यूज ऑलरेडी ओवर स्ट्रेस्ड these orthopedic surgeons. Sir.
Confusion नहीं, it's a complex thing, ऐसा बोलना है, क्योंकि because it is a very complex subject है, इतने सारे चीज़ रहते हैं, क्योंकि आपको भी मालूम है, जैसे डॉक्टर कौशिक had said, कि काफ़ी सारे डेवलपमेंट्स हो रहे हैं, ट्रीटमेंट इतना कॉम्प्लेक्स है, जैसे अपना दवाई ऐसे है, अगर दवाई का डोज थोड़ा ज़्यादा हो गया तो फिर साइड इफ़ेक्ट आने का रिस्क रहता है, दवाई का डोज थोड़ा कम किया तो एफिकेसी नहीं आता है, तो फिर एक ऐसा नाजुक बैलेंस लेके चलना है। दैट इज़ वाई सो व्हेन यू हैव टू हैंडल द थिंग्स व्हेन देयर इज़ अ वेरी थिन लाइन ऑफ डिमार्केशन, सो यू हैव टू अंडरस्टैंड द सब्जेक्ट ए लॉट। तो फिर बहुत ज़्यादा कॉम्प्लेक्सिटी के थ्रू जाना पड़ता है एंड लॉट्स ऑफ रिसर्च इज़ कमिंग एवरी ईयर, न्यू मेडिसिन आ रहा है। जैसे आपने बोला कि स्टेरॉयड से ज़्यादा साइड इफ़ेक्ट हो रहा, क्योंकि हमको नाउ द मॉडर्न वे ऑफ गोइंग इज़ टू सी दैट जितना हो सकता है स्टेरॉयड अवॉइड ही करना। विदाउट स्टेरॉयड कैन वी ट्रीट दिस पेशेंट्स? ऐसे तो लॉट्स ऑफ न्यू थिंग्स आर कमिंग ऐसे, क्योंकि बिकॉज दिस इज़ नॉट ट्रू लाइक टू कन्फ्यूज ऑल दिस थिंग्स, द सब्जेक्ट इज़ बिकमिंग सो वेस्ट, तो एंड इट्स बिकमिंग सो एंड सो कॉम्प्लेक्स एंड रिमेटोलॉजी इज एवॉल्विंग, न्यू डिजीजेस आर बीइंग आइडेंटिफाइड, जो हम पहले इतने साल से जो सोचते थे ये एक बीमारी है, लेकिन अभी पिछले 3-4 साल से निकल रहा है कि ये नया बीमारी है, और इतने साल से हम कुछ दवाइयाँ दे रहे हैं, द न्यू थिंग्स आर कमिंग, दवाइयाँ चेंज हो रहे, पैटर्न्स चेंज हो रहे, तो फिर वी नीड टू कीप आवर सेल्फ अपडेटेड, क्योंकि इसके लिए बहुत ज़रूरी है। जैसे ट्रेनिंग भी है, जो भी आप सीखना चाहते हो रिमेटोलॉजी, तो फिर इसके लिए आपको कमिटमेंट चाहिए, कमिटमेंट, ट्रेनिंग एंड मोस्ट इंपॉर्टेंट टाइम, क्योंकि अभी रिमेटोलॉजी पहले ज़माने जैसे 10 साल 15 साल पहले का पार्ट टाइम जॉब नहीं है, सो इट इज़ बिकम ए फुल टाइम थिंग एंड एज एवरी पेशेंट deserves to be healthy, and उसको because हमारा कोई हक नहीं बनता कि because we are prescribing, ऐसे नहीं कि we should harm patient, because हमारा ऐसे यही सिखाया जाता है हमको, अगर बेनिफिट ना करो तो ना करो, हार्म तो मत करो पेशेंट को। तो इसीलिए अगर पहले ये सीखना है, जैसे yesterday मैं और डॉक्टर कौशिक बात कर रहे थे, हम ये नहीं देख रहे कि हम कितने पेशेंट को टोफासेटनिब स्टार्ट करें, हम ये देख रहे कितने पेशेंट को टोफासेटनिब रोक रहे, तो सो हाउ मेनी पेशेंट्स यू आर स्टॉपिंग गिविंग दिस ड्रग्स। तो ये सब आपको अगर समझना है तो फिर यू नीड टू लर्न, तो फिर सब्जेक्ट तो रहता ही रहता है, बड़ा रहता है, कॉम्प्लेक्स रहता है, सो इट इज़ नॉट टू कन्फ्यूज बट इट इज़ टू मेक यू अंडरस्टैंड द थिंग इज़ कॉम्प्लेक्स। जितना आप सिंपल सोचते हो रूमेटॉइड आर्थराइटिस, उतना सिंपल बीमारी नहीं है।
थैंक यू सर। क्या होता है कि एक वकील भी एक आदमी होता है, और जब अदालत में खड़ा होता है उस समय वो डिस्टर्ब होता है जब उसकी पत्नी आ जाती है। आई वेलकम डॉक्टर मनीषा एट प्रेजेंट। तो थोड़ा सा मैं डिस्टर्ब हो गया था, कुछ मैं देख रहा था फोन आ रहा है, आप जानते हैं अगर वो नहीं रिसीव करता तो मेरा खाना बंद हो सकता था। तो फिर आरोपों का यह दौर चलता रहेगा, और इस तरह के जो जोड़ आप देखते हैं सर, जॉइंट्स, दीज आर द थिंग्स विच disturbs everybody. So sixth allegation is that rheumatologist puts lots of steroid injection in joints, and therefore joint becomes infected and deformed and joint replacement becomes a challenge. ऐसे क्या होता है सर?
राज किरण ने अभी एक बात बताई कि पिछले 10 से 15 साल में रोमेटोलॉजी की शक्ल बदल चुकी है। आप जो फोटो दिखा रहे हैं, जो जोड़ टेढ़े मेढ़े, इसकी बीमारी 15 साल पुरानी होती है, तब जाके जोड़ों का ये हाल होता है। हमारे पास 4 दवाइयाँ थी,
23 साल सर, एग्जैक्टली 23 years when
मेथोट्रेक्सेट, सल्फासालिजिन, हाइड्रोक्सीक्लोरोक्विन, लेफ्लोनामाइड भी 20 साल पहले आया है, 2001 में उसको लॉन्च हुआ था। तब तक 3 दवाई, पेन किलर, स्टीरॉयड के साथ हम पेशेंट को जिंदा रख रहे थे। आपके लिए रोमेटॉइड आर्थराइटिस एक आर्थराइटिस, इन्फ्लेमेशन ऑफ द जॉइंट्स, बस इतना ही है। लेकिन आपने कल से अभी तक में इंटरस्टिशियल लंग डिजीज के बारे में सुन लिया, lifespan of every rheumatoid arthritis is shorter by at least 10 to 15 years. This data is there. You don't need guidelines for it. Read it. You don't need guidelines. Just put lifespan of a rheumatoid arthritis patient on you don't even need AI for this. And do you think that we were in a very good position? हमारे पास 3 दवाई, आप लोग हर साल एक नई टेक्नोलॉजी ऑपरेट करने के लिए आते हो, कभी शोल्डर रिप्लेसमेंट, कभी रिवर्स शोल्डर रिप्लेसमेंट, कभी ये आर्थ्रोस्कोपी, कभी वो आर्थ्रोस्कोपी. तब हम तो आपको ये नहीं पूछते कि ये क्या कर रहे हो आप. पॉइंट इज, अब अगर जो यही चीज आप हमें पूछते हैं तो किस्सा पूरा अलग है. अब एक जोड़ भी हम नहीं छोड़ना चाहते, लेकिन फैक्ट ये है कि रूमेटॉइड आर्थराइटिस में 68 जोड़ों में बीमारी बढ़ती है, और अगर जो इन 68 जोड़ों में से 3 जोड़ या 2 जोड़ रह गए जो सूजे हुए हैं, 64-65 को आपने अच्छी तरह दबा दिया, सब जगह ठीक है, ये 2 जोड़ ये ढीठ हैं, तो उसके लिए आप पूरे बॉडी को पावरफुल इम्यूनोसप्रेसेंट देना और उसकी इम्यून सिस्टम को और दबा देना, अगर जो ये करते हो तो ये गलत है. और इसीलिए आजकल के ज़माने में अब आपको स्टीरॉयड इंजेक्शन इतने दिखेंगे नहीं, लेकिन अगर जो स्टीरॉयड इंजेक्शन की हिस्ट्री दिखी तो वो एक आधे जोड़ में, ऐसे जोड़ में होगी जहां पे बाकी सब दवाइयों से कंट्रोल नहीं हुआ. पेशेंट का लिवर, पेशेंट का किडनी, पेशेंट का वाइट सेल काउंट, पेशेंट का फेफड़ा, ये चीजें और आर्थराइटिस की मेडिसिन लेने के लिए सक्षम नहीं है, और उस जोड़ को मुझे बचाना है. लेकिन इतनी लंबी बीमारी ने के पहले हमारे पास था क्या? तब कोई ऑर्थोपेडिक सर्जन हमारा हाथ नहीं बटाता था. आज आप बटा रहे हैं, ये हमारी किस्मत है. बाकी उस जमाने में ऑर्थोपेडिक सर्जन पेशेंट को ये बोल देते थे, बस दिन गिन लो, पेन किलर खाओ और दिन गिन लो, तुम्हारी बीमारी के लिए कोई दवाई नहीं है, और भेज देते थे. इसीलिए पेशेंट हम तक पहुंचता ही नहीं था. थे भी कम, और नहीं पहुंचता था तो हम भी सोचते थे चलो आज रात को नींद तो मिल गई.
थैंक यू सर. हतोत्साहित मत होइए, और मेरे ऑर्थोपेडिक फ्रेंड्स, आपका वकील आपके साथ है, आपसे पैसा लिया है. मैं अपने हक की लड़ाई लड़ूंगा आज. और एलिगेशन है मेरे पास, ऐसे ऐसे मरीज जो इस गंभीर अवस्था में समाज में हैं, उसका 7th एलिगेशन आप पे जाता है. यू रिमेटोलॉजिस्ट आर सो हम्बल. आप इनका आंसर सुन रहे होंगे, मैं थोड़ा एग्रेसिव होता हूं, ये बहुत पोलाइट हो जाते हैं. You are so humble and polite in counseling and properly trained to convince that patients don't want to come to orthopedic surgeons for joint replacement early. And एक orthopedic surgeon को private hospital भी खोलता है, 5 से 10 करोड़ रुपए लग जाते हैं. सर वो कहाँ जाएगा सर? जो आपने बताया था पहले भी, मैं वो allegations के रूप में लाना चाहता हूं. So what is the solution sir?
ऐसा हम काउंसलिंग और कन्विंस ने ट्रीट करते हैं पेशेंट को. क्योंकि हम ट्रीट करते हैं, वो रिकवर होता है, अच्छा होता है, उसका रिप्लेसमेंट का ज़रूरत नहीं पड़ता. तो इसीलिए आई कॉन्कर विद कौशिक, क्योंकि ये भी आरोप गलत है, पूरे के पूरे आपका आरोप गलत है आज. बिकॉज हम उसको ऐसे ट्रीट करते हैं तो फिर पेशेंट रिकवर हो जाता है, उसका रिप्लेसमेंट का ज़रूरत ही नहीं पड़ता. और देखो मैक्सिमम पेशेंट्स जो है, आप डिजेनरेटिव ऑस्टियोआर्थराइटिस उसको संभालो, बिकॉज ये रूमेटॉइड आर्थराइटिस हमको छोड़ दो. जो भी एज रिलेटेड प्रॉब्लम से ऑस्टियोआर्थराइटिस है वो चलता है, उसको आप लेके चलो रिप्लेसमेंट करने के लिए, और रूमेटॉइड आर्थराइटिस को हमको छोड़ दो, हम उसको ऐसे मैनेज करेंगे ताकि उसका रिप्लेसमेंट की ज़रूरत नहीं पड़ते. और हमको ये पढ़ाया जाता है, हमारा गोल भी वही है. हमारा गोल वही है कि नन ऑफ द पेशेंट ऑफ रूमेटॉइड आर्थराइटिस शुड गो फॉर जॉइंट रिप्लेसमेंट. इफ़ वी आर ट्रीटिंग अवर पेशेंट और वो रिप्लेसमेंट के लिए गया है, तो फिर आवर ट्रीटमेंट हैज़ नॉट वर्कड प्रॉपरली. तो दैट विल बी आवर गोल एंड वी वर्क टुवर्ड्स दैट. आप जैसा मान के चलो, लेकिन हमारा गोल है, वी वर्क फॉर द पेशेंट्स, वी आर हियर फॉर द पेशेंट्स, एंड वी सी दैट ये रिप्लेसमेंट रूमेटॉइड पेशेंट्स में ना हो. और आप ऑस्टियोआर्थराइटिस और पोस्ट ट्रॉमेटिक आर्थराइटिस उसको लेकर आप अपना रिप्लेसमेंट का दुकान चला लो.
मैं थोड़ा सा अलग आपको एक बात बताऊंगा, इसके बारे में ज़रूर सोचिएगा। आप लोग यहाँ पे बहुत सीनियर ऑर्थोपेडिक सर्जन भी बैठे हैं। 3 पॉइंट। कल मैंने बताया था कि कुछ ऑर्थोपेडिक सर्जन्स मेरे बहुत करीबी दोस्त हैं। ऑर्थोपेडिक सर्जन और रोमेटोलॉजिस्ट एक ही थाली के चट्टे बट्टे। अब आप एक बात समझिए इसको, आपका टारगेट पेशेंट को मोबाइल करना है, मेरा टारगेट पेशेंट को मोबाइल करना है। आपका शस्त्र छुरी है, मेरा शस्त्र गोली है। लेकिन बात समझिए, 68 जोड़ में से कितने जोड़ को काटेंगे? रोबोट बनाएंगे क्या? इसलिए जब तक हम किसी पेशेंट की सारी बीमारी कंट्रोल कर ना लें और उसके बाद जो जोड़ ढीठ निकलता है, जिसको या तो बचाना जरूरी है, तो जैसे कि कल वाले साहब बता रहे थे आर्थ्रोस्कोपिक साइनोवेक्टोमी करके, या तो जॉइंट रिप्लेसमेंट करके, जैसे जो मुनासिब जहाँ पे हो वो बेशक कर लो। लेकिन अगर जो आपको ये लगता है कि आप हर जोड़ को रिप्लेस कर लोगे, रूमेटॉइड आर्थराइटिस सबसे पहले छोटे जोड़ों को मारता है। मुझे एक अच्छा एंकल रिप्लेसमेंट सर्जन दिखाओ आपके कंट्री में, चलो एक दिखा दो। आप घुटना ऑपरेट कर लोगे, उसके बाद पेशेंट फिर भी चल नहीं पाता क्योंकि अंगूठे टेढ़े हैं। आपकी टो रिप्लेसमेंट अच्छी नहीं होती क्योंकि पेशेंट के मसल्स वीक हैं, पेशेंट ठीक से वेट बेयर नहीं कर सकता। क्या करूं आपके नी रिप्लेसमेंट का? ये एक चीज। अच्छा, पॉइंट नंबर 2, जितने ऑर्थोपेडिक सर्जन्स माहिर यहाँ पे बैठे हैं जो रूमेटॉइड आर्थराइटिस के पेशेंट्स या स्पॉन्डिलोआर्थ्रोपैथी के पेशेंट्स को ऑपरेट करते हैं, इस बात को ज़रूर मानेंगे कि ऑस्टियोआर्थराइटिस को ऑपरेट करने में जो उनको पिक्चर दिखता है ऑन टेबल और रूमेटॉइड आर्थराइटिस को ऑपरेट करते हुए जो उनको पिक्चर ऑन टेबल दिखता है, लिगामेंट्स की हालत पूरी लैक्सिटी है, बोन्स वीक है, वो आपको ऑस्टियोआर्थराइटिस में नहीं मिलता। अब वो इन्फ्लेम्ड जॉइंट को लूज लिगामेंट्स के साथ जब आप ऑपरेट करते हैं तो वो जॉइंट की लाइफ आपकी ऑस्टियोआर्थराइटिस की तरह अच्छी नहीं होती। इस बात को आप माने या ना माने, ये सत्य है। रूमेटॉइड आर्थराइटिस को नी रिप्लेसमेंट करने के बाद उसकी जॉइंट लूजनिंग जल्दी होती है और ये चीज जाहिर है, ये चीज प्रूवन है। ऑस्टियोआर्थराइटिस मेरी मां का 2008 में हुआ था, आज भी चल रही है परफेक्टली फाइन। बायलैटरल नी रिप्लेसमेंट किया था, आज भी चल रही है। लेकिन यही चीज आप मुझे 17 साल किसी रूमेटॉइड आर्थराइटिस के जॉइंट को स्टेबल जॉइंट दिखा दो, पॉसिबल नहीं है। और लास्ट चीज, आपने एक जोड़ ऑपरेट किया, उसके बाद भी बाकी जोड़ को बचाने के लिए मुझे दवाइयां शुरू रखनी है जिसमें उनकी इम्यूनिटी कम है। आप ही का जोड़ जाएगा, आप ही के जोड़ में इन्फेक्शन लगेगा और उसके बाद मैं जो आपको बताने वाला हूं, ये कोट अनकोट एक ऑर्थोपेडिक सर्जन मेरे पेशेंट से बात करते हुए मेरा सुना हुआ है। सुनिए, मैडम आपका नी रिप्लेसमेंट फर्स्ट क्लास हुआ, हॉस्पिटल फर्स्ट क्लास, मेरा हाथ फर्स्ट क्लास। क्या करें, आपकी बॉडी ने आपको धोखा दे दिया। तो आप मुझे यह कहते हैं कि ये आप जवाब देंगे किसी पेशेंट को जब वो जॉइंट इन्फेक्ट हो जाता है?
जो बातें आप बता रहे हैं समाज के लिए अच्छी है और हम सब ऑर्थोपेडिक सर्जन्स आरोप लगाते हुए थोड़ा सा शक्ल से कहीं ना कहीं मुरझा रहे हैं, लेकिन उस दौर को आगे बढ़ाते हुए जो मरीज आता है हमारे पास, क्योंकि पहला मरीज हमारे पास ही आता है, वो हमसे संपूर्ण इलाज चाहता है। वो चाहता है कि मेरी तकलीफ कम हो जाए। द 8th एलिगेशन जो आपके पास जा रहा है, यू ओवर एम्फेसाइज ऑन रेमिशन ऑफ डिजीज and lifelong treatment by DMRDs and biologics, which is very difficult. इतना महंगा महंगा दवा लगातार वो पूरे जिंदगी भर कैसे खा सकता है या चला सकता है? I welcome our chief guest, Honorable Member of Parliament, Mrs. Shambhavi Chaudhary. A big round of applause for his मिस्टर शामी चौधरी, मैम, ऑनरेबल मेंबर ऑफ पार्लियामेंट, मैं आपको ब्रीफ कर दूं थोड़ा। अदालत को हम लोग यहाँ रोक रहे हैं, आरोपों का दौर चल रहा है। हमारे दो रेप्यूटेड रिमेटोलॉजिस्ट हैं, डॉक्टर कौशिक भोजानी फ्रॉम मुंबई एंड डॉक्टर राजकिरण डुडम फ्रॉम हैदराबाद। प्रोफेसर एस झा इज द ऑनरेबल जज हियर, और मैं एक वकील की हैसियत से अपने ऑर्थोपेडिक सर्जन्स को प्रोटेक्ट करने आया हूं। आरोपों का दौर लगाया जा रहा है इन पे कि इनके कारण हमारा प्रैक्टिस गड़बड़ाता जा रहा है, रिमेटोलॉजिस्ट के कारण। तो इन आरोपों पे अब 8वें इस पे आए हैं, तो ये 8वां आरोप आप पे है। यस सर।
सर ये भी आरोप सरासर गलत है, क्योंकि आप कॉस्ट के बारे में पूछ रहे हैं। इसमें डीएमआर्ट्स का मेथोट्रेक्सेट का हफ्ते में 1 दिन खाने का टैबलेट है सर, उसमें कुछ कॉस्ट है ही नहीं। कभी कभी मतलब हफ्ते में 1 दिन, 1 महीने का थेरेपी 100-150 रुपये में हो जाता है। और वाइसोलोन स्टेरॉइड कुछ भी अगर बीच बीच में अगर दिया, कुछ पेन किलर, उसका भी बहुत महंगा नहीं। सो बायोलॉजिक्स तो बहुत ही कम पेशेंट्स को रिक्वायरमेंट होता है। अगर इफ़ यू प्रॉपरली ट्रीट देम अर्ली, अगर बीमारी को आइडेंटिफाई करें हम और उसको प्रॉपर ट्रीटमेंट दिए, उसको अगर काउंसिल करके अच्छा से कुछ दिन तक कॉन्स्टेंटली उसको ट्रीटमेंट में रखे, तो फिर बहुत कम लोग, मतलब 10 to 15% लोग ये बायोलॉजिक्स तक जाते हैं। 90% तक हम सिंपल ड्रग से मैनेज कर सकते हैं। अगर पेशेंट अगर कमिटेड है, उसको दवाइयाँ ले रहा, अगर हम उसको मैनेज कर रहे बोले तो काफ़ी सारे बार ऐसा हो जाता है पेशेंट भड़क जाता है। जब हम दवाई देते हैं, कोई ना कोई अगर हाफ नॉलेज पर्सन है उसको बोल देता कि अरे ये दवाई से ये साइड इफेक्ट हो जाता, ये दवाई से तुम्हारा किडनी ख़राब हो जाता, वो खाया तो ये हो जाता, तो फिर उसमें पेशेंट कन्फ्यूज़ हो जाता है। बिकॉज फॉर ऑल दीज थिंग्स प्रॉपर मेडिकल एजुकेशन सबको, एटलीस्ट हमारे डॉक्टर फ्रेटर्निटी को बीमारियों के बारे में समझ रहना चाहिए। दे शुड नो अबाउट द मेडिकेशंस, हाउ टू यूज़, हाउ लॉन्ग टू यूज़, एंड कभी कभी इसमें बेसिक कॉम्प्लिकेशंस कैसे आता है, उसको कैसे आइडेंटिफाई करना, कैसे ट्रीट करना। तो मेजॉरिटी ऑफ द पेशेंट्स उतना मतलब एफोर्डेबिलिटी की ज़रूरत नहीं है। और नाउ वी हैव आवर लॉट्स ऑफ प्रोग्राम्स आर आल्सो बीइंग रन बाय एवरी स्टेट गवर्नमेंट एंड सेंट्रल गवर्नमेंट, वेयर दे आर सपोर्टिंग विथ लॉट ऑफ दीज मेडिकेशंस। मतलब प्रत्येक सिटी में अगर देखें तो देर आर लॉट्स ऑफ नाउ गवर्नमेंट हॉस्पिटल्स, रिमेटोलॉजी इज ऑल्सो गेटिंग अवेलेबल इन मोस्ट ऑफ द हॉस्पिटल्स, वेयर पेशेंट्स जा सकते हैं। ज़्यादा से ज़्यादा मेडिसिन भी उनको फ्री में मिलता है, बिकॉज दिस इज़ नॉट वेरी एक्सपेंसिव बिजनेस। बायोलॉजिक्स भी नाउ अगर ऐसा अच्छा थिंग्स है गवर्नमेंट के थ्रू, इफ़ यू नो ऑल दिस थिंग्स, अगर गवर्नमेंट को किसी ने लिखा है कि ये पेशेंट को ये मेडिसिन, बिकॉज हमारा पास तो आता है हैदराबाद में एंड लॉट ऑफ अदर प्लेसेस, अगर हम लिखे कि पेशेंट को इलाज के लिए ये दवाएं की ज़रूरत है, एस्टिमेटेड कॉस्ट 6 months का इतना है, 1 year का इतना है, तो फिर गवर्नमेंट भी प्रोवाइड कर रहा है। सो सिस्टम्स है, एवरीथिंग इज़ अवेलेबल देयर। हमको ये समझ आना चाहिए और पेशेंट को समझाना चाहिए, एंड देयर हैज़ टू बी कॉन्फिडेंस। सो इसीलिए मैं बोलता हूँ ये आरोप ही गलत है। बेसिक ट्रीटमेंट कर सकते हैं कम पैसों से, और अगर एफोर्डेबल नहीं है तो फिर गवर्नमेंट का सपोर्ट ले सकते हैं। जैसे व्हेन वी इन्फॉर्म दिस थिंग्स टू अवर, बिकॉज गवर्नमेंट में जो रहता है, जो चलाते हैं, उनको भी पूरा कंप्लीट आइडिया नहीं रहता है ऐसा पेशेंट है ऐसा, बिकॉज दैट्स वेयर आवर एसोसिएशन कम्स अलाइव। सो एज एन एसोसिएशन वी ट्राई टू पुट दिस फॉरवर्ड टू द गवर्नमेंट। जो बचा कुचा 5-10% के लोग हैं जो एफर्ट नहीं कर सकते वो ट्रीटमेंट के लिए, सो यू प्लीज़ सपोर्ट देम। तो वो पूरा चैनलाइज करके उनको समझा दे तो डेफिनेटली येस, बिकॉज वी आर रिसीविंग सपोर्ट फ्रॉम आवर लाइक पॉलिसी मेकर्स, एंड डेफिनेटली इट विल रीच टू द पेशेंट। तो फिर लाइक देर इज़ एवरीथिंग अवेलेबल, ओनली हमारी तरफ से कमिटमेंट की कमी है। वो इफ़ वी कीप इट, आवर पेशेंट लाइफ्स विल बी मच मच बेटर।
माननीय जज महोदय, हमारे जो आरोपित हैं, एक्विट हैं, वो अच्छी अच्छी बातों से मुझे कुछ गलत दिशा में लेते जा रहे हैं, और मेरे जो ऑर्थोपेडिक फ्रेंड्स हैं वो उनका चेहरा लटकता जा रहा है, वो इनकी तरफ से ज्यादा आकृष्ट कर रहे हैं। तो मैं अंतिम आरोप इन पे लगाना चाहता हूं। अगर कुछ गलत डायग्नोसिस होता है, ये बोलने के लिए एक इंजीनियर है, और किस हालत में ये चला गया है, और हम सब ऑर्थोपेडिक सर्जन्स की गलती मानिए, जिसकी भी गलती मानिए, उसको समाज में बहुत सारे लोग विकृत होते जा रहे हैं, दिव्यांग की श्रेणी में चले जाते हैं। तो अंतिम आरोप मैं लगाना चाहता हूं, इतना कुछ करते हुए भी rheumatologists feel that they are more talented than orthopedic surgeons. Therefore, you don't make us permanent member of Indian Rheumatology Association, and therefore we are not getting trained properly to treat these types of patients.
मैं एसोसिएशन में हूँ, ये एक्चुअली ये भी आरोप गलत है। आप ये ट्रेनिंग और मेंबर के दोनों को क्यों मिला रहे हैं आप? बिकॉज मेंबर तो ये पॉलिसी मैटर से, एसोसिएशन है, ऑर्गेनाइजेशन, ये कम्प्लीटली अलग बात है। ये तो अगर आप रोमेटोलॉजी सीखने में इंटरेस्ट हो और ये रोमेटोलॉजी एडमिनिस्ट्रेशन ट्रेनिंग ऑर्गेनाइजेशन में घुसने में इंटरेस्ट है, सो आपको पहले यू हैव टू मेक योर थिंग्स क्लियर. तो फिर आप, क्योंकि ये मेंबरशिप को तो वो वोटिंग इलेक्शन के लाइक प्रेसिडेंट सेक्रेटरी वो अलग वो डायरेक्शन ही अलग है, बिकॉज दैट इज़ मेनली फॉर द ऑर्गेनाइजेशनल पर्पजेस. ट्रेनिंग एक कम्प्लीटली अलग बात है. अगर आप रोमेटोलॉजी सीखना चाहते हो तो फिर लॉट्स ऑफ थिंग्स आर अवेलेबल. Scientific material is available. We do lot of conferences, CMEs. ऐसे this is wonderful meeting. जैसे yesterday, since yesterday I'm listening lots of beautiful lectures and thanks to Amulya. Like इतने सारे सीखने को मिला. ऐसे बहुत सारे opportunities है सीखने के लिए. आपको मेंबर बनने की क्या ज़रूरत है? मेंबर तो अलग है, इलेक्शंस के लिए वो क्या बनना है, पॉलिसी गवर्नमेंट को रिप्रेजेंट करने के लिए वो अलग बात है. तो फिर आप IRA मेंबर बनने की सोचो मत, आप रोमेटोलॉजी सीखने के लिए सोचो.
सर अंतिम मैं चाहूँगा आप कुछ बोलिए, उसके बाद
आपको एक चीज़ मैं पूछना चाहता हूँ. भाई साहब, आपका नाम क्या है भाई साहब, आप जो खड़े हैं?
प्रदीप.
प्रदीप भाई, आपको कल से डॉक्टर प्रदीप ऑर्थोपेडिक सर्जन बना दूं? ऑपरेट कर लोगे कल से? क्यों नहीं करोगे यार? इनका ये कहना है कि कॉन्फ्रेंस में 2 लेक्चर सुन के ये रोमेटोलॉजी के IRA के मेंबर बन जाएं, तो तुम भी कल से ऑर्थोपेडिक सर्जन बन जाओ. कौन सी बड़ी बात है यार? ट्रेनिंग की थोड़ी जरूरत है. छोड़ यार, आजा 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 आजा, डॉक्टर का लेबल लगाते. बॉस, जिस दिन सीखना चाहो दिल से मेरा नंबर ले लो, मेरे से बिना पूछे बॉम्बे आ जाना. लेकिन वर्ड्स याद रखो, दिल से. मेरे साथ सब्जी की तरह जो हम मार्केट में जाके सब्जी का भाव तोल करते हैं ना, मैं हफ्ते में 1 घंटे आऊँगा, मुझे रोमेटोलॉजिस्ट बना दो. मैं हफ्ते में 2 दिन आऊँगा, मुझे रोमेटोलॉजिस्ट बना दो. दिल से लगा दो, शायद वापस ऑर्थोपेडिक में ना जाओ, रोमेटोलॉजी में आ जाओगे. ये बात तो मेरी शर्त पक्की है. रही बात, इतनी हमारी तरफ से कभी भी परहेज नहीं था, हमारी तरफ से कभी भी ये नहीं था कि हम नहीं सिखाएंगे, क्योंकि हमारे गुरु लोग जो थे उन्होंने आज से 30 साल पहले ऑर्थोपेडिक एसोसिएशंस में जाके रिक्वेस्ट किया था, और ये इतिहास में लिखा हुआ है, आप जाके पढ़ लीजिए. डॉक्टर महेंद्रनाथ कर्नाटका में और डॉक्टर मालविया दिल्ली में हर ऑर्थोपेडिक एसोसिएशन में जाके उनसे रिक्वेस्ट करते थे कि पेशेंट आपके पास पहले आते हैं, आप हमसे हमारे साथ हाथ जोड़िए और सीखिए. तब तो कोई आया नहीं. अब बिना सीखे करना चाहते हैं रोमेटोलॉजी. सीख लो यार, सीखो और करो. मेंबरशिप अलग बात है, लेकिन IRA का रूल है, जिस तरह से आपके ऑर्थोपेडिक एसोसिएशन का रूल है, MS डिग्री लिखे बिना आप ऑर्थोपेडिक एसोसिएशन के मेंबर नहीं बन सकते. आप रोमेटोलॉजी ट्रेन हो जाओ, आप रोमेटोलॉजी एसोसिएशन के मेंबर बन जाओ, कोई प्रॉब्लम नहीं है. मोस्ट वेलकम. थैंक यू.
माननीय जज महोदय, सभी आरोपों को आपने सुना, सभी जवाबों को सुना. अब ये सारी जनता आप क्या देखना चाहती है कि आपका क्या जजमेंट होता है, जो कि समाज के लिए एक नई दिशा निर्धारित करे.
डॉक्टर अमूल्य, आपने बहुत सारे इल्जाम लगाए और हमारे आरोपित दोनों डॉक्टर, जिसमें डॉक्टर राज किरण जो वुड बी सेक्रेटरी हैं, सेक्रेटरी इलेक्ट हैं इंडियन रोमेटोलॉजी एसोसिएशन के, और बॉम्बे से बहुत प्रतिष्ठित डॉक्टर कौशिक भी आए हैं. आपने इल्ज़ाम लगाए, उन्होंने डिफेंड किया. मुझे एक छोटी सी कहानी याद आ रही है. एक दार्शनिक कहीं से गुजर रहा था और एक कोल्हू चल रहा था, बैल नाच रहा था, और कोल्हू चलाने वाला इंसान सोया हुआ था जमीन पर. दार्शनिक वहाँ रुक गया और उसने देखा कि ये मालिक इसका सोया हुआ है और बैल है कि चक्कर लगाया जा रहा है. उसने उसको उठाया. भाई साहब, आपका बैल चल रहा है, लेकिन आपने इसके आँखों में साइड से पट्टी क्यों लगा दी है? तो उसने कहा कि इसलिए लगा दी है कि अगर खुला रहेगा तो ये कहीं बाएं दाएं भागने का कोशिश करेगा, सो ये समझ रहा है कि हम तो घूम रहे हैं, और ये स्वच्छंद घूम पाता है इस पट्टी की वजह से.
फिर उसने कहा तुम सो जाते हो, तुमको पता कैसे चलेगा कि ये काम कर रहा है कि रुक गया? तो उसने कहा कि इसके गले में घंटी लगी है, आपने नहीं देखा? ये घंटी बजती रहती है, बजना बंद हो जाएगा तो मैं जग जाऊंगा। फिर उसने कहा अगर ये एक ही जगह खड़ा होकर गर्दन हिलाता रहे तो घंटी तो बजती रहेगी। तो उसने कहा वो दार्शनिक तुम हो ना, वो दार्शनिक नहीं है। तो कहने का गरज है कि हम ऑर्थोपेडिक सर्जन सिर्फ सर्जन तो नहीं हैं, हम फिजिशियन भी हैं। हम अपने ओपीडी चैम्बर में फिजिशियन का काम करते हैं और फिर अपने ऑपरेशन थिएटर में जो कला सर्जिकल स्किल्स हमने सीखा है उसका इस्तेमाल करते हैं। लेकिन इसका अर्थ यह तो नहीं है कि हम अपने मरीजों के साथ अपने क्लिनिक के चैम्बर में जस्टिस ना करें। हमें आपके साथ मिलकर टीचर टॉट का रिलेशनशिप नहीं चाहिए। हम आपको मास्टर ट्रेनर की तरह बुलाए हैं और हम चाहते हैं कि हमारे ऑर्थोपेडिक सर्जन्स विलिंग ट्रेंड होने के लिए उत्सुक हैं, उत्साहित हैं। और सबसे बड़ा टीचर कौन है? ना ही ऑर्थोपेडिक सर्जन है, ना ही आप रिमेटोलॉजिस्ट हैं, वो हमारा मास्टर, हमारा पेशेंट है। हम अपनी गलतियों से एज ए सर्जन भी सीखते हैं, हम अपनी गलतियों से एज ए फिजिशियन भी सीखते हैं। कल से बहुत सारे विषयों पे आपने प्रकाश डाला, लोगों ने आपसे प्रश्न किया और आपने बहुत ही बढ़िया तरीका से स्टेप बाय स्टेप बातें बताने का प्रयास किया है। मुझे एक और छोटी सी बात याद आती है। इंग्लैंड में पहले सर्जन्स नहीं हुआ करते थे, बार्बर होते थे जो सर्जन का काम करते थे और उन्हें बार्बर सर्जन कहा जाता था। जब कुछ लोग पढ़े लिखे सर्जन हो गए तो उन्होंने बार्बर को कहा भैया देखो आप ऑपरेशन करते हो लेकिन जरा सा हम तुमको सिखा देते हैं एनाटमी, यहाँ पे ये नस है, यहाँ वो है, ये कट जाएगा। जैसे ही उसको एनाटमी बताने लगे बार्बर अब डरने लगा और उसने सर्जरी छोड़ दिया। हो सकता है हम में से यहाँ बहुत सारे लोग हैं जो आपने सारे कॉम्प्लिकेशंस इलाज के बताए हैं, कुछ लोग छोड़ दें कि भाई हम भले सर्जरी करते हैं, मुझे नहीं रूमेटोलॉजी के पेशेंट्स ट्रीट करना है। लेकिन वी आर ऑल बेसिकली MBBS, सो वी हैव दैट बेसिक नॉलेज। अतः मुझे लगता है कि आपके आने से, आपके साथ मिलने से, वो बात को तो हम मना नहीं कर सकते कि एक समय रूमेटोलॉजिस्ट हमारे पास आते थे कि हमारी बात सुन लो। बहुत सारी बातें वक्त के साथ बदलती हैं और आज सबसे बड़ी खुशी की बात है कि हमारे बुलावे पे आप आए हैं। डॉक्टर कौशिक, आप मुंबई से आए हैं, अमिताभ बच्चन की नगरी है, फिल्म सिटी है, और जब अमिताभ बच्चन फेमस हुआ था तो ही वॉज कॉल्ड एज एंग्री यंग मैन। आई फाइंड दैट एंग्री यंग मैन in you, but I think it comes from the fact that you have seen the mistakes committed by not only orthopedic surgeon, even general physicians, even GPs. So those experience can get translated into proper training of whosoever, but definitely an MBBS gets. मैं पूरे ही इज्जत के साथ कहना चाहता हूँ कि आपके कुछ रूमेटोलॉजिस्ट भी हैं जिनके पास रूमेटोलॉजी की डिग्री तो नहीं है, लेकिन उन्होंने रूमेटोलॉजी यूनिट में काम किया है और वो रूमेटोलॉजी की प्रैक्टिस करते करते काफ़ी परिपक्व हुए हैं। परेशानी तो यहाँ है कि मरीज बहुत हैं,
आप जैसे लोग या हम जैसे ऑर्थोपेडिक सर्जन जो रूमेटोलॉजी का इलाज करते हैं उनकी संख्या कम है। डॉक्टर राजकिरण, आपने भी अपने मधुर वाणी से अपने एसोसिएशन का बचाव किया और आप बिल्कुल सही हैं कि जिस तरह से इंडियन ऑर्थोपेडिक एसोसिएशन आपको फुल मेंबर नहीं बना सकती, आप भी हमें फुल मेंबर तो नहीं बनाते हैं लेकिन एसोसिएट मेंबर हम बन सकते हैं। सीखने वाले के लिए कहाँ कमी है किसी चीज़ की, आपके एसोसिएशन में, यूलार में, एप्लार में, एसीआर में जाकर लोग सीख सकते हैं और सीख पाते हैं। मुझे अंत में यह कहते हुए बहुत ही प्रसन्नता हो रही है कि आपने अपना बचाव सही किया और आपने एक बात उठाई थी कि आप एंकल रिप्लेसमेंट सर्जन बताओ। मैं प्रेसिडेंट फुट एंड एंकल सोसाइटी का पास प्रेसिडेंट हूँ और मैं जानता हूँ कि एंकल के एनाटमी को, स्ट्रक्चर को देख करके अब दुनिया में ज़रूर एंकल रिप्लेसमेंट होने लगा, अपने हिंदुस्तान में भी होने लगा, आपके बॉम्बे और पूना में भी होने लगा है, बट स्टिल इट इज इन nascent स्टेज। सो रिप्लेसमेंट हर जॉइंट में पॉसिबल है। फिंगर जॉइंट्स के रिप्लेसमेंट के लिए आप भी मरीज भेजते हैं हम ऑर्थोपेडिक सर्जन्स के पास। सो अंत में आप सबों ने अपना बचाव इतनी अच्छी तरह किया। हम दोनों के बीच में कब हम आपको मरीज भेजें और कब आप जॉइंट रिप्लेसमेंट के लिए मरीज भेजें, मरीजों की कमी नहीं है। ऐसा तो है नहीं कि हर मरीज का हम शुरू से इलाज करते आए हैं। बहुत सारे पेशेंट हैं जो नेग्लेक्टेड है, लेट आए हैं, डिफॉर्म्ड हो चुके हैं, उनका तो जॉइंट रिप्लेसमेंट करना ही होगा। और इन्हीं बातों के साथ मैं आज यह कहते हुए बड़ा ही संतुष्ट महसूस करता हूँ कि आप सबों ने अपना बिल्कुल सही बचाव किया और डॉक्टर अमूल्य आपने बहुत सारे अभियोग लगाए और मुझे लगता है कि कुछ और भी अभियोग अगर समय होता तो आप लगाते। आप वकील के रूप में बहुत ही दक्ष हैं। फाइनली मैं आप दोनों मुजरिमों को बाइज्जत बरी करता हूं और दोस्ताना हाथ अपने ऑर्थोपेडिक सर्जन के तरफ से आपकी ओर बढ़ाता हूं। बहुत बहुत धन्यवाद।
Thank you, sir. Our aim is a healthy and happy life of our patients ultimately. We all orthopedic surgeons need good guidance and supervision of rheumatologists like you to manage the rheumatoid patients in society. Thank you so much. Thank you. And I will request my dear friend, my younger brother Ramit, to kindly come forward for the inaugural function. To start with the inaugural function.
Everyone, once again, and on behalf of the entire organizing committee of Global Orthopedic Forum working behind this Aarcon 2024, I welcome all of you once again, and especially our chief guest, Mrs. Sambhavi Chaudhary. Welcome you, ma'am. So we are proceeding with the formal inaugural function, and for this, first and foremost, I'd like to invite on the stage our chief guest, Mrs. Sambhavi Chaudhary, ma'am. Please come on the dais, please, ma'am. A big round of applause for youngest member of parliament, Mrs. Sambhavi Chaudhary. She is MP from Samastipur and holds the record for being the youngest member of parliament. Next, I'd like to invite for the inaugural function somebody who is not only a father figure for Bihar Orthopedic Association, but also in true sense of the word, a father figure for rheumatology all over India, Dr. Professor S.S. Jha, sir. Please come on the dais. President BOA, Dr. Anil Kumar, sir. Please come on the dais. Secretary BOA, Dr. Praveen Kumar Sahu, and President of Global Orthopedic Forum, Dr. Sarsis Nanam sir, Director of Mahavir Cancer Sansthan, Dr. Manisha ma'am. Please come forward, ma'am. Dr. Amulya sir, Dr. Manish sir, the most renowned rheumatologist from very own Patna. Please come on the dais, sir. Now I request all the dignitaries to proceed with the lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हर्तु मे पापं सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम्
Thank you so much, dignitaries. Please stay back for a moment. Now, sounds down, please. From this year onwards, we are adding on another segment in the inaugural function, and as Dr. Amulya sir is known for his trailblazing abilities, and he has always been a trendsetter. तो इस बार उन्होंने कुछ नया एक ऐड किया है सेगमेंट इनॉग्रेशन में, जिसकी भूमिका के लिए मैं दो पंक्तियां पढ़ना चाहूँगा। मैंने एक चिड़िया पाली, एक दिन वो उड़ गई। फिर मैंने एक गिलहरी पाली, एक दिन वो भी चली गई। फिर मैंने एक दिन एक पेड़ लगाया, दोनों वापस आ गए। So these few lines symbolize a sign of hope. We've been talking about rheumatology since last evening, the various medical aspects, how we can go about treating with the help of medicines and with replacement surgeries. लेकिन rheumatology में एक aspect होता है निराशा का भी, the psychological aspect. बहुत बार rheumatology के patients डिप्रेशन में भी होते हैं, निराश होते हैं, और ऐसे में एक आशा की किरण उसे हम rheumatologist और ऑर्थोपेडिक सर्जन्स मिल करके दे सकते हैं। इसी को सिंबलाइज करने के लिए डॉक्टर अमूल्या सर ने सब लोगों को मिल करके एक हार्नेस करने के लिए ये मुहिम की शुरुआत की है। हाउ टुगेदर ऑर्थोपेडिक सर्जन्स एंड rheumatologists कैन water saplings and nurture them into beautiful plants as a sign of hope. Thank you so much, all the dignitaries. I request Sambhavi ma'am to stay back on stage and request all other dignitaries to please take their respective seats. I request our chief guest, Mrs. Sambhavi ma'am, to felicitate some of our guest faculties, and I'd like to initiate the proceedings. For this, I'd like to invite, first of all, Dr. Raj Kiran Dudam on stage and request Sambhavi ma'am to felicitate him with a certificate. This memento is in the form of a certificate with individualized photograph of the speaker, the faculty. All the pen has been taken by Dr. Amulya sir individually. So much of meticulous work goes into finding photographs of the faculties and putting them on certificates. Next, I invite Dr. Kaushik Bhojani sir on stage. Please come, sir. Dr. Kaushik Bhojani sir. I think after all the intense court proceedings, he has taken a break. Dr. Kaushik Bhojani sir. And next. कोई बात नहीं. Please, sir. This way. We had intense, heated debate, great court proceedings, and we just witnessed a wonderful debate. It gives me intense pleasure to invite our next guest faculty, Dr. Smriti Ramtake ma'am. Thank you so much, ma'am, for sparing so much time. I'm delighted to invite our next guest faculty, Dr. Shyamasish Bandopadhyay sir, on stage. Please come, sir. From Kolkata, has traveled all the way down to Patna. We had the privilege to listen to your oration, sir. I think Dr. Kavita ma'am has left just now. Okay. So I take the opportunity to invite Dr. Rajiv Ranjan Kumar sir. Please come on the dais, sir. Dr. Rajiv Ranjan. Has he also left? Okay. Dr. Bindyachal Gupta sir. Thank you so much, sir. We are delighted to invite our next guest faculty, Dr. Ishan Mishra from Varanasi. Dr. Ishan Mishra from Varanasi, I think he has also left. This program, indeed, is the brainchild of Dr. Amulya sir, but in association with Bihar Orthopedic Association, we've been performing this program over the years, and this time around we have had great support from the President of Bihar Orthopedic Association, and we'd like to call upon stage our guest of honor, Dr. Anil Kumar sir, the President of BOA, and request Chief Guest ma'am to felicitate him. I also invite the Secretary of BOA, Dr. Praveen Kumar Sahu sir, for all your support. You spared so much time last evening also. A very dynamic secretary of Bihar Orthopedic Association, also amongst the teaching faculties in the Department of Orthopedics at Nalanda Medical College, Dr. Praveen Sahu sir. Proceeding to the next few, uh, amongst the organizing committee, again the father figure, Dr. Professor S.S. Jha sir. Please come up, sir, and request Sambhavi ma'am to felicitate him. Dr. Sarsis Nanam sir, please come on the dais. Dr. Professor S.S. Jha is somebody whom we always love to listen to, a great orator, a great academician, always sparing time for academic activities and very benevolent towards his juniors. Thank you so much, sir.
बिहार की बेटी जिसे प्रधानमंत्री मोदी ने भी अपनी बेटी कहा और सांभवी जब चुनाव लड़ रही थी तो लोगों ने लिख रखा था हर जगह सांभवी है तो संभव है. That she is inaugurating this conference tells that it is going to be a great success and will show the path for our rheumatology patient to freedom from disease. सांभवी हमारी बहू भी हैं और हमने अपने चैम्बर से बैठ के उस समय जितने मरीज इनके एरिया से आए उन्हें कहता रहा, लेकिन देखिए अब क्या हो रहा है सर, वो फ़ोन करते हैं मेरा ये काम है, आप सांभवी को बताइए कि ये मेरा काम कैसे होगा. So I have to come to you again and again for wishing for completing their aspirations from you. But at the same time, I must tell you that your constituency persons say she is a different person and she keeps on coming. So keep making contact, frequent contact, and work for their thank you. Best wishes. God bless.
Dr. Sarsis Nanam sir, a very humble man, ever smiling, and the president of Global Orthopedic Forum. Dr. Dinesh Kumar sir, please come forward. And next in line is Dr. Jibendu Chaudhary sir. I request you also to kindly come up stage. Dr. Dinesh sir, he has always been an active member of the organizing committee of all activities of Global Orthopedic Forum, a very close companion of Dr. Amulya sir, a very loving senior. Dr. Ishan Mishra, if you have come, please be on the stage. Dr. Ishan Mishra, वाराणसी, उनका सर्टिफिकेट ले आइए. Now I take the opportunity to invite the next member of the organizing committee, Dr. Karunesh Ranjan. Dr. Karunesh, a very young, dynamic, handsome young man who does a lot of complex surgeries and shows a special interest in bone tumors and their reconstructive works. Dr. Karunesh. I can see the charming face of Dr. Nishikant. We all take so much pride in having you with us, Dr. Nishikant, and I welcome you. Next is the man behind the show. Guess his name. Dr. Amulya sir. And so many of the speakers last evening also reiterated that we all orthopedic surgeons, even now, amongst the allegations, there was so much that we all orthopedic surgeons primarily would love to operate, perform surgeries, because probably that involves more bucks. But then he is one person who has taken all the pain since all these years and has been holding rheumatology conferences.
For all of you, you know Ramit. I know much more than what you know about Ramit. He's a man who can stand with you all 24 hours. If Amulya has got some name in the society, lots of credit goes to this person. May I invite Shambhavi to kindly present this memento to Dr. Ramit Gunjan, a renowned orthopedic surgeon of Patna, the joint organizing secretary of this function.
Now I request Dr. Manisha Singh ma'am to kindly come up stage and present our chief guest, Mrs. Sambhavi Chaudhary ma'am, with a bouquet. Dr. Manisha Singh ma'am, the director of Mahavir Cancer Sansthan, the very elegant better half of Dr. Amulya sir, and a renowned oncologist. Now I request Dr. Mahesh sir, please come up on stage and present Sambhavi ma'am with a lapel pin. Dr. Madhusudan sir, please come up on stage and present ma'am with a memento. Now I request Dr. Upendra Prasad sir from Muzaffarpur, President-elect BOA, to present ma'am with a shawl.
Coming towards the fag end of this inaugural function, naturally कोई भी कॉन्फ्रेंस होता है तो कुछ अच्छे के लिए होता है, उस बीच में बहुत सारी यादें आ जाती हैं जिसके हिसाब से आप आगे चलते हैं। कुछ दिनों पहले मुझे मालूम हुआ एक लड़का जो बहुत ज़्यादा मुझसे जुड़ा हुआ था, पिछले 10 वर्षों से अगर मैं कोई काम करता था कहीं ना कहीं मेरे आसपास खड़ा रहता था हमेशा। वह मेदांता हॉस्पिटल में ही वॉज लाइंग इन द लास्ट ब्रेथ। मैंने जब क्रिटिकल मेडिसिन के डॉक्टर से पूछा, बोला कि सर उम्मीद नहीं है, शायद आज या कल कभी भी वो एक्सपायर कर सकता है। करीब 15 दिन पहले की बात है। 4-5 दिन बीत गए, कोई खबर नहीं आ रही थी। मैं 2 दिन तक मैं मेदांता में पूछा, उसके बाद मैं छोड़ दिया कि अब नहीं पूछता हूं क्योंकि अब क्या होगा, क्योंकि डॉक्टर वाज नॉट रेडी टू गिव मी एनीथिंग पॉजिटिव। बोला हार्ट 10% काम कर रहा है। एक्मो मशीन नेचुरली ऑल नो कि जब डॉक्टर प्रभात का प्रॉब्लम हुआ था हैदराबाद वो गए थे एक्मो मशीन लगाने के लिए। अनफॉर्चुनेटली ही कुडंट कम बैक। अ वेरी डियर फ्रेंड ऑफ माइन डॉक्टर लेट प्रभात। तो करीब 7 या 8 दिन के बाद मैं और मनीषा बैठे हुए थे। मनीषा को मैं हर चीज बताता था। मैंने मनीषा को बोला कि यार मैं सही बता रहा हूँ, प्लीज डोंट टेक इट अदरवाइज, यार श्राद्ध में मुझे जाना चाहिए उसके यहाँ, क्योंकि हमेशा मेरे साथ रहा। मुझे याद है 26 जनवरी को वो अपनी बिटिया को लेके आया था मुझसे आशीर्वाद दिलाने कि मेरी बिटिया आपको अपना आइडियल मानती है, सर इसको आप आशीर्वाद दे दीजिए। 7th में पढ़ती है उसकी बेटी। मैंने फोन किया, उसके यहां फोन स्विच ऑफ, उसके यहां जान पहचान वाले को, फार्मास्यूटिकल से रिलेटेड है इसलिए मैं बता रहा हूं, फार्मा के बहुत लोग हैं यहां। जिस लड़के ने उठाया फोन, मैंने केवल उससे पूछा क्या हाल है। उसने बोला सर आपका एहसान हम लोग नहीं भूलेंगे। बोले यार फोन कर लेने से कौन सा एहसान हो जाता है। मुझे था कि ये डेट बता दे मुझे किस दिन उसके श्राद्ध में आना है, क्योंकि डॉक्टर ने जवाब दे दिया है। बोला कि रितेश भैया अपने घर चले गए, ठीक है। सो शॉकिंग। मैं फोन रख दिया, मैं मनीषा के तो देख रहा हूं यार मुझे क्या बोल रहा है ये। एंड बाय गॉड ग्रेस ही इज विथ अस टुडे। रितेश कैन आई कॉल यू, वेयर आर यू? आज इसको देख के लगेगा नहीं ये आदमी 5 दिन एक्मो पे रहा था, और आज से नहीं बस 8 दिन पहले ये हॉस्पिटल से डिस्चार्ज हुआ, लेकिन आज उसी एनर्जी के साथ फिर मेरे साथ खड़ा है। ये होता है कि देयर इज समथिंग ग्रेट देन व्हाट वी पीपल आर डूइंग इन दिस वर्ल्ड। मेरे पिताजी हमेशा कहा करते थे दवा के ऊपर दुआ की जरूरत होती है। एक शॉल मैं चाहूंगा रितेश को, मैं मनीषा आपको भी रिक्वेस्ट करूंगा, क्योंकि वो 7 दिन मैं जानता हूं, हर दिन मैं इसके चर्चा करता था कि किस तरह से इसकी सांसें अंतिम गई होंगी। रितेश प्लीज कम हियर। और ये है एक फार्मास्यूटिकल और डॉक्टर्स के बीच का एक जिसको मिला के हम लोग को चलना है। So now it is a time to listen to our chief guest. Why I called her? इसका जन्म भी हमारे सामने हुआ है, शांभवी का, और नाम से बोल रहा हूं प्लीज। मैं जानता हूं इतनी प्यारी बच्ची है कि इसको कभी खराब नहीं लगेगा। ऑनरेबल, रिस्पेक्टेड और क्या क्या वर्ड जो मेंबर ऑफ पार्लियामेंट के लिए बोला जाता है और जो बाहर से आए हुए उनको मालूम होना चाहिए। यंगेस्ट मेंबर ऑफ पार्लियामेंट ऑफ इंडिया। बिग राउंड ऑफ अप्लॉज फॉर शांभवी। 25.5 साल की थी जब ये मेंबर ऑफ पार्लियामेंट बनी, और टुडे शी इज विथ अस टू ग्रेस अस। एंड रितेश वी आर थैंकफुल। 2 शब्द में आपका सुबह सुनना, उसके बाद शांभवी कोई।
जनरली लोग कहते हैं जिंदगी ना मिलेगी दोबारा, लेकिन मैं ये नहीं कह सकता। आप लोगों, सब लोगों ने जिसने मेरे लिए ब्लेस किया उसके लिए बहुत बहुत धन्यवाद। आई सर्च अ लॉट बट आई कुड नॉट फाइंड एनी वर्ड टू पे माई ग्रेटिट्यूड्स। सर के लिए धन्यवाद, इन्होंने फिजिकली, इकोनॉमिकली, इमोशनली हर तरह से मेरे फैमिली के साथ मेरे ब्लैक डेज में खड़े रहे। जब आदमी कमज़ोर होता है तो उसको ताकत चाहिए होता है लड़ने के लिए। जिस तरह कोई भी पूजा बिना अक्षत के पूर्ण नहीं होती है। जब मेरे फैमिली लड़ रहा था, थक रहा था, तब सर सपोर्ट करते थे, तो लगता है जब सर सपोर्ट कर सकते तो हम लोग क्यों नहीं लड़ेंगे। थैंक यू सर, आई कुड नॉट हैव एनी वर्ड टू पे माय ग्रेटिट्यूड।
थैंक यू। And it's now for you, Shambhavi, please.
थैंक यू अंकल। आपने कहा कि ऑनरेबल या फिर महोदया नहीं बोलते, बट हम सबको यही कहते कि मेरी जीत इसी में है कि लोग हमको सांसद महोदया नहीं सांसद बिटिया कहते हैं। एंड आई थिंक दैट इज़ अ ट्रू विक्ट्री। And before I start with my formal speech, I just want to take a moment to thank you all for the incredible work that you do. I come from a family where I have grandparents, I have very old citizens, and I know what role orthopedics play in their life. So thank you so much for that. Esteemed doctors and delegates, it is both a profound honor and a great pleasure to stand before you today at the inaugural function of Aarcon 2024. As we gather here at Hotel Chanakya in Patna, we are united by a common purpose, advancing our understanding and management of rheumatological conditions, including rheumatoid arthritis, both in pediatric and adult populations. I am deeply grateful for the opportunity to serve as your chief guest at this prestigious event. Your commitment to addressing these complex conditions and your dedication to improving patient outcomes is truly commendable. Aarcon 2024, organized by the Global Orthopedic Forum, represents a significant milestone in our collective journey to tackle the challenges posed by rheumatological diseases. This forum brings together leading national faculties and experts from across India, including Dr. Kaushik Bhojani from Mumbai, Dr. Bindyachal Kumar Gupta from Ranchi, Dr. Saimasis Bandhopadhyay from Kolkata, Dr. Rajkiran Dudam from Hyderabad, Dr. Kavita Krishna from Pune, Dr. Smriti Ramteke from Nagpur, and Dr. Ishan Mishra from Varanasi. If I have forgot to mention any names, I'm deeply apologetic. I welcome all the doctors and all the delegates. Their participation reflects the breadth of expertise and dedication present in medical field, and their contributions will undoubtedly enrich the discussions and enhance understanding. The focus of this year's conference is particularly significant. Rheumatoid arthritis is a complex condition that affects millions of people, causing considerable pain and impacting the quality of life. Your mission here is to explore the latest advances in management, share knowledge, and collaborate on new strategies to improve patient outcomes. As you all embark on this conference, I encourage all delegates and participants to engage deeply with the sessions, share insights, and collaborate. The exchange of knowledge that occurs here has the potential to drive significant improvements in patient care and treatment methodologies. Your work extends beyond these conference halls. It reaches into the lives of countless individuals who rely on your expertise and dedication. Let us commit to using this opportunity to advance our knowledge, enhance our skills, and ultimately make a positive impact in those we serve. Thank you to all the participants and organizers for your commitment to the important cause. I wish you all a successful and productive conference. I would also like to take a moment to personally thank Dr. Amulya Singh for inviting me to this prestigious occasion and making me a part of this enriching conference. I would also like to take a moment to pay my regards to Dr. S.S. Jha, who for us is not only a doctor but a guardian. I have seen him serve people endlessly, selflessly, and I just hope that God gives him more power to do so in the coming future. Thank you everyone and all the best.
The end of the inaugural function. We have got 2 more sessions to go. Faculties have to leave also to the airport. Friends, thank you so much. सारे रंगों को एक साथ एकत्रित करना एक डिफिकल्ट काम होता है, पर एक अच्छा गुरु जिसको मिल जाए, आई एम थैंकफुल टू डॉक्टर एस झा. इसलिए मैं आपका नाम पहले ले रहा हूँ. अपने ऑनरेबल रिस्पेक्टेड जो सांसद बिटिया की बात होती है कि कहीं ना कहीं अगर आपने दिशा नहीं दिखाई होती सर, हम लोग सफलता की तरफ नहीं बढ़ते. थैंक यू सो मच. थैंक यू शामवी फॉर gracing this occasion. Naturally, we all are indebted to you. All the respected guest faculties who have taken their precious time. मैं जानता हूँ जितने लोग हैं, मैं कोशिश कर भी फ़ोन से भी नहीं बात कर पाता था क्योंकि दे आर सो बिजी इन देयर ओन वर्ल्ड. उसके बाद वो 2 दिन लगातार आए, यहाँ पे आए पटना की धरती पे. मोस्ट ऑफ देम हैव कम फॉर द फर्स्ट टाइम, और ये कारण संभव हुआ हमारे रिसेप्शन कमेटी चेयरपर्सन डॉक्टर मनीष. डॉक्टर मनीष, ही वॉज सफरिंग फ्रॉम चिकनगुनिया, वहाँ से ही हैज रिकवर्ड. परसों तक शाम तक बुखार था बार बार, लेकिन ही केप्ट ऑन मैसेजिंग मी, सर ये हो रहा है, मैं कोशिश कर रहा हूँ. मैं बार बार बोलता था यू टेक रेस्ट. कल भी वो शाम में आप देखें करीब 2.5 से 3 घंटे वो वहाँ बैठा. आज भी करीब 11 बजे के बाद से 10 बजे के बाद से ही इज़ हियर ओनली. थैंक यू मनीष फॉर ग्रेसिंग दिस ओकेजन. ऑल द फैकल्टीज हु हैव कम हियर जस्ट बिकॉज ऑफ यू ओनली, दे ऑल बिग शॉट्स. आपने कोशिश किया और उनको बुलाया. ऑल रिस्पेक्टेड डेलीगेट्स, आप लोग जो आए, समय दिया है सीखने के लिए. नेचुरली हम लोग जो आज बातें हो रही थी आर्कॉन की अदालत में, हम लोग सीखेंगे, कुछ अच्छा के लिए करेंगे, बाकी जो नहीं कर पाते वो उनको भेजेंगे, उनके पास हमारे मरीज जाएंगे. और रिस्पेक्टेड डॉक्टर अनिल कुमार सर, माय गार्जियन, माय एल्डर ब्रदर प्रवीण, माय यंगर ब्रदर, बिहार ऑर्थोपेडिक एसोसिएशन के साथ मिलते हुए हम लोग हमेशा काम करते रहे. ये बिहार ऑर्थोपेडिक एसोसिएशन की पहचान है, और कोई भी कार्यक्रम तभी सफल होता है जब सारे फार्मास्यूटिकल कंपनीज साथ जुड़ जाते हैं. आई एम थैंकफुल टू ऑल ऑफ यू. बिग राउंड ऑफ अप्लॉज फॉर द फार्मास्यूटिकल कंपनीज एट प्रेजेंट. यू हैव गिवन मी दैट सपोर्ट. और जब सबसे थक के हार जाता है तो उसको एक पत्नी का सपोर्ट चाहिए. आई गॉट इट. थैंक यू मनीषा फॉर स्टैंडिंग विथ मी. एवरी वीक आई बीन ट्रैवलिंग. वो बार बार मुझे यही बोलती है कि आप कीजिएगा कैसे. आप शिलोंग जाते हैं एक सप्ताह, फिर अगले सप्ताह श्रीनगर जाते हैं, फिर मैं थर्ड को फिर श्रीनगर जा रहा हूँ. लेक्चर्स के लिए घूमने नहीं जा रहा हूँ प्लीज. और तो उसके साथ आजू बाजू में जो ऑर्गेनाइजिंग कमेटी का नाम सुना, डॉक्टर रमेश, डॉक्टर जीवेंद्र चौधरी, माई प्रेसिडेंट डॉक्टर सरसिस नैनम, सब लोगों ने मिलकर लगातार साथ दिया है. करुणेश, आई लव यू ब्रदर, यू आर लाइक माई सन आई विल से. मैं 10th से तुम्हें ग्रूम कर रहा हूँ. वो जब 10वीं कक्षा में थे तब से मुझे याद है कैसे तुम गए लखनऊ, वहां से कैसे तुमने पीजीआई रोहतक पहुंचे हो, एसआरशिप किया. हर चीज मैंने देखा है और शायद ये किस्मत का फल होता है. यू गॉट अ ब्यूटीफुल वाइफ. सो गॉड ब्लेस यू. सब लोगों को मैं फिर से शुक्रिया अदा करना चाहता हूं, धन्यवाद देना चाहता हूं. प्रेस मीडिया आपको धन्यवाद देना चाहता हूं. चाणक्य के सारे स्टाफ उनको धन्यवाद देना चाहता हूं. यू हैव मेड एवरीथिंग एफर्टलेस. We are enjoying your hospitality and audiovisual people also. My photographers also, Saima and Abhay. Thank you very much. Now we will proceed to the next session. Vikas, it is for you, moderator. Please come here. और Dr. कौशिक को जाना है, उनका सेशन पहले कर दिया जाएगा. So maybe can you stay here to listen 1 or 2 lectures as per your convenience? Yeah, I know. You are really busy. You have given us so much time. So Vikas, please start with the next session.
Yeah, please, sir. Please, I'd like to invite you on desk. Dr. Upendra, sir, from Muzaffarpur. Dr. Arun, sir, please. And Dr. Mahesh Prasad, sir. Now I like to invite our speaker, Kaushik Bhojani sir from Mumbai. Please, sir. Amitabh Bachchan.
कल वाला टॉप, कल वाला ओपन yesterday 28/9. उसमें मेरा खोल दीजिए. कौशिक एस भोजानी. गो डाउन. Can I start? Good afternoon, everyone. I continue from where I left off yesterday because this is actually 2 parts out of 3 of a teaching session that I hold for orthopedic surgeons actually. And this is something where if I can orient you and if I can give you a flavor of rheumatology, then I've done my job. The beauty of rheumatology does not lie in making a diagnosis. The beauty of rheumatology lies in excluding what is not supposed to be your diagnosis. So when Professor Jha was saying something, I loved it because, you know, there's a true story. There was a young doctor who started practice diagonally across a very senior doctor. And after 1 year, his practice wouldn't pick up at all. The senior doctor's practice wouldn't stop. So he went there and said, sir, मैं gold medalist हूँ, सारी किताबें पढ़ी हैं, आपकी लाइन खत्म होती नहीं, मेरी शुरू होती नहीं, चक्कर क्या है? So the senior physician laughed and said, after 30 years of practice, I know what not to do. And so what I want to give you is precisely that, what I was teaching yesterday and what I'm taking forwards. Most people would like to teach you what is there, but that every intelligent, see, orthopedics, to get admission into orthopedics, you need to be a topper. We are talking about high IQ doctors out here. They know how to read the books and they know how to read the guidelines. But what the books do not teach is what not to do. So this is what we go through before we decide what is not rheumatoid arthritis. And we've missed anything or everything. And these are the kind of arthritis that you're going to see before you're going to call it a rheumatoid arthritis, because if you have a rheumatoid factor, a CCP positive, your classification criteria are matching, clinically the patient has got PIP joints and so on, you're fairly certain. But the game starts when you have a low titer rheumatoid factor, the CCP is either not available or negative, and the patient doesn't have classical polyarthritis, symmetrical small and large joints. What are you going to do there? And that's how you exclude before you say, yes, this is seronegative rheumatoid arthritis. So this is where I got up yesterday and objected to the chairperson. He's sitting there. And I'm sorry, sir, I don't know your name, but Raj. So this is where we start. Judicious investigations. I am not an angry young man. I am an extremely passionate man. It just reminded me of the fact that maybe my bloodline is like this, because when my father joined ICICI in 1973, he was called the angry young man. And when he retired in 2001, he was told he was called the angry man. Only the young went out. And I'm 54, so I am not surprised if it's just the bloodline. But this is possibly the way I teach, because I am more emphatic. I want to send home points so that they stay, so that somebody will benefit. And so whether to perform a test or not depends on your history and physical examination. I was talking to Dr. Singh this morning about the fact that there's a 26-year-old boy who is still admitted in Fortis. I was asked to see him 8 days ago. He was seen by 3 orthopedic surgeons and 2 spine surgeons for severe back pain, mid-back to low back, difficulty in turning sides in bed, unable to get out, right hip joint lying in an externally rotated position, unable to move it, and this gentleman had a relatively high ESR, falling hemoglobin, counts somewhere around 12 to 13,000, albumin slightly on the lower side, globulin slightly high, which were done by the spine surgeons, not by the first 3 orthopedic surgeons, but obviously the spine surgeon, who's also from the orthopedic background, was wiser. He was wiser because there were x-rays available, there were basic tests available, and so on. So he went a little further and he did an MRI spine, a plain MRI spine, and this is where I was talking yesterday. The MRI is not wrong. We asked for the wrong MRI. And so you should know what to ask for, and that comes from the history. So a plain MRI LS spine was done, and the patient was declared as a psycho. His vitamin D was 14, he was given 2 shots of Aracetol, NSAIDs, no response to NSAIDs, back pain में कुछ मुझे दिख नहीं रहा है, inflammatory नहीं है, fracture नहीं है, psycho है, your son is depressed. Okay, and I was called in to see this patient on that Anant Chaturdashi, one day after Anant Chaturdashi, and when I saw this boy, the first thing that struck you was he was sweating in a centrally air-conditioned hospital. Temperature was 99.4, and I asked, are you eating well? And he said, I have lost weight, I have not been eating properly. And I tried to flex his hip and he wouldn't let me. And there was an X-ray PBH available. So I got a contrast MRI done of the pelvis, and it had marrow changes all across. I did a biopsy with a PET scan. This guy is a leukemia, and he's missed the diagnosis by 3 months, so he's advanced now. This is what I mean. Did we ask for the right MRI? Did we get that history? Did we listen to the fact that he's not eating? Did we listen to the fact that he's sweating even in an AC? That's what I talk about. So tests do not arising from such a base will cause more confusion than clarification, and this is what I want to drive home. Please do the test, please investigate. But in order to listen to that, sir will agree with me, he's a clinician first. He decides his tests on the basis of what he examines. Nowadays, we write the tests while listening to the patient without touching the patient. This is the truth, whether you accept it or you not is absolutely up to you. So for every 20 healthy individuals tested, the law of averages says one will have an abnormal report. So if you get a case of fibromyalgia, and if you are going to turn around and start doing HLA-B27s and even vice versa, you think female spondyloarthropathies don't happen? Of course they happen. But you've decided the patient is paining all over, and so you've decided that this patient looks all right from the front, and so you've decided that this patient is FM, and you're going to lose it. So interpretation of investigations, whether it's a rheumatoid factor, whether it's a CCP, are you having elevated globulins? Do you know how to interpret that anemia? Have you actually looked at the red cell indices? All of y'all have learnt it at Sir mentioned, all of us are MBBS, isn't it? All of us knew how to look at a hemoglobin. But then why is a laboratory giving you 18 parameters on a CBC? And why is it highlighting a few of those parameters in bold? But we don't want to read that. We don't want to look at that, and that is where we sometimes miss. Now we are going to give 15 milligrams of methotrexate to a patient whose hemoglobin is 9.5 grams, and we're saying this is anemia of chronic disease without seeing that the MCV is hovering around 99.5. So the patient is B12 deficient, and you've turned around and given the patient 15 milligrams of methotrexate, and then the patient goes into bicytopenia. I don't think the patient is at fault. I don't think the patient's body is a problem. We didn't read that report. Synovial fluid rheumatoid factor thankfully is not done anymore, and so most people don't do it, and so there isn't an issue. I think I have given you an example and covered about the MRI. I could give you loads more, and just to give you an example, I had a patient who was sent to me from Kolkata. The patient was not seen by, was seen by a physician, related to a doctor family, ocular swelling around the eye, biopsy, lacrimal biopsy done. It was told this is dacrocystitis and so on. And this patient actually was a lymphoma around the eye. So this is, how are you going to interpret that PET CT? When are you going to do a PET? When are you going to do an aortogram? When are you going to do the nerve conduction study and make sure that the joint pains that you're seeing are not because of a vasculitis and they are only a rheumatoid arthritis? That's the game. And which part are you going to biopsy? So I still have 5 minutes. I want to drive home the fact that a gentleman admitted under an orthopedic surgeon came with an MRI, unable to move his right hip at all, completely frozen hip, sir, severe pain. And the patient was exposed to an MRI which was done, a plain MRI with the pelvis was done, and no note given to the radiologist. We expect the radiologist to do magic, isn't it? But those poor people are sitting behind a monitor without a history. How often have we picked up the phone and spoken to the radiologist that this is what I'm looking for? So when my name was being announced out here right now, and I came running in with my phone, I was talking to my head of radiology in Fortis, because there was a 26-year-old boy with fever and severe neck pain, treated as meningitis with 2 hospitalizations 1 month apart, 1 month each, 6 months apart. Over 6 months he's had 2 1-month hospitalizations, and now he's transferred to our hospital, severe neck pain, and they've done everything before sending the patient. So they've done an MRI brain, they've obviously done all of that, and they've even done a cervical spine MR, okay, not showing anything. He had ear pain and sinusitis before each episode, so even the ENT eval with Hopkins laryngoscopy has been done. He's bringing up fresh blood every time, every day, 3 times a day. Actually, TID, he's bringing out blood. He feels a sour eructation coming up, and then he brings out fresh blood. So I was just talking to the radiologist saying, have we looked at carotid vasculitis? Because his pain is coming down, severe pain down the sternocleidomastoid, and he is not responding to any NSAID. So the history and understanding how to interpret. This is very easy for every orthopedic surgeon. You will see the subcutaneous nodule and you will see the joint pains, you will know it. But what not to do is stop where you see that the eyes are turning red, because that means this gentleman is now developing vasculitis, and you trying to treat the vasculitis might get difficult. Take the help of a rheumatologist, continue to treat whatever you want. So a proposal that I make in Mumbai to every physician and orthopedic surgeon is, usually specialists look for referrals from them and they are the ones who do it. My case is exactly the reverse. I say I will refer you the patient because I don't have appointment slots. I'm booked for 3 months. You look after the patient, you treat the patient, give me a call every month, let me know what's happening, send me the blood work so that I don't have to worry about the patient you're looking after. I'll see the patient once in 6 months. It helps you, it helps me, it's a win-win situation for the patient. So this right hand side lower eye and this one, this patient was a case of joint pains because of Sjogren's syndrome. Mind you, every Sjogren's syndrome will have a rheumatoid factor strongly positive. Rheumatoid factor is got a sensitivity of 67% in rheumatoid arthritis, but 90% in Sjogren's syndrome. And they will all have joint pains. And so this patient had dry eyes, and this patient had a fall, fractured her spine, naturally went to a spine surgeon, was given NSAIDs, was put on bed rest, was done, all the right things were done. But because the pain was unbearable, the patient was put on a combination of pregabalin along with 25 milligrams of nortriptyline, along whatever, for pain relief, okay? The intentions were great. But see what happened to the eye, it ulcerated. So, if I can humbly request you, what is important is to know what not to do. What to do is fine. So if you read on top it's Sjogren's syndrome, pick up the phone and talk to the rheumatologist. This is what I want to give. Do you have a problem? It just takes a phone call. And so before treating, this is what we do. And I am going to sign off in the last 50 seconds with this. So this is a photograph I showed you yesterday. This patient presented as rheumatoid arthritis, but look at the face, look at the cheeks, and the faint red rash on the cheeks can pass off as acne. Look behind the ears, and what you thought was a rheumatoid arthritis was actually a psoriatic arthritis. And this one I showed you, I am going backwards, is it? Yeah. We write allopurinol very commonly, isn't it? We just write it for every uric acid of 6.1 and 6.2. And then this is what happens, because a 6.1 and a 6.2 doesn't need treatment. Now uric acid is down your alley 500 times more than a rheumatologist's alley. Forget rheumatoid arthritis. All the gouts come to you. Every gout goes to an orthopedic surgeon, and most times it doesn't reach a rheumatologist. This is when the patient reaches us. Why don't you know about it? Because the patient didn't come back to you. This is leflunomide-induced vasculitis. So Dr. Nimish Nanavati, who's a very senior rheumatologist in Mumbai, is about 66, 67 now. His son has started practicing rheumatology. He used to say, I have stopped more leflunomide than started it. And that applies to tofacitinib, and I'll come to that in the next slide. But this is methotrexate given in wrong doses, given over. Somebody was asking Smruti or Raj yesterday about the fact that can we split the dose over 2 days of the week and so on, provided the gap between 2 doses is 5.5 days. So you give it on 2 consecutive days. Don't play around with Monday, Wednesday, Tuesday, Friday. Don't come up with your new regimens, because you will land up in a mess. And this is what happened. And this is methotrexate-induced hypersensitivity pneumonitis. This was on a patient who was given methotrexate 20 milligrams starting, and this is what I had to handle. He was in the ICU on ventilator for a long, long time, finally pulled out. SAZO, which is thought so commonly. I have a patient who's lost her vision because of Stevens-Johnson syndrome. So have you looked at the history of sulfur allergies? We all talk about SAZO, but if we forget that the content is sulfasalazine. When we give it to a male patient, we don't do a G6PD. And when we give it to a female patient, most of them are carriers, but we don't bother to see this. HCQ causes psoriasis as well, apart from the bullseye maculopathy, and the bullseye maculopathy is irreversible. And hence, make sure that you know that the patient is diabetic or not, the patient has got a ocular issue or not, the patient is a high myope with a thin retina or not. And the beautiful tofacitinib, which has now replaced methotrexate and leflunomide on every orthopedic surgeon's pen. So portal thrombosis, pulmonary thromboembolism, because of extensive DVT, myocardial infarction with cardiac failure are just some of the complications that where I've had to stop tofacitinib. I'm not even going to bore you with the number of pyelonephritis and the number of other major infections like pneumonitis and so on that I've had to deal, because the patient was not adequately evaluated to see the fitness. If the patient is diabetic, you are in a mess with tofacitinib. Half of them are. If the patient is adequately immunosuppressed and tends to get sinusitis frequently, you have a problem. If the patient's urine is not clean, you have a problem. There's an extensive workup. Dr. Rohini Handa had said 6 years ago, predicted 6 years ago when it first came out, and said that it's going to come as a generic soon. Once it's going to come as generic, you and I are going to handle only the complications created by others for tofacitinib. And I had actually laughed, and I have had to eat humble pie because he was so right. This is what is happening with us with tofacitinib now. So the moral story before I close, this is on my last slide, sir. I won't take any, I appreciate the fact that Dr. Amulya Singh gave me 2 more minutes. I had requested 2 more. Necessary, otherwise you're going to land up in a mess. So please do prescribe, treat. We are happy to be available on the phone. Cartoons like me work long hours with our phones on D&D, but send me a message and I'll call you back. And in all sincerity, I'll give you the best advice possible, because at the end of the day, you're not my competitor, you're my friend, and you're going to help another patient. It may backfire if the appropriate drug is not used, understanding the background, and it may not be safe. We play around with toxic drugs, and that's all that I want to leave you behind with. Thank you very much.
Yes. Thank you, Dr. Kaushik Bhojani, for your excellent and informative information. What to do and what not to do, both are important. So our next speaker is Dr. Shyamashis Bandopadhyay.
Right. After an extensive teaching session from Kaushik, we are into domains of making treatment little cheaper for patients. As we know that in outpatient practices, 70% of our patients are self-funding. So any money that is saved is a big saving for them. So biosimilars, you all are well aware of this term biosimilar. A lot of biologics which say 15 years back used to be quite expensive has become more and more affordable. So we are going to talk a little bit of what biosimilarity is and how do we go forward. Now, traditionally, pharmaceutical companies have developed chemical drugs, which are like aspirin, acetyl salicylic acid, to treat a wide range of illnesses. Since 1970, a revolution in biotechnology has made possible these new drug biologics. So this is a large protein molecule typically derived from living cells and used in treatment of various conditions. The therapeutic targets are proteins, DNAs, monoclonal antibodies, fusion molecules, and generally the size is about 1,000 times bigger than the standard drug. Examples are like growth hormone, insulin, erythropoietin, vaccines, monoclonal antibodies, so on and so forth. So the difference from a normal standard drug and a biologic is in the size. Aspirin, acetyl salicylic acid, is of 21 atoms. Growth hormone is of 3,000 atoms. and monoclonal antibodies are of 25,000 atoms. So you can see the size difference. Structure, they can be of multiple degree structures. And bonding in normal drugs are normally covalent bonding, and here there are both strong and weak bonding. So there are legally approved biosimilars, which are subsequent versions of the innovator biopharmaceuticals following expiry of the patent molecule. And because the structural and chemical complexity, these biological products are considered similar but not generic equivalent. WHO and FDA all have got separate definitions of biosimilarity, and based on these definitions, it should be a biologic agent. The reference product should be already licensed for that biologic agent. Demonstration of high similarity in safety, quality, and efficacy. And similarity should be demonstrated using a set of comprehensive comparability exercises. One has to understand that biosimilars are unlike generic medications, where the active ingredients are identical. Biosimilars, by definitions, are not likely to be identical from the original biologic. So, original biologic and a biosimilar molecule will never be identical like snowflakes. So, if you see a snowflake, two separate snowflakes can never be identical. Different manufacturers will have different biosimilar. So, if you see these biosimilarity biological proteins, there are small peptides like insulin, there are medium-sized peptides like erythropoietin, GCSFs, and there are larger proteins like eye injections, chemotherapeutics like Herceptin, Avastin, etc. So one has to understand the production of a biologic involves a genetic code of a chosen protein, such as immune system antibody is identified and replicated for a functional DNA sequence. These DNA sequences are introduced in a host cell, and these genetically modified cell lines are carefully selected, the master cell line, and cultured to produce large biosecretor factory and produce of the biosimilar molecule. Biologic manufacturing is a complex phenomenon. Hence, biosimilar molecules will always be different. If we look at the complex manufacturing process, then we will see that there will be a proprietary knowledge, and there's an immense difficulty in accurately duplicating this protein molecule. So one would think that, well, with all this difficulty, when you create a biosimilar, what's the advantage? The biosimilar advantage is it allows wider and easier access to these agents. Hence, the cost is lower, and it will not only improve the cost effectiveness, but also improve drug accessibility. So worldwide, there is a growing trend of use of biosimilar molecules, and the safe and regulated introduction of biosimilar molecules in the market has been forecasted to increase access of these medicines and reduce cost for our patients. There are lots of concern in these biosimilar molecules. One would understand that because of their different origin, whether they would have similar biological effects, whether the toxicology and the side effects will be same or different. So there is obviously need of very thorough testing for these biosimilar molecules overall. Efficacy wise, if you look at erythropoietin, which is a very small molecule in biologic range, there are 11 erythropoietin molecules which are available for 4 different countries: Korea, Argentina, China, and India. And there is significant diversion between these 4 molecules, and the similarity can vary between 70 to 220%. So you can have extremely efficacious erythropoietin from some country in some batch to a very ineffective erythropoietin from other country of same molecule. So this is something which needs to be clearly understood before one prescribes a biosimilar molecule for their patients. As Raj Kiran was telling, that we practice please don't harm. So this is something which we keep in mind always. So there's extreme importance of pharmacovigilance for these molecules overall. Now, biosimilar allows us to substitute the dispensing of a generic drug to a prescribed IP, and hence produces a lot of cost saving. Now, one should not decrease the safety, should not have an uncontrolled substitution, and should keep an eye on the adverse events. All the biosimilars carry a unique INN number, and that is something you should check before you actually prescribe somebody. So there are globally accepted standards from WHO starting from 2009, and one cannot write every molecule as a biosimilar molecule unless these set standards are matched. So it's a regulatory term which is there to denote comparability between a biosimilar and its reference medical product. Regulatory bodies have got a stepwise approach to demonstrate the biosimilarity, and there must be clinically meaningful difference between safety, potency, and purity. So there is terms like equivalence margin in the field of biosimilarity, and one should have a reasonable equivalence margin because before prescription. So all these molecules which we commonly use in our rheumatological practices like etanercept, infliximab, adalimumab, you have an equivalence margin of -15 to +15, so on and so forth. So you could see that for individual molecule there is an equivalence margin for the molecule to be accepted as a biosimilar molecule. We as a group have done some studies in biosimilarity overall. So this is one publication in clinical rheumatology of efficacy and safety of a biosimilar molecule of a particular variety for the treatment of patients with moderate to severe RA following failure of conventional DMARDs. We also have studies, I was part of an expert panel consensus of using biosimilar rituximab in rheumatoid arthritis in India. We've got Euler and Appler presentation of modified dose rituximab biosimilar in rheumatoid arthritis comparing B-cell depletion effect and disease activity. So the standard dose regime, which is 1 gram in 15 days interval for rituximab, modified dose is 500 milligram in 15 days interval of a biosimilar molecule, and the RA outcome measures in 12 months post biosimilar rituximab therapy is here, and one could see that it is effective. There are Euler presentation of same nature. Comparative evaluation efficacy of adalimumab biosimilar of a particular company with a reference molecule and publication in one of the journals. Efficacy and safety of ADA biosimilar of a company in Aarcon, and continued effectiveness of a biosimilar ADA after stoppage of the initial treatment of patients with Aarcon. So a lot of biosimilar work we have done and seen because of our continued interest in biosimilar molecule being cheaper and more affordable for our patients. It's a similar ADA after stoppage, and altered dose regime of infliximab in Aarcon, which is in comparison of an infliximab biosimilar, and so in India overall, the scenario of Indian Global market for Indian non-innovator products are approximately USD 1.5 billion. So it's a big market. Estimated exports of Indian biopharma products are increasing quite rapidly, as you all know, and good acceptance of non-innovator products amongst healthcare professionals and patients, and homegrown biopharma industries actively developing and marketing non-innovator products in India. So biosimilar molecules in various fields, not only in rheumatology, but also in endocrinology and also elsewhere in hematology, are becoming more and more acceptable in Indian scenario. So in summary, biosimilars are highly similar versions of already authorized innovator biologicals. They demonstrate no clinically meaningful difference versus their innovator products in terms of efficacy, safety, quality, and biological activity. They must meet strict criteria of quality and comparability, and have demonstrated growing acceptance and use in Indian patients. So with more and more innovator drugs going off patent, there is urgent need to regulate this increasing number of copy biotherapeutics. New non-innovator biotherapeutics should be made available as soon as patent protection is over, so that economically compromised patients have an option to opt for cheaper copy versions, which reduces cost of drugs, now a global priority, rather than just being a major issue in developing economics. This is becoming more and more important, and here India is actually showing route towards the global world in line with countries like Korea and Taiwan and China. Of course, I cannot exclude China from that discussion, in making biosimilars more and more available for various conditions as a cheaper alternative to our Western world. Thank you very much for your hearing.
Thank you, sir. So may I request Dr. Vidyanchal to speak on recent advances in management of rheumatoid arthritis.
Good afternoon to all of you. I'm going to tell you about the recent advancement in the management of rheumatoid arthritis. As we know, rheumatoid arthritis is the most common inflammatory disorder you encounter in daily clinical practice. We should know about the drugs which are being used, because day to day there is increase in the number of drugs we are using, but they also come with a lot of side effects. So everybody is using, and because it is your right to treat the patient, you should have the proper knowledge about the drug, not only the effectiveness as well as the side effect the patient may encounter. So it is very, very generous to use it. We know it is a commonest inflammatory joint disease affecting approximately 1% of the population. It is the most common in female, and the ratio is 3:1. If it is not treated, it can lead to deformity and joint damage. When go for the pathogenesis, there are some risk factors. About 60% they are contributed by genetic constituent, and most of them come from the presence of SER epitope. It is a sequence of 5 amino acids in a HLA-DR beta gene of sequence 20 to 24, which confer the risk for the development of seropositive rheumatoid arthritis, especially anti-CCP. Non-genetic risk factors, it contribute to 40% of the cases, and the most common is smoking. As such, there is no diagnostic criteria for rheumatoid arthritis. Most of the time we make a clinical judgment, because it is the most common inflammatory arthritis. If it is symmetrical, polyarticular, involving lower and upper limb, and it is chronic in nature, we can be a rheumatoid arthritis. These are classification criteria jointly given by ACR and EULAR in 2010 for the classification. It is not a diagnostic criteria as such. For diagnosis, we need some lab tests, but before lab test, it is a history and examination, which will give you a clinical clue whether the patient is inflammatory arthritis or not. So always go for clinical examination. And then there are some blood tests, routine like ESR and CRP, they are inflammatory markers. RF anti-CCP, we know RF and anti-CCP, these are the diagnostic tests for rheumatoid arthritis. RF and anti-CCP has a sensitivity of around 60 to 70%, while specificity, anti-CCP is more than 95% specific. At the same time, you should know around 20 to 30% patients, they remain seronegative. So it is a clinical examination and the presence of rise in inflammatory markers which give a clinical clue that is inflammatory in nature, and it could be seronegative rheumatoid arthritis. When you go for the reset advancements, we can broadly describe into two. First, with increase in the number of drugs, the target become more and more specific. And first, you have to, there is a concept of treat to target. We have to make a target. We have to, before starting a treatment, we have to set a target to treat the patient. And the second, there is increase in the number of drugs with a specific targets. This is also highlight in the recent EULAR and ACR guidelines, which is the concept of window of opportunity, which conclude that DMARD should be started as soon as possible. Once you make a diagnosis of rheumatoid, don't wait. Thus start DMARDs at an appropriate dose and follow treat to target strategy. What is the, how it will improve the prognosis of the patient? Look, this is the chart will give you the idea. If the patient is present in the late or you're going to start with the DMARDs, there will be more chances the patient goes into trouble and there is a lot of irreversible damage. Once we start early, we can prevent the damage to the joints. Treat to target strategy, we have to make a target. We have to monitor every 3 to months, and the most ideal target is remission. If you are not able to maintain remission, it is the low disease activity, which is the alternative to treated to target strategy. This is the increase in the number of drugs and a historical overview over the number of drugs which are adding for the treatment of rheumatoid arthritis. And for the last 5 to 10 years, there is only a single class of drug which come into attention everywhere is JAK inhibitors. So mostly JAK inhibitors, they are used everywhere. Whether it is a rheumatoid, ankylosing, vasculitis, myositis, they have become the drug of everywhere. Classically, we classified into DMARDs into 3 classification: conventional, which includes their small molecular weight synthetic DMARDs; second, biological DMARDs, which are monoclonal antibody or less often soluble receptor construct; third, it is a target synthetic DMARDs. What are the problems we are having with the conventional DMARDs? They are ineffective up to 30 to 40% cases of rheumatoid arthritis. Second thing, they have a non-selective action, so more often they have come with a lot of side effect. Then comes to the biological DMARDs, but they are very efficacious drug, but at the same time, if we had a problem with the biological DMARDs, they are large proteins, so they require parenteral administration. Second thing, they are immunogenic, they are potentially immunogenic, so there is a chances of production of anti-drug antibodies. So what are the consequences? There is a reduction in the efficacy and more development of infusion reactions. Then there is a come with the latest molecules, they are JAK inhibitors. They are small molecules which could be taken orally. This is the change in the scenario we are used as a concept of using DMARDs for the last 5 to 10 years. Before 5 to 10 years, conventional DMARDs is the first drug of choice, but later followed by anti-TNF therapy. But for last 5 to 10 years, conventional DMARDs, they are followed by JAK inhibitors. JAK inhibitors took the place of anti-TNF and they become the more and more used drug in case of rheumatoid arthritis. So what are JAK inhibitors? JAK inhibitors, they are the newest class of drugs. They are intracellular non-receptor tyrosine kinases. There are 4 family of JAK, 4 member of JAK family consist, which include JAK1, JAK2, JAK3 and tyrosine kinase 2. These are the 4 JAK inhibitors which are available, which are approved by European and FDA guidelines for the treatment of rheumatoid arthritis. The first one is tofacitinib. Tofacitinib is a pain JAK inhibitor, followed by baricitinib, upadacitinib and filgotinib. This is the mode of action. Any cytokine, they bind with the receptor. At the intracellular side, there are JAK inhibitors are there. Once cytokine binds to the receptor, there is an autophosphorylation of the JAK molecule. In turn, JAK molecule causes phosphorylation of the state dimers. There is a formation of state dimers which translocate into the nucleus, and there is an activation of respective genes. And these are the whole family of the cytokines which are act through JAK family of intracellular receptors. That's why they are become the JAK of all trades, because a lot of cytokines they act through these intracellular receptors. These are the approval of JAK inhibitors. Tofacitinib is the first, which comes in 2012. Pafacitinib is the molecule which is approved only in Japan. These are the FDA approval of tofacitinib, where you can use JAK inhibitors, rheumatoid arthritis, psoriatic arthritis, polyarticular JIA, and ankylosing spondylitis. But it is a very good molecule, but when we have a when we had a very good role, remember, with great power comes great responsibility. There has been a misuse of JAK inhibitors. In day-to-day clinic practice, we are seeing most often we see a lot of prescription with JAK inhibitors without any risk stratification or without any proper screening for prescribing JAK inhibitors. And often they are using as a first-line treatment to every one patient who are suffering from joint pain. Second, there is no any screening protocol that should be followed before prescribing JAK inhibitors. Third, there is no stratification strategy. So tofacitinib now become a TOFI. They are every patient who are coming with a joint pain, they are giving tofacitinib. They become the first-line treatment. So it is always be advisable to should be given in an approved recommendation and prescribed only after failure, ineffective, or the patient is intolerant to conventional DMARDs. There should be a screening protocol. You should follow. Screening is mandatory. All patients who are going to prescribe a JAK inhibitors. First, hepatitis B, hepatitis C test, Montox or quantiferon TB gold, and chest X-ray. If any patient, because tuberculosis now it is endemic in nature, endemic in India, and the patient who are on biological DMARD or JAK inhibitor, they are risk of developing tuberculosis. It is 4 to 8 times risk as compared to general population. If the patient have a latent TB, which is come out when quantiferon X-ray or Montox, they are positive, but clinical X-ray is normal, then we should be treated with a rifampicin plus isoniazid for at least 3 months, or isoniazid monotherapy for 6-month therapy. And biological, that can be started, or JAK inhibitor after 1 month completion of therapy. If the patient has active TB, first treat TB, then we start on JAK inhibitors. There should be always prescribing, we should weigh the benefit and risk of the treatment. These are the risk factors you should have in your mind before prescribing a JAK inhibitor. Age over 65 years, any patient who is a smoker, current smoking, or is a past history, cardiovascular risk factor in the form of diabetes, obesity, hypertension, any risk factor of malignancy, risk factor of thromboembolic phenomena. Any patient with history of MI or a heart failure, patient on any blood clotting disorder, or a patient history of DVT, patient taking combined oral contraceptive pills, patient who are undergoing major surgery, or patient who are immobile, all they are risk for developing thromboembolic events. So this is a very recognized tool for risk stratification of patients who are put on JAK inhibitors. The red areas should be focused. They should be avoided, patient with JAK inhibitors. We have to keep in mind 2 factors. There are non-modifiable risk factors or a modifiable risk factor score. If the score is around 3, just avoid JAK inhibitors. 0, 1, 2 is appropriate. These are the green area where you can use without any complications. That's why in 2021, FDA expanded their safety warning to the JAK inhibitor class, and in the latest guideline European, they have been put JAK inhibitors only after use of biological DMARDs. At baseline, before starting tofacitinib, we had if hemoglobin is less than 9 gram per dl, if the absolute lymphocyte count is below 500 or absolute neutrophil count below 1000, should not be started on tofacitinib therapy. And this should be monitored every 3 months on the patient on tofacitinib. If the lymphocyte count is less than 500, we have to interrupt the dosing. If absolute neutrophil count in between 500 to 1000, we have to discontinue the medication and wait when there is a rise in absolute neutrophil count. If absolute neutrophil count is become less than 500, interrupt the dosing, don't use JAK inhibitor further in that patient. If the hemoglobin is less than 8 gram or a decrease of more than 2 gram while on JAK inhibitors, interrupt dosing until hemoglobin values have normalized. In the presence of serious infection, you should discontinue the treatment. These are the common adverse effects we see in a clinical practice on prescribing JAK inhibitor. Most often we see common infection like URTI, LRTI. In case of recurrent UTI infections, recurrent boils, risk of herpes zoster reactivation. As compared to general population, patients are 5 to 10 times higher risk of developing herpes zoster infection, risk of venous thromboembolism, or risk of major adverse cardiovascular events. Now come to the biological demands. There are 4 class of biological demand. Most often you are using anti-TNF therapy. There is a rituximab, they are targeted CD20 antibody. 2 interleukin-6 inhibitors are there. Tocilizumab, now it is approval of sarilumab and abatacept, which is not available currently in India. These are the anti-TNF drugs. First is the infliximab, which comes out in around 2000. It is a chimeric monoclonal antibody. It was followed by adalimumab, golimumab. They are fully human monoclonal antibody. Etanercept, it is a fusion of Fc fragment with the receptor protein, or sertologib pigel. It is just a Fab fragment which are attached to polyethylene glycol to increase the half-life of the drug. These are the normal dose we are using in a clinical practice when we prescribing anti-TNF drug. Adalimumab, 40 milligrams subcutaneous every 2 weeks. Etanercept, 50 milligrams subcutaneous every week. Golimumab, 50 milligrams subcutaneous on a monthly basis. And infliximab, it is an intravenous infusion. We have often give 5 milligram per kg body weight every 4 to 8 weeks with or without loading dose. TNF is a major inflammatory cytokine. It is one of the major breakthrough in around 2000 where we get a role of TNF, and this led to a role of anti-TNF therapy. Indication when we have to give biological DMARDs only when conventional DMARDs are ineffective, failure, or intolerance to therapy. These are the normal contraindication of anti-TNF drug. When you prescribe, you should look for should not be given a patient who are suffering for any fever, patient who have active TB or suffering from latent TB, patient who have a recurrent or chronic infection, patient with heart failure with LVF less than 45, SLE patient, because TNF they are found to cause reactivation of SLE, or de novo lupus patient, patient who have a neurological disease, multiple sclerosis, optic neuritis, and demyelinating disorder. Rituximab is a drug we are using. They are an intravenous drug, it given every 6 monthly basis, and dose is usually 1 to 2 gram. These are the common adverse effects we encountered when we giving a rituximab infusion. These are the recent guideline. Both the guideline accepted is a methotrexate is the first line treatment. Always use methotrexate as a first line drug with the appropriate dose of 15 milligram per kg body weight. It should be started irrespective of irrespective onset of it is a newly diagnosed case. In a SER guideline, it could be possible we can give a isolated, or you can with a bridge with the low dose corticosteroid, but in ULAR there is a compulsory guideline. You can bridge with the corticosteroid for 3 to 6 months and then withdraw the steroid. If the patient do not reach the target with methotrexate, the patient can be given a biological DMARD or target synthetic DMARD. There is no any option. Either we can use target synthetic DMARD or biological DMARD. But in ULAR guidelines, biological DMARD should be preferred, and the second line is JAK inhibitors. There is no stratification protocol in ACR, whereas in ULAR there is a strict risk stratification. If there is a presence of any risk factor, poor risk factor for the severity of the rheumatoid, biological DMARD should be preferred. In patient without poor prognostic factor, conventional DMARD should be considered other than methotrexate. Thank you.
Thank you, Vindhyachal. And I think a very complex topic, and you elaborated so nicely, and I hope it will be very beneficial to all of us. Our next speaker, Dr. Nishikant, and he will speak on a very complex ankylosing spondylitis patient, how to do a THR.
So first of all, I'd like to thank Amulya sir, Ramit sir for having me here. So I shall be talking about total hip arthroplasty ankylosing spondylitis. So these are my disclosures. I'm a consultant to Stryker and Johnson & Johnson. I'm being paid by these two companies. So there are very few talks which start with the take-home message, but mine will. My take-home message would be, decisions are more important than incisions. And this holds true in cases of total hip arthroplasty. So hip arthroplasty is all about three things: your the cup position, your offset, and limb length. All these three things has to be good to get the best results in hip arthroplasty. So starting with a case, this is a 20 years old chap, nursing student in NMCH, presented with this. Diagnosed as AS, taken treatment, now not able to walk. Came to me. So what are the things other than hip and SI joint you see in this picture? Anyone? Ramit boss? Apart from this hip fusion, SI joint, what can you see in these x-rays? Yes, not our concern. Yes, sir? Anyone? Mild protrusion is there, yes. So if you look at carefully about this obturator, so I'll come over it again. So I decided to do the hip arthroplasty, did bilateral hip arthroplasty in this case. So coming on to Angst spot, it's a chronic inflammatory disease, primarily affects the SI joint, spine and the hip, and the erosive changes are in the hip joint as well. So this is the post-op X-ray. Any comments? I know anyone can say the inclination is a bit vertical, the version is not correct, but it's deliberate. Why? I will tell. So this is the video of the patient in the pre-op period. You can see he's not even able to take a couple of steps. It's painful. He's not able to walk. He came to me over the stretcher. The same patient, this is the 2-month post-op. Can you play the video? This is the video of the patient in the post-operative 2-month period. He can walk, he can sit, he can climb the stairs. He can do each and everything. This is a life-changing moment for him. So why total hip arthroplasty in AS is different? So mostly because of spinopelvic abnormality. So your spine and pelvis is connected with each other through SI joint, and your spine is fixed and SI joint is fixed in this. So the spine and the pelvis movement is not going to happen here. So this is the major thing in which the AS is different from other avians and other cases we all are dealing with. So you need to know three things: the pelvic incidence, the sacral slope, and the pelvic tilt. These three things are of utmost importance before proceeding for hip arthroplasty in these AS patients. There are contractures. They can present variedly. They can present as ankylosis, maybe bony or fibrous. They can produce protrusion. The bone quality is very poor thanks to our rheumatology patients. They are always on steroids. Anesthetic complications are there, like fused spine, poor lung function, may need fiber optic intubation in these patients. So you need to know these patients very well. What are the complications they are going to have? Otherwise, these kind of complication is always waiting for you. So coming on to pelvic tilt. Pelvic tilt is the relationship between anterior superior iliac spine and the pubis. So this is the neutral pelvic tilt. So as the ASI goes posteriorly, it will be a posterior pelvic tilt. As the ASI goes anteriorly, it will be anterior pelvic tilt. So this pelvic tilt is relationship between ASIS and pubis. If it is neutral, it's neutral. If it's goes posterior, it will be posterior pelvic tilt. Anteriorly, it will be anterior pelvic tilt. So what happens? Look at this X-ray. These two X-rays we used to get. if you're getting these kind of X-ray, means like an inlet view, this is suggesting a anterior pelvic tilt. You can see the operator foramen is looking like a cat's eye. So this is the inlet view, means the patient has anterior pelvic tilt. And these are very common in Angst-Pont patients, means the patient has a posterior pelvic tilt. So the initial X-ray which I have shown has a large operator foramen, means the patient has a posterior pelvic tilt inbuilt in those patients. And we need to deal with those differently. Coming on to sacral slope. So this is the angle between the S1 with the horizontal. This is the angle with the patient standing. This is the angle with the patient in sitting posture. If the difference in the sacral slope is less than 10 degrees, means your spine is stiff. So you need to have these two X-rays, the lateral pelvis radiograph in standing and lateral pelvic radiograph while sitting, and calculate the sacral slope. The difference is less than 10, it means your spine is stiff. You need to consult your spine surgeons. Another is pelvic incidence. Pelvic incidence is combination of sacral slope and pelvic tilt. And important thing is pelvic incidence is always constant. Means if your pelvic tilt increases, your sacral slope will decrease. So this is a very informative video which I am going to show it to you. Look at this. The patient is going from standing to sitting posture. The pelvis is going in the posterior direction. So as you move from standing to sitting posture, the pelvis tilts posteriorly. So there is a biological opening of the cup, means your anteversion and inclination of the cup will increase. So this is very important. When you stand, goes from standing to sitting posture, your anteversion and inclination of the cup increases. So coming on to the anterior pelvic tilt, you can see as the pelvis goes anteriorly, you can see there is decrease in the inclination and the version. So if there is anterior pelvic tilt, there will be decrease in the version and inclination. And if there is a posterior pelvic tilt, look at here. The cup is going in posterior direction. There is an increase in the inclination and version. So what's the rule? So normally you can think there is a 1-to-1 rule, but it's not. So every 10 degree change in the pelvic tilt, there is 7 degree change in anteversion, while 3 degree change in the inclination. This is the rule. So coming on to few situations, like that my patient had. He had a stuck sitting position. Means your pelvis is posteriorly tilted and it remains posteriorly tilted while the patient goes from standing to sitting posture. Look at this. So when the patient sits, there is a chance of posterior impingement and increased risk of dislocation anteriorly. So these situations where there is a stuck sitting position where the pelvis is posteriorly tilted and remain posteriorly tilted while sitting posture, there is increased risk of anterior dislocation. So how will you manage this? So in these situations, you need to put your cup in decreased version and increased inclinations. Similarly, another situations like stuck standing, the pelvis is in neutral tilt and it remained neutral while in the sitting position. So there is an anterior impingement and risk of posterior dislocation here. So here you need to increase your version. Coming on to my X-rays, you can see now. These are the increased operator foramen. So this is a stuck sitting position. So I have increased the inclination and decreased the version. So this is deliberate. So this is a busy slide, I know that. But I need to few points about the orthopedic surgeons to take away from this slide. Before proceeding for any patient with hip arthroplasty, you should order 2 X-rays. One, the pelvis radiograph in standing and lateral radiographs. Calculate the sacral slope. If the sacral slope difference is less than 10 degree, means your spine is stiff. Sacral slope difference is more than 10 degree, spine has normal mobility. One thing which I would recommend, calculate the pelvic incidence and decrease the lumbar lordosis. If it is more than 10 degree, you should consult your spine surgeon. So even if you're not able to understand this, I have just simplified it in 3 terms. If there is a flexion deformity, means the patient has a kyphotic deformity, you need to reduce your version. If the person has excessive lumbar lordosis, you need to increase your version. And if the person has scoliotic deformity, you need to close your cuffs. These are 3 things which By remembering this, you can just come out by any situation. So what are the surgical challenges? Positioning these patients, because these patients are fixed. Exposure is difficult, osteotomy of the neck, deformities corrections, and tight reduction is always there. So positioning. So I approach my hips. I can approach from all positions, from the posterior, anterior. You can give me, I can approach through middle approach as well. So this is a lateral position. Normally I do my hips through lateral approaches. This is the position for the abducted and external rotated patients. So you can see the hip is fused. Nobody is holding it. So operating these patients are tough. So first identify the junction of the head and sternum. Then you can release the G-max tender. Osteotomy of the neck, it must be done in 2 stages. You have to be careful because cutting, if you are not control over the saw blade, you can cut the sternum. So you have to do it in 2 stages. First osteotomy should be at the level of the head and neck junction. Another, you can plan it accordingly, your situation. So this is the way you can cut your neck. And then dislocate your femur, and then you can plan your rimming. So mostly go on to release the anterior capsule, ergotomy, or occasionally you may need to release the sartorius. So this is the way you prepare your sternum. In situ rimming, in cases of fused hips, you can do the in situ rimming over the head. So don't try to over rim. The cup size is decided by the anterior and posterior column, not by the superior and inferior wall. So that is the most important thing. So try to look for the bleeding from the surfaces. So you can see it's bleeding all around. So that's the right time. So I normally don't use these reamers. I try to get the tactile feedback from the floor of the sternum. That's my usual size. I don't rely on these trials. You can see. So what I do extra, I do this kind of rose petaling, chiseling of the bone over the sclerotic surface. And this is my way of placing the uncemented cup. I move to the anterior surface, then put my cup, putting the screws in the anterior superior and posterior superior direction, and few gentle hammering. Remember, your hammering should be at the level of the wrist, not on your elbow and the shoulder. And this is the way you can get a very good purchase. It has to be controlled. Just few punches and it's done. See, this is the position of the cup and this is the intra picture. So TAL is our guide for inclination and anterior wall is our guide for version. So this is a case. You can see there's this much defect in there. So what will you do, Ravit boss? This much protusio is there and this much defect. Which kind of cup you will prefer?
So basically, we'll need to lateralize the acetabulum.
How will you fill this defect? This is a large cup there.
Yeah.
So you want to fill it with a cement or bone? So bone is always available here.
Bone is available there. Normally, we won't like to go for augments. Bone would be sufficient.
Yes. So I just use the similar bone graft over here and use the dual mobility cup here. Similar case, fibrous ankylosis, bilateral THR.
Sorry to interrupt.
Just
we are running short of time.
Just a couple of more slides, sir.
We should conclude.
So these are trilog stems. Another case, Mahesh sir, OA with a fracture. How many of you will fix it? Mahesh sir?
This is a very tough situation to find out, and whether to fix or not fix, that depends on your experience, whether going it's wrong or right. But my concern is there, this is the fused joint. When you fix it, the purpose is lost.
Yeah.
So you have to replace it.
Absolutely. So the similar thing was done. I did in single stages. this dual multi-cup Wagner stem with trochanteric wiring. Another case, in this, open this, sir, this fracture. Fix it. So, opinion can vary. I decided to do it in single stages, use a provisional plate to fix it, Wagner stem, single stage hip arthroplasty. Another case, this much defect. So decided to do it in single stage, bilateral arthroplasty, use dual multi-cup, like this. So this was case I did around 2015. He came to me in 2022 with this. So 7 years down the line, one hip failed, one hip was standing. So decided to revise it with impaction bone grafting technique. So this is the 3-year follow-up. So in this situation, bony ankylosis of bilateral hip and bilateral knee. So this was a patient, he was moving with fused bilateral hip and fused bilateral knee. So decided to do the bilateral hip and bilateral knee sequentially. So this is the bilateral hip, bilateral knee. This is the 8-year follow-up. And this is the same patient walking after this surgery. So this paper has been published as well. So my conclusion would be hip arthroplasty in AS is challenge. Challenges are many. Mostly it will be osteotomy of the neck, spinopelvic relationships, and balancing of the soft tissue. This long learning cuff, dual multi-cup may be needed, and heterotopic ossification is very common in these cases. So hip arthroplasty is an art and science to be learned, not to be wrestled with. So thanks a lot for your patient hearing. With a saying, I just end with a couple of. एक बार on करना उसको last में. Last. With a saying that आंधियों में भी जो जलता हुआ मिल जाएगा, उस दिए से पूछना मेरा पता मिल जाएगा.
Thank you, Nishikant. A wonderful lecture on a very complex topic and how to deal with such kind of situations. Thank you again. And our next speaker, Dr. Rajiv Ranjan. Dr. Rajiv. And he will speak on perioperative management of rheumatoid arthritis patient.
Good afternoon, everyone. So this topic has already been something discussed by Kavita ma'am in the morning. So my topic become very easy now. So if you see that rheumatoid arthritis patient, there is 50% increase in prosthetic joint infection compared to osteoarthritis. And the flare of rheumatoid arthritis is more than 60% patients seen after surgery. So these two things are very important, and you have to balance the two things. You have to control the rheumatoid arthritis disease activity, then you have to plan for the surgery for best outcome, and you have also to reduce the infection risk. So in one study here, the flares of patient of rheumatoid arthritis after THR or TKA, so they have found a very important thing, that there is higher flare rates of rheumatoid arthritis if the disease activity at baseline before surgery is high. So most important thing is inflammation. If you can control the inflammation before surgery, then the outcome for replacement will be rewarding. So higher RA disease activity is one of the important factor, and you have to deal it before planning surgery. So one meta-analysis where the outcome for TK are in patient with rheumatoid arthritis and osteoarthritis has been compared. And in this meta-analysis, almost more than 78,000 knees operated patients were taken, and they have taken from 34 studies. So what they found, that DVT and pulmonary embolism is less in rheumatoid arthritis patients. There is less functional score in rheumatoid arthritis patients. RA patients are having higher infection rate, higher chances of loosening of the joint, and there is higher chances of revisions of replacement. And they found few important risk factors. The first is steroid. If the steroid intake is more than 15 milligram, the risk for prosthetic joint infections are high. Obesity is another the important risk factor. Poor rheumatoid arthritis disease activity control is the another risk factor, and the patients who are having coronary artery disease is an important risk factor. So the principle of management is the control of rheumatoid arthritis is must before planning surgery. So obviously if you think that the disease is active, there is inflammation, high SR, high CRP, patient is having multiple joint pain and swelling, please do not go for elective surgery. Control the disease inflammation, can take opinion from your colleagues. Assessment of disease activity is very important before planning surgery. Then you have to optimize the medicines. Which medicines are safer? You can continue in the perioperative period. Which medicines are not safe? You have to hold it or you have to decrease the dose. Try to give minimum steroid before surgery. If the patient is tolerating 2.5 or 5 and the disease activity is under control, that is the best thing you can give to the patient. Target before TKR or THR, you have to target either the patient should be in remission or low disease activity. Then plan surgery. So what is our job is to control the disease activity and give you to the patient in a state where the surgery outcome will be very good. Also we have to look the dose adjustment and also the extra-articular features. Very important before planning surgery is the cardiac and pulmonary function assessment, because you know rheumatoid arthritis is an important risk factor for coronary artery disease, and ILD is very prevalent in rheumatoid arthritis patient. Cervical spine examination and X-ray is very important. You have to also look for cricoarytenoid arthritis evaluation, because these two things can lead to difficult intubation, and spinal cord manipulation is very important in surgery. So what is very important thing never to ignore is first cardiovascular risk assessment. Always take cardiovascular risk assessment before planning surgery. Cervical spine assessment is very important. Rheumatoid arthritis inflammation control is very important. Try to keep or give the patient at minimum steroid dose. So regarding glucocorticoids, two important features are first the adrenal insufficiency. This patient can land up in the adrenal shock. Infection risk is very high, especially if you use prednisolone more than 15 milligram. There are multiple other complications during surgery like the impaired wound healing, skin thinning. There may be the chance of hematoma or skin ulceration, higher fracture risk. So the best thing is try to put the patient on the minimum steroid before planning elective surgery. So we have 2022 American College Rheumatology plus Orthopedic Association for the surgery. They sit together and gave a guideline regarding the better management for the patient who are going for THR or TKR. So the guideline is that continue conventional synthetic DMARDs. If the patient is on methotrexate, hydroxychloroquine, sulfasalazine, leflunomide and apremilast, there is no need to stop these drugs, because the chances of infection during perioperative and post-operative with these drugs are very, very minimal. In fact, the flare rate of rheumatoid arthritis is very high, and if you stop these drugs, so what happens, even after a good surgery, the patient will complain persistent pain in the surgical site. Another important thing is targeted synthetic DMARD, tofacitinib. Ideally, in the earlier guideline, it was said that you have to stop it 1 week before, but recently they have said even you can stop this drug 3 days prior to the surgery. Steroid, I have already talked about this. And if the patient is taking any low dose steroid, continue this particular drug. You can shift to the hydrocortisone IV preparation during the operative period. So DMARDs are started once the wound healing is there. Approximately it takes around 2 weeks for wound healing. In post-operative period, you can start those drugs who have been stopped. You can hike up the therapy, you can increase the therapy if the patient is having some symptoms or sign for high disease activity. So these things are very well known to you, that DBT prophylaxis is very important, and in rheumatoid arthritis patient it is advisable to give prophylactic antibiotic also for prevention of infection. If I can summarize, the most important thing is control of RA disease activity before planning surgery. Minimum steroid use before surgery is very important. No need to stop conventional synthetic DMARD because we have usually seen that flare of rheumatoid arthritis is very common if you are stopping conventional synthetic DMARDs. So the outcome for the surgery is also becomes poor if you stop conventional synthetic DMARD. Try to put the patient on the minimum steroid dose. 2.5 or 5 is a good dose where the patient can, disease activity can be getting under control and without any complication. Don't forget to assess cardiovascular risk factors, cervical spine, and obviously DVT prophylaxis. Thank you very much.
Thank you, Dr. Rajiv Ranjan, for your wonderful presentation. Now we are concluding the session. If there is any question, can be discussed during next session, that is panel discussion. Thank you.
Yeah, we will conclude. Thank you very much, sir. We will conclude this session, and we were supposed to finish at 2. Less time is left. So may I request, thank you very much, sir. Sir, the mementos are there outside. Basically, we will be presenting. Lunch will be on this floor, just above. You have to go to the floor above. And your bag distribution, delegate bag is at Imperial Garden. So people finish your lunch, then you go there. Pharmaceutical peoples will be there. There is a trade center, 40 stalls are there. Please do visit. So first of all, I will request Niharika, Dr. Niharika, please come. You are one of the panelists. Dr. Bindhyachal, Dr. Rajiv Ranjan, Dr. Manish. हम लोग थोड़ा फास्ट चलेंगे क्योंकि समय कम है और सबको भूख भी लगी हुई है. डॉक्टर राजकिरण, आई विल रिक्वेस्ट यू, क्योंकि आपका एक्सपर्ट ओपिनियन 1-2 मिल जाएगा तो हम लोग के लिए फायदा मिल जाएगा. आप आगे आ जाए. और डॉक्टर राजीव, अच्छा डॉक्टर राजीव आ रहे हैं तो वी विल स्टार्ट. ज़्यादा समय नहीं लूँगा. प्लीज स्टार्ट योर प्रेजेंटेशन. डॉक्टर मनीष. डॉक्टर राज प्लीज, क्योंकि ये ऐसा है कि ऑर्थोपेडिशियन ने मैनेज किया है तो नेचुरली आप लोग का एक क्रिटिकल कमेंट बहुत जरूरी है, लेकिन हम थोड़ा फास्ट चलेंगे. जो भी आंसर देना है, क्रिटिकल, बैड, गुड, प्लीज बी फास्ट. दिस पेशेंट, basically we had lots of guest faculty. The history goes 16 years back. A 45-year-old lady presented with polyarthralgia of 7 months duration, severe pain in multiple joints, swelling in joints, more in wrist, not able to do normal daily activities, bedridden for 2 months. तो ये 16 साल पहले की कहानी है. How it started वो 17 साल पहले. The problem started in November 2007 with pain in finger and toes. There was no fever initially. She took some analgesics. Pain increased gradually, involved other joints by January 2008. Pain was more in night and morning, associated morning stiffness. She consulted local doctors. December 2007 में this was the report, basic report जो कि patient ने मुझे दिया था. Antibiotic analgesics were prescribed after seeing blood reports. No significant relief. Pain increased in other joints in January 2008. There was swelling. Patient was taking medicines from local doctors. No improvement. क्या होता है हमेशा पेरिफेरी में? Patient shifted to Ayurvedic treatment. Ayurvedic treatment में गई, but 2 महीने में problem increased, low grade fever, physiotherapy advised. मैं history दे रहा हूँ इसलिए I'm not asking you anything at present. जो हमेशा जो बातें होती हैं, AKT was started in April 2008 after seeing reports. ESR raised था, इसके कारण somebody started tuberculosis treatment. Pain swelling gradually increased. May 2008 में she went for Kerala massage. June 2008 the problem increased with intense pain and swelling in joints, tender joints were there. Now homeopathic medicine. 8 महीने के बाद homeopathic medicine शुरू हो गई. There was no relief. Anxiety increased, restlessness, decreased appetite. And my first interaction with the patient in July 2008. My first interaction, patient was brought in ambulance with heavy dose of analgesics. She was crying with pain. Joints acute tender, severe pain. She was begging for some relief. Niharika, 8 महीने पहले का history है. Now this condition, how to approach?
सर फर्स्ट ऑफ ऑल मैं पेशेंट को पहले पेन से रिलीव करूँगी सर, और उसके लिए सर डायग्नोस्टिक जो टेस्ट हैं जैसे RA फैक्टर, ACPA, CRP अगेन, ESR अगेन, और जो रिपोर्ट आते ही सर मैं उसको आगे के लिए प्रोसीड करूँगी.
मनीष. फर्स्ट हमारा क्या कंसल्टेशन ऑर्थोपेडिशियंस के पास अगर आए हुए हैं, फर्स्ट शुड बी पेन मैनेजमेंट और डायग्नोसिस? 2008 की है सर, जुलाई 2008।
पेशेंट बेड रिडन क्यों था, लार्ज जॉइंट से या?
लार्ज जॉइंट्स।
लार्ज जॉइंट के इन्वॉल्वमेंट से बेड रिडन था?
Basically all joints, but bedridden because of the large joint.
Large joint.
Neck, knee, hip, everything, back also. सारी जगह पेन उसको बहुत थे.
Okay. Assessment was done for large joints.
Swelling थी, large joints में swelling थी.
Hip joint status? Hip joint.
Hip joint का X-ray will just try to see अगर उस समय हुआ था कि नहीं, मेरे पास क्या था. तो you want कि अच्छे से large joint का सारा X-ray हो, ठीक? And blood test what निहारिका has said. तो हम लोग एक तो हो जा रहा है. एंड व्हाट अगर पेन के लिए हम अगर वेट करते हैं तो उस समय क्या दवा देना है? नहीं.
While we are working for working the patient and doing the test, simultaneously we will manage the pain.
Right. तो मैं आगे बढ़ता हूँ क्या कि आप लोग का ये जो था उसमें ब्लड रिपोर्ट था, टोटल काउंट जो ESR was raised, CRP was 34, RA factor 18, एंटी CCP 35. ये उस समय का रिपोर्ट है 16 साल पहले का. और कैन वी कॉल इट आर्थराइटिस, पोलियार्थराइटिस, जो भी हो? विंध्याचल
सर, हाँ कह सकते हैं अर्थराइटिस है सर. वी डोंट नो द कट ऑफ ऑफ रूमेटॉइड फॉर एंटी CCP. अगर ये कट ऑफ से ज़्यादा हैं तो इट इज़ अ टिपिकल रूमेटॉइड आर्थराइटिस. उनको अच्छे से प्रॉपर ट्रीटमेंट नहीं मिला, इसीलिए उनकी कंडीशन डिटोरिएट हो रही है. वी हैव टू टेक केयर बोथ बिकॉज द क्लिनिकली इट इज़ अ रूमेटॉइड सर. वी हैव टू इनिशिएट द ट्रीटमेंट एंड देन एट द सेम टाइम वी हैव टू वर्क आउट फॉर द लैब इन्वेस्टिगेशन.
राइट. सर डॉक्टर राजकिरण सर, यहाँ पे अगर रूमेटॉइड हम डायग्नोज कर लेते हैं सर, ठीक है, हो सकता है बहुत सा इन्वेस्टिगेशन नहीं हुआ, assume that it is a case of rheumatoid arthritis. अभी किस प्रोटोकॉल से? क्योंकि अगर हम DMRD शुरू करते हैं, it's my way of thinking, it may take about 1.5 months for.
Because for this patient she needs symptomatic relief, so it's in 2008. So like we need to start both therapy which modifies the symptoms as well as disease modifying. So we have to start this patient with methotrexate. Because like I don't remember her age, if she is not planning for pregnancy or even if she plans for pregnancy in the future, near future also, because her becoming all right is most important.
At that time she was 38 years old and a nun. Yeah. Basically she is a nun.
So she need to be started on methotrexate. Along with methotrexate for symptomatic relief, we have to start steroids and NSAIDs.
Right.
So we have to see that we need to quickly optimize the doses of methotrexate and bring down her from steroids if her symptoms improve.
Right. Steroids and methotrexate. एक्सरे उस समय का ये था सर, ये एक्सरे है, ये उस समय का एक्सरे हैंड का था, पेल्विस का. लकली आई गॉट इट मनीष, उस समय का है ये. 8 महीने पहले, मैंने 8 महीने जो दर्द रही है उस समय का एक्सरे है. और रियली सॉरी, नो क्लिनिकल पिक्चर अवेलेबल ऑफ 11 years बैक नाउ एट दैट टाइम. बट हाउ विल यू मैनेज? व्हाट आप लोगों ने बात सुन ली है, एनाल्जेसिक्स, एंटीबायोटिक, पेंटोप्रोजोल. बट व्हाट आई डिड सर, व्हाट आई डिड, सोलिमेट्रोल 1 ग्राम IV. कहाँ इसको गलत ये होगा, क्या होगा सर? या विंध्याचल या टेक इट. हम लोग फास्ट चलेंगे क्या कि सब लोग को भूख लगी हुई है, ज्यादा समय नहीं लेंगे.
इट इज नॉट अ प्रोटोकॉल, इतना डोज की जरूरत नहीं है सर. वी कैन मैनेज विद द ओरल मेडिसिन अप टू 10 to 40 milligram steroid with beautifully sir. Don't go for 1 gram solumetrol. They are reserved for sir like RA with ILD, for aggressive diseases, any kidney problem or a vasculitis sir. For joint pain as such, it is not a recommended dose sir.
Right. The high dose of steroid, what is advocated by Dr. Bindyachal, should not have been given, but it was given at that time. There was relief. Next day, same drugs, more investigation, 1 more gram of solumetrol was given next day. और उसके बाद third day, it was a very good relief. Patient was able to move her limbs slightly, in a good way. ESR was 90, CRP 42 और जो भी हुआ उसके बाद पेशेंट कंसिडर्ड बी अ गॉड. उसको लगा एक भगवान मिल गया है इतने महीने के बाद, 8 महीने के बाद. मैं आगे ले जा रहा हूं. सो व्हाट टू डू नेक्स्ट? डॉक्टर मनीष
सर, कंटिन्यू करना है उसको, जो भी डिमांड आप सेलेक्ट किए हैं उसका रिस्पांस देखना है. अच्छा रिस्पांस चल रहा है, पेशेंट को रिमिशन की तरफ लेके जाना है.
राइट.
रेमिशन में गया तो मेंटेन करनी है उसके डोज को जब तक हम कर सकते हैं.
ये उस समय का MRI का पिक्चर है. बहुत ज़्यादा डिटेल में फिर MRI पे अभी नहीं जा रहा हूँ कि लोग बोलते हैं MRI कराना चाहिए, स्पेशली हैंड का MRI शुड बी डन अगर आपको कंफ्यूजन हो रहा है. और ये सारे प्रोटोकॉल है जो कि आप लोग कल से सुन रहे हैं, उसके बारे में फिर डिटेल में नहीं जा रहा हूँ. नाउ व्हाट टू डू नेक्स्ट? व्हाट मनीष हैज सेड कि on 5th day started DMRD. Niharika, methotrexate 15 mg weekly. I started hydroxychloroquine 4 mg per day. ये regime ठीक था, गलत था? 38 years old female, unmarried but not going to be married.
नहीं सर, सही है.
ठीक, तो इस पे ये काम आगे बढ़ाया गया. I thought my job is done because मुझे कितना knowledge है, naturally डॉक्टर राजकिरण समझ गए होंगे, being orthopedic surgeon, कि मैं ज़्यादा मुझे knowledge नहीं था उस समय 16 साल पहले.
सर, हाइड्रोक्सीक्लोरोक्विन को 2 डिवाइडेड डोज में भी दे सकते हैं.
Twice daily, it was given twice daily. But pain started increasing after 10 days. 10 दिन के बाद दर्द बढ़ना शुरू हो गया. और is my diagnosis wrong? विंध्याचल, अभी आपकी बात. Right.
हेलो, वो सर वो क्विकली काम करता है फॉर ब्रीफ बट द डिजीज अंडर अभी भी एक्टिव है सर. ESR and CRP are very raised, so we give to have to add a load of steroid concurrent for a brief period of time to get a.
That was wrong, which I did. आज मुझे लग रहा है कि उस समय लो डोज स्टेरॉइड मुझे चलाना चाहिए था, which I didn't do.
Methotrexate सर 4 to 5-6 वीक बाद काम
तो I didn't do. सर इसलिए मैं एग्जैक्ट केस को प्रेजेंट कर रहा हूं जो मैंने किया था. Added low dose steroid now. अगस्त, 1 महीने के बाद मैंने फिर उसको स्टेरॉइड ऐड किया. 15 डे आफ्टर स्टेरॉइड, ये उसका फाइंडिंग था. आप लोग देख रहे हैं, इसमें ज्यादा डिटेल नहीं जाऊंगा कि लंबी कहानी, अभी मुझे 15 साल कवर करने हैं, मैं फास्ट जा रहा हूं. और प्रॉब्लम फिर उसका सितंबर में इंक्रीज करने लगा. माई इमेज ऑफ गॉड वॉज लॉस्ट. शी कंसिडर्ड मी नाउ एज अ डेविल. शी वॉज ऑलरेडी ऑन DMRD. व्हाट नेक्स्ट? लो डोज स्टेरॉइड दे रहा था सर. तो अब क्या कर सकता था? पेशेंट को फिर से ज्वाइंट पेन, स्वेलिंग सब शुरू हो गया. हाँ, विच वन? स्टेरॉइड डोज बढ़ाना होगा या? ओके, राइट राइट. तो उस समय वी शुड हैव इंक्रीज द डोज. शायद मैंने नहीं किया था, मुझे याद जो पड़ रहा है कि मैंने नहीं किया था. लो डोज मैंने सोचा कि क्या मैं डेफो नहीं प्रेडनिसोलोन शायद चलाया था, लेकिन 6 मिलीग्राम 5 मिलीग्राम ओनली. सो मोर टेस्ट वाज डन. PCR फॉर कॉक्स नेगेटिव, MON2 नेगेटिव, HIV नेगेटिव. उस समय रिटुक्सीमैब सर फर्स्ट टाइम आई थी जो मुझे मालूम हुआ था. आई नेवर न्यू, क्योंकि शायद हैदराबाद में कॉन्फ्रेंस आपने उसी समय हुआ था 5-6 के आसपास या 7 में. मैं गया था तो मैंने नाम सुना था उस समय रिटुक्सीमैब का. एंड माय वाइफ, शी इज ऑन्कोलॉजिस्ट, शी इज यूजिंग रिटुक्सीमैब. तो मैंने उससे डिस्कस किया, कैन आई यूज इट? तो शी गेव मी अ ग्रीन सिग्नल दैट सो प्लान फॉर बायोलॉजिक्स. शुड आई स्टार्ट? सर डॉक्टर राजकिरण, उस समय स्टार्ट करना चाहिए था कि नहीं?
A couple of things here, like the initial images which you have shown, the X-rays followed by MRI. So MRI mein there are some erosions.
Right.
So it's an aggressive disease because this disease has a very poor prognostic markers. Why? Because the disease like it's progressing very fast. Like the patient is become bedridden, she has wrist joint problems, and she is unable to walk, and it's an erosive disease to begin with. So lots of poor prognostic factors are there, and I think depot steroid or low dose continuous steroids would have been helped. It's too early to directly push into rituximab, and this patient might again methotrexate might have been converted to subcutaneous methotrexate. We can do that, and we can increase the methotrexate. We can add other DMR like sulfasalzine or hydroxychloroquine. And rituximab we can give, but rituximab doesn't act such faster, because even if you give rituximab, because the main issue is symptomatic relief here. So we are looking at a symptomatic relief of the patient and at the same time disease control, both we want. Because rituximab, even if you give, the onset of action of rituximab is little slow. Even it lasts for longer time, but the effect of rituximab you will get better after a month. Maybe second month, and third month is very good. You feel the patient feel much better. So if you are looking for a long-term goal, and if you want, you can hold the patient with steroid or NSAID or whatever it is, rituximab is the choice. But if you want a quick recovery, patient has to become very quickly normal, and already you think that you have given lots of steroids, and you can't risk giving more steroids and NSAIDs to that patient. And anti-TNF drug would have been a better choice at this time. Because a drug like infliximab or etanercept, adalimumab is not available at that time. It has come in 2016. So Enbrel and Remicade were available. They will give a quick action. So what exactly we want in this particular patient, it's a dialogue between consultant and a patient. You need to take a call. If you are able to hold the patient with other drugs, give rituximab. And the patient wants immediate relief, you are unable to give more steroids, more NSAIDs, choose anti-TNF.
Yeah, anti-TNF would have been a better drug. What the? Yes. Yeah, you should be here. डॉक्टर राजीव एक चेयर हम लोग हाँ यू प्लीज हम लोग थोड़ा फास्ट लेकिन चलेंगे
Right, sir. So, in my opinion, why I think we missed is the hemoglobin was 5.5.
Yeah,
if
yeah.
I am not wrong.
Yeah,
So this is very severe anemia. I need to find out the cause of anemia. Why the rheumatoid arthritis patient is having so severe anemia? What is the cause? It is peptic ulcer disease. It is something autoimmune hemolytic anemia. It is SLE patient that is looking like RA coming with polyarthritis. So this thing I will evaluate in the first phase of presentation.
So we should have evaluated the cause of anemia also. Mostly the blood transfusion was given at that time. Dr. Rajiv, please welcome. Sir, what I did, sir. Yes, sir, your exact story. What I did. Rituximab was given on the 59th day after my first interaction, and after 54 days of starting oral DMRDs. और जो डोज मैंने दिया था वो 500 milligram IV infusion at interval of 5 to 7 days each. Total 2 grams were given in 18 days. Ideally it should be given 1 gram at 15 days interval. यहाँ पे थोड़ा सा deviate किया था मैंने with all precautions. Precautions क्या है वो biologicals में आप लोगों ने पढ़ा होगा. ये मैंने दे दिया था. मैं आगे कहानी ले चल रहा हूँ. Pain and swelling. She is the patient. Everything has been written. She is a good patient of mine. इसलिए बहुत सारे photographs के मिलेंगे. Nothing is being hidden. Pain and swelling decreased, movement improved, appetite improved, no fever. Response was very good. Now you see, सर ने जो बोला था 2 महीने के बाद सही रिस्पॉन्स मिलता है वही हुआ जो अगस्त में मैंने शुरू किया था. अक्टूबर में 2 महीने के बाद ESR थोड़ा सा कम होने लगा. Response was very good. Should I continue DMRD? Now which one? Anybody? Same thing.
Methotrexate.
Right. Same thing was continued. Methotrexate, hydroxychloroquine, no steroid was continuing at this time with calcium, vitamin D, multivitamin. Response was very good. January 2009. अब 7 में 6 महीने टोटल और करीब करीब बायोलॉजिकल चलाने के 4 महीने बीत चुके हैं. This is the condition. February 2009 in my hospital she was back to work. चलने उलने लगी सब चीज ठीक ठाक. The quality of life changed. She was able to do almost all her work. The attendants were so happy and satisfied. April 2009 मीन्स करीब करीब 10 महीने मेरे इलाज के बाद पेशेंट बिकेम इरेगुलर जो कि हमेशा होता है. ठीक होने के बाद पेन स्वेलिंग इंक्रीज इन जॉइंट टेंडरनेस स्टिफनेस इंक्रीज्ड. जुलाई 2009 एक साल बीत गया. 2008 में पहली बार मैं देखा था. दवा बंद करने के बाद फिर से ESR रेज होने लगा है, CRP रेज हो रहा है, क्रिएटिनिन लकली ठीक ठाक है. पेशेंट काउंसल्ड वेल एंड DMRD स्टार्टेड अगेन. मैं अब थोड़ा फास्ट चल रहा हूं फिर से, लेकिन यहां पे लेफ्लुनामाइड मैंने ऐड किया था 10 मिलीग्राम. योर सर ठीक है. लेफ्लुनामाइड उस समय ऐड किया था विद मेथोट्रेक्सेट, हाइड्रोक्सीक्लोरोक्विन एंड लो डोज ऑफ स्टेरॉइड वाज गिवन फॉर 3 वीक्स. सितंबर 2009 ESR वाज 68 CRP जो भी है. लेकिन आप देख लीजिए सर मैं 2011 तक का आपको रिपोर्ट दिखा रहा हूं. ग्रेजुअली ESR फॉल कर रहा है और करीब अब 3 साल हो गए हैं. CRP नॉर्मल आया है करीब करीब 2.5 साल के ट्रीटमेंट के बाद. नो चेंज इन डोजेस, ओनली मेड 2011 low dose of steroid again was given for 3 weeks. सर यहां तक है. मैं आगे बढ़ाते जा रहा हूं तेजी से. She could do all her activities. Who was bedridden 1 year back और ये आराम से मेरे सीढ़ी पर चढ़ के ऊपर चल रही थी. इस समय कोई दिक्कत नहीं थी. प्रोग्रेस was monitored. सर अब हम लोग 2008 से शुरू करके 7 साल आगे आ गए हैं. अब देखिए 2015 में सर यहां मैं थोड़ा फास्ट जा रहा हूं इसलिए हो सकता है सडनली जून 2013 के बाद 2 साल के बाद मेरे पास आई है ESR 113 और CRP 26.87 यहां पे आ गया था. क्यों हुआ शायद इसलिए मैं आप लोगों को अभी पूछ नहीं रहा हूं. इज समथिंग अलार्मिंग. यहां पे अब जो करीब करीब इलाज पहला जो पड़ा था 2008 में रिटुक्सीमैब पड़ा. नो रिपीट डोजेस वाज गिवन. 2015 में हम आ गए हैं सर. यहां पे क्या सोचना चाहिए डॉक्टर राज? अच्छा
She is relapsing. She is relapsing.
Right. तो counsel her well, wanted to give her next cycle rituximab after proper investigation. Patient was asked to get admitted. 2015 की बात कर रहा हूं, but she went home. She didn't stay at my hospital. She came back next years. 1 साल के बाद. Extreme weakness मेरे ICU में है. Lethargy, fever, decreased appetite. अब बताइए. Irregular DMRD sir.
Yeah, but again, what she was taking all these months, because 1 year she's taking on DMRDs only or some indigenous medicine, because these
irregular DMRDs sir, irregular DMRDs लेकिन यहां पे जो ब्लड रिपोर्ट होता है सर, टोटल काउंट है 61,000.
कुछ नहीं है सर, इसमें कंफ्यूजन क्या है, फिर से मैनेज कीजिए.
ठीक.
61,000 is quite high.
61,000.
हाँ, यहाँ पे
Counts बहुत ज़्यादा.
हाँ.
Sepsis, malignancy, I think a lot of things you need to evaluate her further.
Yeah. What Dr. Rajkiran is saying कि अगर 61,000 आ गया आपके पास, एक साल के पास आपके पास नहीं था, और पत्नी मेरी कैंसर विभाग में ऑन्कोलॉजिस्ट है, तो पूछना तो पड़ा कि अब क्या करना चाहिए. बोन मैरो वाज डन, डायग्नोज्ड एज क्रोनिक लिम्फोप्रोलिफरेटिव डिसऑर्डर. इसके आगे मुझे खुद नहीं मालूम था कि अब क्या करना है. फिर से मैंने मनीषा से पूछा, एडवाइज्ड फ्लो साइटोमेट्री. मैं कभी नहीं कराता हूं, नेचुरली उसे पूछ के किया हूं सर, इसलिए मैं आपको बताता जा रहा हूं. CLL डायग्नोस्टिक पैनल में ये आया, डिटेल्स में नहीं शो कर रहा हूं. बोन मैरो सैंपल शो टोटल ल्यूकोसाइट काउंट ऑफ 85,000 नाउ. फिर क्योंकि ऑन्कोलॉजिस्ट नहीं है तो मैं इसलिए आगे बढ़ा रहा हूं सर, क्या कि अब उनका डोमेन आ गया था, आपसे मैं नहीं पूछ रहा हूं. फ्लो साइटोमेट्री में यही आया था, सजेस्टिव ऑफ BCL है और क्रोनिक लिम्फोसिटिक ल्यूकीमिया. तब मैंने ऑन्कोलॉजिस्ट से पूछा अपनी पत्नी से, अब क्या करना चाहिए, क्योंकि नेचुरली मनीष इज ऑलवेज देयर विथ मी टू हेल्प मी आउट, लेकिन थोड़ा सा डोमेन आगे बढ़ गया था. सो कीमोथेरेपी स्टार्टेड ऑन 10th of September 2016. एंड व्हाट वाज द डोज, फिर इसके बारे में मुझे नहीं मालूम है सर. डोज उसने कैलकुलेट करके मुझे बताया था, रिटुक्सिमैब 375 मिलीग्राम पर मीटर स्क्वायर according to the body surface area, and her body surface area was 1.4 meter. So dose was, what she told me, is 500 milligram at 3 weekly interval in combination with some chemotherapeutic drug, bendamustine. Total 6 cycles were given. ये अब BCLL की हम लोग मैनेज कर रहे हैं, तो थोड़ा अभी हट गया हूं, इसलिए मैं आगे बढ़ता जा रहा हूं. पेशेंट स्टार्टेड फीलिंग वेल, DMRDs कंटिन्यूड. सर ये हुआ था हम लोग के साइड से. Methotrexate hydroxychloroquine with chemotherapy was being given. Progress monitored. अब आप देख रहे हैं जो 16 में 19,000, 85,000 से 19,000 आया, 17,800 आया, और आफ्टर 4 साइकिल्स सब चीज धीरे धीरे ठीक हो रहा था. पेन एंड स्वेलिंग इन जॉइंट्स, पेन ऑन मूवमेंट, मॉर्निंग स्टिफनेस जो भी था, बट पेशेंट वाज नॉट एबल टू डू नॉर्मल डेली एक्टिविटीज. शी वांटेड अ बेटर लाइफ. अब क्या करे, क्या कि वो साइकिल खत्म हो गया था. अगेन शी केम बैक टू मी, सर अब क्या करना चाहिए था सर. वहां पे सब चीज ऑलमोस्ट नॉर्मल आते जा रहा था. वो कीमोथेरेपी का लोग उन्होंने बोला कि मेरा डोज कंप्लीट हो गया है, नाउ यू कैन डू व्हाटएवर यू लाइक.
When was the last chemotherapy dose of rituximab?
Sir, that was in 16. That was, I will tell you, September 2016. उन्होंने 6 साइकिल दिया था सर, और that went for October. ये नवंबर का रिपोर्ट है सर, अक्टूबर में खत्म हो गया था सर.
October खत्म हो गया, but November she still has pains.
Yeah.
Two things we can do, because it just completed in September and patient is complaining in the November. You can still wait for some more period for rituximab to act. Maybe few more months you can wait, because as I said, rituximab is a little bit slow acting, and a lot of things are happening. Because pain and swelling, you said, whether we need to see whether that particular, is it arthritis or is it something related to malignancy which is causing the bone pains. Maybe a further evaluation like bone scan and all, they might help, and confirmation whether it is truly arthritis or not. If it is truly arthritis, then we need to play around with the drugs which we treat, like DMRs. And if it is not related to an arthritis pain, we need to treat it differently.
Right. Dr. Rajkiran's opinion of that, either now you have to decide whether it is you going towards right direction of arthritis or something else. But मैंने क्या किया, after doing all investigations, sir, Dr. Rajiv, you will comment on this. 2 grams of rituximab was again given in 20 days in November, December 2016. ये justified था कि नहीं?
No sir, I don't think so, because the patient is suffering from last more than 10 years, and if you look at the parameters, the inflammatory markers are not so much high, and after giving 6 cycles of chemotherapy, I would not give rituximab much more if the disease is not active. I will examine the joint. If the clinically the patient is not having arthritis significant, I am not getting in the blood parameter, the chances of non-specific psychosomatic pain syndrome is more likely. So I should, even there is some mild joint pain, I would have given some DMARDs and some 2.5 to 5 milligram of low dose steroid.
Right. But this was given. That's why ideal thing is that what you are getting from these people. What I did, I'm just presenting because ये मालूम होना चाहिए कि मैंने क्या किया, गलतियां कहाँ कहाँ हुई. That's you should all learn. दिसंबर 2017, एक साल के बाद, DMRDs continue methotrexate hydroxychloroquine with maintenance therapy and she is recovering well now. She is improving. प्रोग्रेस मॉनिटर जो आपको मैंने बताया था नवंबर तक का दिखाया था, 16 से आप देख लीजिए, दिसंबर से ग्रेजुअली 19 तक, अब फिर हम लोग का भी 11 साल का जर्नी हो चुका है सर. 8,800 पे नीचे में है टोटल काउंट एंड ESR इज 28 एंड क्रिएटिनिन इज नॉर्मल एंड CRP इज नॉर्मल. ये 2019 पे हम लोग आ चुके हैं. 2019 का ये सब एक्सरे है. केम फॉर रूटीन चेकअप, थोड़ा फास्ट जा रहा हूं कि ऑलरेडी 10 मिनट में एक्सीड कर चुका हूं. अक्टूबर 2019 का ये है. नो विजन प्रॉब्लम, पेशेंट कंफर्टेबल बिकॉज बहुत लंबा हाइड्रोक्सीक्लोरोक्विन चला था. शी कैन डू ऑल हर एक्टिविटीज ऑन हाइड्रोक्सीक्लोरोक्विन 200 मिलीग्राम ट्वाइस डेली एट दैट टाइम. नो मेथोट्रेक्सेट. मैंने जो किया था वही मैं बता रहा हूं. एंड इसको मैं थोड़ा सुन लीजिए सर, ये 2 मिनट का ये है. Sound.
56.
Yes. When you started this problem of joint pain?
It started in 2007 and it became acute within no time.
How many months?
Maybe about 5 months.
Within 5 months the pain increased in all the joints?
Yes, doctor. Yeah.
And you had pain and swelling also?
Yes.
And whether you were able to do some of your work?
No. I was not able to walk. I could not do my even personal work.
You were bedridden almost?
Yeah.
With all those pains, swelling all around?
Yes.
In between, what type of treatment you took in 5 months?
I was taking some physiotherapy.
Physiotherapy?
Yeah.
Some medications? Allopathic medicine?
No. I did not do that time.
No allopathic medicine?
But I started in the month of June.
Okay.
Yeah.
Right.
Yeah.
Then what you did?
Afterwards, I was taking homeopathy medicine, but within a month again my pain increased and I was unable to do anything again. So I came here and I started my medication. And
how you felt after that?
After that, within 1 month I was able to walk.
And all your normal activities you resumed within?
No, maybe in the beginning I found difficult, but within 2 months.
This is the same thing what I have expressed.
Yes.
And what activity you do? You are a social worker. Basically, you are working for a missionary.
Yes. I am doing my teaching work.
Chalo. So now comes 2022, 2 years before. All well now. क्योंकि question अब last में आना है. Patient is happy on hydroxychloroquine 200 milligram once daily. Regular follow-up 6 monthly वो चला जा रहा है. बीच में अब now she is not leaving. Now the question arises, sir, इसको कब हम दवा बंद करने का सोच सकते हैं कि उसके आगे फिर हम आ जाते हैं. Should biological be repeated? क्या कि she is comfortable 200 milligram निहारिका?
No need of any biological.
Right. तो no need of further, जो कि बोला जाता है कि लाइफ लॉन्ग बायोलॉजिकल देना चाहिए, वहां पे मैं अपना प्रैक्टिकल बता रहा हूं. किताबों में अलग बात लिखी होती है कि हर 6 महीने में आपको रिटुक्समैब या जो भी बोला जाता है, लेकिन एक्चुअल क्या हो सकता है, दैट वी डिविएट, बट यू गेट गुड रिजल्ट. एंड दिस शी विजिटेड अभी 3 महीने पहले शायद, मोस्ट प्रोबेबली माय चैम्बर. परफेक्ट यही है ऑन हाइड्रोक्सीक्लोरोक्विन 200 मिलीग्राम वंस डेली. सर एक लास्ट क्वेश्चन, क्योंकि मैं थैंक यू पे आ चुका हूं. कैन वी कॉल इन टोटल रिमिशन? सर जो आप लोगों ने सुबह से बताया है सर, can we call?
A couple of things here regarding this hydroxychloroquine. It's been going on for a very long time.
Yes, sir. Yes, sir.
And the initial dosage also, looking at her, appears to be maybe slightly on higher side. So better don't give hydroxychloroquine more than 5 milligrams per kg body weight. So this appears to be 400 for her, appears to be slightly on higher side. And almost like more than 10 years of hydroxychloroquine means she might not have symptoms. Routine ophthalmic checkup might not pick up the true HCQ toxicity. A proper complete checkup with visual field testing and OCT needs to be done, and a thorough retina checkup needs to be done in that particular patients, and annually HCQ checkup if it is done much better, because she is more than 10 years. Second thing is, before telling whether the patient is in remission or not remission, one should understand the natural course of rheumatoid arthritis, because the rheumatoid arthritis doesn't behave similarly in every patient. So one patient has a monophasic course where they just come with severe symptoms, you give something treatment and they become all right, they might not have relapse at all. And some patients will have a polyphasic course. So it comes and stays in remission for a couple of years, 3 years, 4 years, 5 years, and some trigger happens, it might come back. and few of them have a progressive course. 30 to 40% will have, the disease keeps on progressing. So whatever you give, and they sometimes become refractory to therapy also. So rheumatoids, it doesn't mean that if it comes, the patient throughout the life, they'll keep on having. So this particular patient looks like a polyphasic course. So she's good on hydroxychloroquine, proper checkup with hydroxychloroquine, eye checkup you can continue, or you can change to some other drug like safer drug like a sir is an advocate of sulfasalazine or any other thing, and closely observe her. And I think because she has relapsed already twice in the past, so for this kind of patient it's better not to stop therapy, at least continue on something and keep a close watch on this patient.
Right, thank you very much. We wanted to close at 2, we are closing at 15 past 2. Sorry for extending it for 15 more minutes. लेकिन ये सब ऐसे पेशेंट हैं जो हमारी जिंदगी में आते हैं और बहुत कुछ हम लोग को सिखा के जाते हैं. Naturally, I have got a dear friend, Dr. Manish, with me. कि जब भी कुछ खराब हो जाता है तो फिर Manish is always there to help me out in Patna, not only for me, for all the doctors of Bihar. Niharika is there. लेकिन हम लोग को अपने हिसाब से we have to learn the basics only. We don't want to manage the advanced cases. Learn the basics, and what you should do, you should learn. What you should not do, क्या नहीं करना है, उसको सबसे पहले सीख लेना है. डॉक्टर कौशिक भुजानी ने बोला. So thank you, sir. We would like to conclude with these words. Finally, Aarcon 2024 is over. आप लोग lunch के लिए, I will invite everybody to the floor above. And thank you all the respected dignitaries and Dr. Bindyachal, Dr. Raj Kiran, Dr. Rajiv. उसके बाद हमारे लोकल फैकल्टी, बिकॉज निहारिका कल से तुम बैठी हुई हो इतने प्यार से, थैंक यू. एंड अभिषेक भी यहाँ पे है, हमारा फिजिशियन यहाँ पे, एंड डॉक्टर मनीष, नो वर्ड्स फॉर यू बिकॉज यू आर द पर्सन हु हैव मेड दिस आर्कॉन 2024 हैपन. एक भी कभी क्वेश्चन नहीं आया कि सर ऐसा क्यों हो रहा है, जो होता था यस सर आप कीजिए, मैं हूँ साथ में. Thank you, Manish. That's a big gesture that you have shown. And Ashish Jha, sir, as a father figure, I will just bow down in front of you, sir, because you have blessed us always. Nishikant, thank you. Ramit and everybody, I will say thank you. And let's join for lunch. जितने लोग हैं सब लोग आइए ऊपर से. उसके बाद प्लीज ट्रेड सेंटर में एक बार घूम लीजिएगा, इंपीरियल गार्डन में. We will be blessed if you are there. Thank you. Thank you.